Check, check, hey, check, mic check, one, two. Check, hey, hey, check, one, two, hey, check. पास है भी उनके पास है। हेलो हेलो कौन कर चेक चेक हे हे चेक चेक हे वन टू चेक ठीक है वो तो बढ़ जाएगा ठीक
test, check, check, test, check. Hey, hello, check, check, test.
Very good afternoon to all. I am Ashish Chinchole, Marketing Head in Primus Division of Lupin. It is my privilege to welcome all respected faculties and delegates in the first Upgradio program 2024 in the city of Pearls, Hyderabad. Upgradio is a fellow course of interventional cardiology which is organized in association with CRFTCT USA and FACT Foundation, which is supported by Lupin Limited. From Lupin, special thanks to Dr. A. Srinivas Kumar, Dr. Rishi Sethi, who have designed and crafted the entire program to upgrade us in the field of interventional cardiology. I would request Mr. Rohit Nair to please come on dais and share the Lupin corporate overview.
So, very good afternoon to all the doctors. I am Rohit Nair, taking care of cardiology, CNS, and Sri Lanka business for Lupin. And I welcome you all for this first of its kind program, which is Upgradio, which is in association with CRF TCT. This program cannot, start without thanking two of our main course coordinators, that is Dr. Rishi Sethi and Dr. A. Srinivas Kumar. And I really want to thank Dr. Rishi Sethi and Dr. Srinivas Kumar for collaborating this entire program and giving their time and making this program. So this is the first of the kind program, and every year we ensure that we will continue this program with much more academic feast. Just to give you a Lupin overview, Lupin was founded in 1968 by late Dr. Deshbandhu Gupta. Lupin today, if you see, we are the third largest in the US by prescriptions. Lupin is the sixth Indian pharma today in the market. We are eighth largest in South Africa. We are also, Lupin is fourth largest in Australia and also second largest in Philippines as far as branded generic prescription is concerned. We have 15 manufacturing sites, 7 R&D sites, 911 active patents, and 463 ANDAs filled with US FDA as on date till March 23. If you see the partnering track record, I think Lupin is the front runner in bringing all the innovative patented products in India. And these are few of the companies which has in-licensed with Lupin to market their products in India, whether it is Lilly, Boehringer Ingelheim, Novartis, and so on. If you see, these are the therapeutic areas in which today Lupin is present. The top 5 therapeutic areas is cardiology, anti-diabetes, respiratory, anti-infective, and GI, which contributes almost 76% of the total sale of Lupin in Indian pharma market. This is another arm which Lupin has started, which is another company which we have started that is known as Lupin Diagnostic. And we are more than happy to offer that we have served more than 3 lakhs patients. Already more than 1,000 collection centers have been installed till now with more than 50 labs all over India. And it is a company which is there for highly specialized services for clinicians, specialists, hospitals, and patients. And just to share with you that recently, Lupin Diagnostics has been awarded for the best pathology lab by ET Healthcare Awards. First time in India, I think Lupin has introduced a fully owned subsidiary, which is Lupin Digital Health. Lupin Digital Health has introduced Life, which is a program for remote cardiac rehabilitation for heart failure, CAD, and heart failure patients. Life program is designed by all the Indian cardiologists for Indian patients. Please experience the experience center of Lupin Digital Health, which is just outside this hall. I really want to thank all the doctors of Indian fraternity, and because of your support today, it has made Lupin the third largest as far as cardiology segment in India is concerned. These are the few brands which are one of the pillar brands as far as Indian cardiology market is concerned. And once again, I want to thank all the doctors who have made these brands a big brands. At Lupin, our priority is patient centricity. And these are the 2 programs which we have started. One is JEET, which is a program which is centered towards all the cardiology patients. And also we have Hamrahi, where we are partnering with all the diabetes patients. Both these programs are directed towards education, awareness, and adherence. And happy to share that in combining both these programs, we have enrolled more than 15,000 patients till now. Few of the accolades where, patients at center, whatever we do in Lupin, these are the few accolades which Lupin has got. And also Lupin has won the Indian Pharma Awards 2021 for Innovative Pharma Strategy for Excellence in Patient Care. With this, I once again thank you all for being here and making this program a successful one. Thank you all.
I thank you, Mr. Rohit Nair, for the insights on Lupin corporate overview. Now I request Mr. Rohit Nair to please felicitate our course coordinator, Dr. Rishi Sethi. Rishi Sethi, sir, please. Now I invite all the faculties of the program for lamp lighting ceremony. So please come on stage. And Mr. Rohit Mandro, sir, please come on stage.
विघ्नेश्वराय वरदाय सुरप्रियाय बोधाय सकलाय जगद्धिताय नागाय सुतियाय विभूषिताय गौरी सुताय गणनाय नमो नमस्ते विघ्नेश्वराय वरदाय सुरप्रियाय
Thank you very much, everyone. Now I hand over session to Dr. Vivek Kulapkar from Lupin Medical Team.
Thank you, Ashish. So once again, a very good afternoon to all of you from Lupin Cardiology team. And it's a privilege to host this meeting for today, which is the Upper Radio 2024. So without much ado, I would now kickstart the first session, which is the basics of angiography and PCI. So the chairperson for this session would be Dr. Rishi Sethi. So can we have the CV slide of Dr. Sethi, please? Yeah, so Dr. Rishi Sethi doesn't need any introduction. He is the professor, Department of Cardiology at King George Medical University, Lucknow. He's the associate director for CHIP CTO. He's a reviewer for Biotechnology Ignition Grant, BIRAC. He's the member subject expert committee for CDSCO. He has published several articles in national as well as international journals. He is the executive editor of journal Heart India since 2017. He is also the vice president of UP chapter CSI 2020, and he is there till date. So with this, now I would hand over the session to Dr. Rishi Sethi to kickstart the proceedings for today's session.
Thank you very much, Team Lupin, and thank you all of you for being with us today. Post-lunch sessions are challenging, but I hope you eat in light and you can take a bit of coffee and tea too. But I'm sure that the speakers will be deliberating on the topics with such finesse that our attention would be wrapped and on the subject. One is a lonely place to be on the stage, so may I please request Dr. Rajesh Vijayvargi and Dr. Shiv Kumar, sir, to please join me on stage and help me out in this task of, you know. So what we want is that since most of the attendees are DM students or freshly out of their DMs, we want the session to be a little more interactive. And of course, we'll be starting with the basics of interventional cardiology, about the hardware, about the angiograms. You all have been seeing cases of coronary and structural interventions in your cath labs being done by your consultants. And I'm sure all of you are experienced to some degree about angiographies and angioplasties for sure. But still, even at this stage, and correct me if I'm wrong, it's always nice to go back to the basics and learn about essential techniques of PCIs, essentials about hardwares, because sometimes when we are doing these things day in and day out, then probably we skip on the theoretical part of it, and it's always good to brush some dust of our clinical knowledge and try to understand things from the foundational steps itself. So in that context is the first session about the foundations of interventional cardiology, about basics of coronary angiography and hardwares of coronary angioplasties. And I would first call upon Dr. Rajesh Vijayvargi to take a talk on the art of optimal angiogram. Dr. Rajesh is an acclaimed interventional cardiologist. His expertise, and he is known to all of us as a really national, leading figure in intracoronary imaging of OCT and IVUS. We all have learned a lot from him, but now he has to take a step backwards. And from intracoronary imaging, he has to go back to the luminogram of coronary angiogram. And I love to hear what Dr. Rajesh has to say about the art of coronary angiogram, more than the skill.
Hey, good afternoon, everyone. Thanks, Dr. Sethi, for the kind introduction. And this is the topic of my talk regarding basic of angiography views and PCI. As you all know, this is the cath lab scenario where we do in a central cath lab with a monitor, defibrillator is on the side. And for the angiography in routine, we do have the patient for the fasting 6 hours, though it's not a routine to have no fasting, but then sometime an emergency situation can arise and then you are supposed to have an intubation and anesthesia backup. So it's always better to have a fasting state for the patient when being taken on the table. Those who do have a renal failure, where there is a concern about, say, contrast-induced nephropathy, to be taken first few cases, and later on the rest of the cases can be taken. Yes, the angiography has to be done under local anesthesia, but one can need a general anesthesia in case the situation do deteriorate, and therefore what's a precaution to be taken for general anesthesia should be there for each and every patient. What's the site of access is there for the angiography that has to be saved, disinfected, and sterile atmosphere should be there. And this is about the catheterization trolley. You do have the 3-way syringes and various essential things which is available with the long line. And this is about the transradial access. Can you give the mic, please? Is it okay now? So this is about the transradial access, and another one is transfemoral. You have to see the puncture site in transfemoral, the femoral. Is it audible now? Okay. So it's a transfemoral access. Under the fluoroscopy, one has to see the femoral head, and thereafter one can go ahead. Few people do go ahead with the ultrasound to look for the femoral artery site, and it should be about the bifurcation and the head. So then, following the intervention, you can very well have a good compression without having pseudoaneurysm or hematoma formation. After the access, yes, you have to push the catheter through the sheath. Most of the time, it's a 6F sheath over the wire, connected with the three-way. This is the contrast. Sometimes you do have a line across for the contrast, and selective cannulation of both the left and right coronary artery has to be done to look for any blockade and then to go ahead for the intervention. So regarding the views, this is RAO and the LAO view which has to be taken, and then again this is right and left, and then caudal and the cranial. These are the various views which has to be taken during the angiography, and these are the two important plane one should understand about atrioventricular and interventricular plane. The first diagram is of atrioventricular. Sorry, can I? So here you can see, can the marker is visible? Can you help me?
Go on to the next slide.
Marker, please. Okay, fine. So here you see, this is the right coronary artery. Basically, this is, one can say RAO view. This is the right coronary artery, which goes into atrioventricular groove, and same extent true for the left circumflex. Both the vessel do go into the atrioventricular groove, and then this is basically the iliocranial, where this is the LAD, which goes into the interventricular septum. The posterior part of interventricular septum is supplied by the PD branch, which can be from right coronary artery in, let's say, 85% of the cases, and 15% of the cases it's from the left circumflex, and therefore one to mention as the right dominant versus left dominant depending on the origin of the PD. And then we do come across various branches. This is the epicaudal view. The first one, you can very well appreciate the good left main over here. The proximal and the distal part of LCX is well visualized. And this is the OM, or obtuse marginal first, obtuse marginal second, and this is small vessel is the left circumflex. So the distal LCX is the one which do go into the interventricular group. And depending on the origin of the OM, one can very well divide. So LCX before the OM is the proximal LCX, distal to the OM is the distal LCX. In this particular view, you can very well appreciate the proximal LAD, and this is the epicranial view where the LAD proximal, or rather mid to distal LAD is well appreciated. Whenever there is the left dominant circulation, you can very well appreciate the PD over here. And this is the epicranial view where you can separate the two. Here are the diagonal, the bigger diagonal D1 and D2, and these are the various septals arising from the LAD. How to divide the LAD? So S1, the prominent S1, this is over here. So before the S1, the LAD is the proximal, and the D2, this is the D2. So proximal S1 to D2, the distance between the two is the mid LAD, and after the D2 origin, it's the distal area. So this is the way one has to have the differentiation, and you can very well appreciate in this particular view, you can very well visualize the mid LAD and distal LAD. So during the intervention, this is the view to go ahead for the intervention of this particular segment. And this is the iliocranial view where you can very well separate the LAD with the diagonal. This can be, and this is also the view which has to be seen during the left main ostial stenting. Another one is commonly known as a spider view. This is a LA caudal, where you can very well appreciate the proximal part of the LAD of the LCX and also the left main. There is some modification. This is the areocranial view, where you can very well appreciate the proximal LAD along with the mid to distal LAD and also the left main ostium. So this is the one view where when the intervention or stenting has to be done, you can go ahead for the left main ostium stenting and also proximal to distal LAD stenting. Lateral view for the left coronary system, most of the time it is not been done, but then this is a very good view to differentiate a big diagonal from the LAD. So LAD do come anteriorly substernal, while diagonal is going to come over here. Sometimes with the CTO, chronic total occlusion intervention, when you are not sure about your wire is in the LAD or the diagonal, this is the view which can very well confirm. In case the wire do come like this is the LAD, otherwise it's going to be the diagonal. So these are the various views for the left system. Now comes to the right coronary. So around 85% of the cases, right coronary is dominant. And then initially you do have the two branches, cornus branch and the SA nodal. In this particular case, SA nodal is quite small. This is the another one is the cornus branch. And then the proximal, mid and distal RC have been differentiated by proximal RCA is the ostium to the RV branch to acute marginal is the mid RCA, and acute marginal to the distal till the bifurcation is the distal RCA. And then comes the PD and the PLV. The this is the lower one is the PD, which go into the interventricular septum posteriorly, and PLV is the one which goes into the AV groove. So this is the way how to differentiate the various branches, and this is the way how to have a nomenclature of the proximal, mid and distal LED, PD and PLV during the time of intervention. Most of the time, the LEO is the good view to go ahead for the intervention. RAO view is the one where you can very well appreciate the mid RCA. Sometimes the CTO intervention, when there is the RV branch, you are not sure whether you are in the RCA or it's the RV or the acute marginal branch. And this is the RAO view, which is going to be helpful to have an idea about that, okay, you are in the RCA proper instead of the side branch. This is the lateral view, which can very well differentiate the mid RCA from their branches. And this is another view, which is of helpful during the PCI when there is a doubt about whether we are entering into the branch or the RCA proper. This is the AP cranial view, where you can very well differentiate the PD and PLV very nicely for the right coronary artery. Whenever one is going to go ahead for the bifurcation is stenting at the distal part of the RCA and PDPLV. This is the view which is helpful to differentiate, to have a good delineation of these two branches and have a successful intervention. So all this is about the various views which are helpful during the angiography. Something about the guide catheter which has to be used. You all know about what's the role of guide catheter. It's a vehicle for the contrast injection, measurement of the blood pressure across the aorta and the ostium of the right or the left coronary artery, conduit for the transfer of various wire and devices across, and support to give the advancement for the device exchange. A very important thing whenever you do go ahead for the catheterization, for the intervention, kindly take care of the blood pressure. Here is the ventriculization because you are not getting the proper transmission of catheter tip, and then possibly it's getting attached getting adjacent to the wall of the one of the coronary artery, and this is the damping which is one has to be very careful in case at this point or this point you have you have given the injection across the coronary. This is likely to have a dissection, ventricular tachycardia and cardiac arrest. This type of pressure damping can be there in those with the small vessel and the large guide catheter, ostial spasm, selective engagement of the seconus branch, which around 20 to 25% of the cases, there can be two separate origin of the RCA proper and the conus branch, and then injection to the conus branch can lead to the damping and also the ventricular tachycardia. Sometimes the ostial stenosis of the RCA of the left main also cause the damping, and at that moment of time, one has to be careful in cannulation and to go ahead for the intervention. Catheter wise, you do have a 3-layer catheter for the guide catheter for the PCI. Outer one is polyurethane or polyethylene, and the middle one is the steel, stainless steel, which is kink resistant, and the inner one is PTFE, which is smooth thrombus resistance catheter. Most of the time, the catheter has the length of 100 to 110 centimeter. They have a primary, secondary, and tertiary curve. Left Judkins do have a primary curve over here at the tip, and this is the secondary curve. And for the Judkins right, you do have an additional curve in the shaft. That's the tertiary one. Whether it's a 6F, 5F, or what sort of size is there, it's the outer diameter of the catheter. And the inner diameter is important during the intervention. And if you see for the 5 to 7F guide catheter, it's the Medtronic guide catheter, which do have a maximum lumen compared to other catheter. And it's going to be easy for the interventionist to go ahead for different bulkier device or two balloon when one is using the Medtronic compared to other guide catheter. There is a difference between the diagnostic versus guide. There are 2 layers for the diagnosis versus 3 for the guide catheter. Selection of the guide catheter during the PCI. Most of the time, it's the 6F is to help in crossing various devices. But whenever you do have a kissing balloon inflation or the rotabar, which is 1.75, there may be the need for the 7F guide, and the 8F guide is very much restricted to those with a trifurcation region where the 3 balloon has to be used for the kissing inflation. A smaller size of guide catheter, yes, less of the bleeding, less of the contrast. Those with the contrast induced nephropathy, it's helpful, while the bigger size is helpful for the good support and exchange of the various bulkier device during the intervention. Then which guide to be used during the PCI depend on ascending aorta dimension. You do have the narrow, which is less than 3.5, ascending aorta 3.5 to 4 is the normal one, which we routinely come across, and the dilated ascending aorta is the more than 4 centimeter in the dimension. So this is the way to have the aortic dimension, and depending on this dimension, one has to choose the guide catheter, which cannot be the same one for each and every side of the aorta. And then there is a concern about the coronary ostium location and their takeoff. So coronary ostial location can be superior, inferior, anterior, or posterior, and similarly, the takeoff of the coronary can be different. This is about the left and right coronary artery, which do have a horizontal upper and lower takeoff for both the RCA and the left coronary artery, which is well depicted in this particular picture. This particular case had a left coronary artery originating from the posterior side. Difficult to have nasal cannulation with a routine catheter, and it's ultimately the multi-purpose catheter which was used for the index case. Ultimately, with the CT scan, we could very well demonstrate the posterior sinus origin of this artery, and it's a EBU guide which was helpful for the PCI. And this particular case was published in the Indian Heart Journal. And regarding the backup support, it's very important to have a good backup support in those with the complex, tough lesion, those with the CTO, and it depends on the catheter size. 7F or 8F guide is going to be the good support, good backup support compared to 6F or the 5F size. And this particular angle, you can appreciate over a angle which is around 90 degree between this vertical line versus the aorta is the versus the catheter is the one. In case it's around 90, this is going to the good support compared to those with the more angle. And other thing is the contact area. A contact you to have a support from the opposite wall of the aorta, from the sinuses and from the aortic arch. And then it's very important. This is very important thing that you have to have a coaxial alignment whenever you do cannulate the coronary. Otherwise, there is a risk to have dissection and complication during the percutaneous intervention. Regarding the backup support, it can be passive. Passive means the guide catheter itself is going to give the support, whether it's a 7F or MPLARS or EBU guide, versus active support is the one where you do have a manipulation of the routine guide catheter to have a good support across. And this particular case where the distal RCA was diseased and along with the bypass graft, you see the multipurpose catheter has come up to this point from the aorta to give the good support. So this is about the active support of the guide catheter, and we had a successful stenting of the distal RCA via the saphenous vein graft. And this is about the passive support. It's a AL1 guide. You see the mid RCA, which is markedly calcified or not able to push the balloon and various devices. So at this point, we have taken the guide liner at this point, and then successfully stenting could be done across this calcified right coronary artery with the passive support of the AL1 and with the help of the guide liner. Various type of guide catheters, some brief thing about you have a GL varying from 3 to 5, and it all depend on the length between the primary curve and the secondary curve. So it's a 3, 4, and 5 centimeter is the length. And this type of say with the bigger size, in case the aorta is dilated, it's a bigger size of the Judkins left, which is helpful for the cannulation of the left coronary artery. MPLARS again 0.75 to 2 or 3 MPLARS guide catheter. It's again the distance between the primary and the secondary curve in centimeter, which is going to nomenclature. These various catheters again is with the aortic dilatation. One has to choose the bigger one. It's very important for fellows to learn about AL to have a risk of coronary artery dissection. It has to be gently cannulated for the left coronary artery, and it's very important that during the removal, you have to push it so it gets prolapse in the aortic sinus, rotate it to decannulate the left coronary, and then remove it. Or otherwise, when you are doing the PCI, you can put a balloon over here, and over the balloon and the wire, you have to pull it out, and then otherwise there is a risk to have a dissection of the left main coronary artery. So you do an AR guide. It is again depending on the AR 1 to 3, depending on the aortic root size. Larger the size, you have to do AR 2 or AR 3. Most commonly, it's a AL1, which is used for the right coronary artery in the complex lesion, but then AR is another guide which can be of use. EBU guide catheter commonly used for the left coronary system. Depending on the curve of the secondary curve length, it can be defined as 2.5 to 4. And as per the aortic dilatation, the bigger size of EBU guide has to be used for the complex left coronary PCI. This is the Shepherd Cook, where the SCR guide from the Medtronic was used to have the PCI of the proximal RCA. And this is the high takeoff where the AL1 was used for the PCI. This particular case has now very high origin of the right coronary artery from the aortic ascending aorta, and it's around 3 centimeter above the sinotubular junction. Initially, there was some difficulty where the RCA is to localize the RCA. CT scan could confirm the origin from the ascending aorta, and then it's the AL1 guide which was used to have a successful OCT guided PCI. Got published in one of the European Heart Journal. And something about the dextrocardia. This is the case where you have to have an orientation. RA view look like the LAO and the vice versa. So this is the proximal RCA, which is 100% cut off with the acute MI, and successful PCI was done, published in one of the World Journal of Cardiology. And this is the another horizontal sweep reverse method. Each and every cath lab do have this modality. So you have to just flip the just flip the machine orientation from the outside, and then you have now rotation of this image. So epicranial and caudal will remain the same. RAO, LO will become the reverse. So if you see this particular image is basically the spider view. For the conventional normal angiogram, it's going to be the LAO caudal. But this is the RAO caudal in the dextrocardia patient. This is LAO cranial, but then in conventional normal angiogram, it's going to be the RAO cranial, and this is LAO for the normal RCA is turned out to be RAO. So you have to just reverse the image to have an idea about, and this particular study of around five patient experience we could publish in the ACI intervention. So take home message, choose the angiographic view for optimal profile of lesion prior to PCI and at the time of PCI as well. Mind that any extreme caudal or cranial view do have a more scattered radiation. So avoid this type of view more frequently and for prolonged duration during the PCI. And during the PCI, of course, an appropriate size and safe guide catheter is important. Once you choose a guide catheter, went ahead with the intervention, a complication in between like the dissection, you cannot change the guide catheter. So try to choose the appropriate guide catheter at the time when you are going to start the intervention, and then proceed accordingly. Thanks for the kind attention.
Thank you so much, Dr. Rajesh. I mean, if you may, just to, we can take one or two questions from the audience if you have, for the sake of time. And before the students make up their mind, is there any specific indication where you will electively go for a femoral approach in your practice nowadays?
It depend upon how you are trained. Most of my PCI initially was around 85% was transradial, which now is 95%. There is a concern about 6FC for the transradial and 7F with the transfemoral, but now with the 7F, 6F thermoseed, and you can very well place the 7F guide. One can go ahead with the transradial as well. Sometime when you feel like it's a CTO lesion and then you are supposed to have a good backup support, I would say transfemoral is going to have more backup support compared to transradial. So whenever you feel like that, okay, this is the case where you do need to have a good support, and there is possibility that you are not going to get the good support via the transradial, that's the time one can shift to the transfemoral asset. But then most of the time, it's a transradial, even with the 7F, one can go out for the PCI.
And for Lima interventions, what is your approach in terms of your access and your choice of guide?
For the Lima intervention, there is a concern about, say, length of the guide. So sometime you have to have a cutting of the guide catheter, and then to go ahead for this thing, either you can go from the left radial to a short distance and can very well go ahead for the intervention. For the Lima, it's one important point which has to be looked into is that you can very well place an additional wire across the subclavian artery, so you are not going to dissect the ostium of the Lima. Sometimes these are very tortuous and long, and then there is always a concern about whether your devices will be able to reach to the anastomotic side of the Lima to LAD or the distal LAD. At that moment, you have to modify the thing. I had tried few patients with the renal guide, which is of a smaller length. You go via the left radial, place it at the ostium of the Lima, and then proceed. And then because the shorter length of the renal guide, you can go ahead with various devices extending up to the distal part of the LAD.
Sure. Any questions from the audience? So I suggest you all keep on, your mind should be clicking very fast as the speakers are speaking. Yes, please go ahead. Good. Take the mic. Take the mic. Take the mic, please.
When we fail in radial approach, sir, access, you directly go to femoral or you try ulnar, sir?
See, previously, people used to do that particular test, Allen test.
Allen's test.
Allen test to look for patency and good flow across. But when you fail across the radial, it's preferable to go the alternative side, whether it's a left radial or femoral instead of trying for the ulnar. In case there is any complication with the ulnar as well, you are going to have an ischemia of the head, which is troublesome for both the patient and also for the physician.
Sir,
So
another-
what sir is saying is absolutely clear. If you have failed the radial, do not try an ulnar in the same hand, because then you have the chance of compromising the entire, palmar circulation. So either you go a left radial or you go femoral. That is your choice. But do not attempt the radial in the same arm.
Sir, another one question, sir. What we feel, many textbooks nowadays writing that machine injectable contrast. Machine will inject the contrast, you will program it. And we do generally manual contrast injection during angiography. So what is your view on machine, use of machine for contrast injection rather than manually injecting?
I mean, automated injections are definitely things that are used in many of the Western worlds. I'm not sure whether Indian labs are doing it or not, but it's more about your lab setup and your technician setting it up in a right way. There's no right or wrong here. The
Sir,
machine-based injections.
Many observational studies show that automated settings require less contrast for equivalent results.
Yeah, so automatic pressure injectors for coronary arteries are equally good and sometimes better in terms when you are doing OCT procedures and things like that. But for the lack of adequate technicians and the setting up of the whole equipment, many of the Indian labs are not doing it. That's what my assessment is.
Thank you, sir.
I would also like to add over here with the machine injection, you have fixed the amount of dye. With the experience, you have an idea about when to give the extra amount of dye during the diagnostic angiogram or during the PCA, and when to give the lower amount. And this can be manually modified depending on the visualization. And therefore, the manual is going to be better. Sometimes you have the damping, and in case you are given the good amount of contrast across, there is going to be a dissection. So this is the way, most of the time, what I personally feel, you go with a small amount, less of force. So initially, look, everything is okay. And in case the thing is not getting visualized, you can give more force and more amount of contrast, both during the diagnostic and also during the intervention.
Yeah. Thank you. Thank you. It's been so I would request more and more audience to the students to ask questions, whatever comes to your mind. We are going a little off the agenda, but we are inviting Dr. Jayesh Prajapati. He has a flight to catch, so he'll be taking a talk on newer balloons and DEBs. Dr. Jayesh is a senior professor, interventional cardiologist of acclaim from UN Mehta in Ahmedabad, a good friend, and I'm eager to hear him about.
Thank you, Dr. Rishi Shetty, for my kind introduction, and good afternoon to chairperson and all dear friends. And thanks to Lupin for organizing this symposia, and of course the TCT India, Srinivas Kumar and Rishi Shetty for inviting me. So today I'm going to talk in I think 15-20 minutes time regarding the newer balloons and drug-eluting balloon. As per, I'll focus on that. So we know the conventional coronary balloons that are the main regular balloon, what we are using it, the compliant balloon and semi-compliant. So we use semi-compliant balloon for the pre-dilatation, most of the cases, non-compliant balloon for the post-dilatation, means post-stenting optimization. And of course, then some of the special modified balloon that what we are using are the scoring balloon like angiosculpt and that kind of balloon. While the cutting balloon that has been now to modify the calcium, that is what we are using it. Another high pressure balloon, that is OP and NC, they can go up to 30-50 atmosphere pressure, and they can, particularly for the calcific lesions, these are the one of the useful balloon. They are a non-compliant balloon, but it doesn't expand much. And of course, these are the good balloon for sometime once you have implanted a stent, we are not able to dilate with regular NC balloon, then these are the ones balloon, these are useful. And of course, we know the IVL also, which has nowadays is a very, very good tool where we are not able to crack the calcium after even after rotablation or something like the focal calcium and all. So IABP and I don't want to touch upon. So today I'm basically going to discuss mainly on the drug-eluting balloon. So this is already I have discussed. So we know that after we want invention of these stents, nowadays DES is to be considered the gold standard newer generations, but we are searching for nowadays we are facing the problem with the DES also, because DES carries a late catch-up. Every year 2% to 3% of the patient then late catch-up means 3 years, 5 years. Down the time they come with a new atherosclerosis. And DES failure nowadays is a non-thing. So how many layer we implant? So we are trying nowadays, world is trying to make a metal-free coronary or metal-free vessel. So we have tried with the absorb and all biodegradable stents and all, but somehow, unfortunately, there are some problems, late thrombosis and all these things. So then the nowadays, since last, I think 5 to 7 years, mainly we are focusing on drug-eluting balloon. And sometime also we are thinking that indication are expanding. So this is basically has been introduced, particularly leaving nothing behind. So that is one of the important, how many metal layer we can implant. Sometimes one restenosis, suppose bare metal restenosis there, we have implanted DES. And then what next? 2 layer, after 2 layer, it is not better not to put any more layer into the coronary. So DEB concept was born in 2000. And which are the two drugs? We are using mainly two drugs, Limus drug and Taxol drug. So Paclitaxel nowadays in coronary stent is out. But of course, the drug-eluting balloon, when we see the literature, the Paclitaxel is people say that Paclitaxel is a drug which required for the drug-eluting balloon, because this is a lipophilic drug and this drug fits for the drug-eluting balloon. So data says that the Paclitaxel is a mostly classic, but when you use a sirolimus as a drug-eluting balloon, then we have to think twice, because it's not a class effect. Because sirolimus drug is a water soluble, not a lipid soluble, so doesn't transfer. Why when we coat any balloon with a drugs, that drugs should transfer to the vessel wall. That is important. So transfer should be fast. When inflate a balloon, we have got a limit time. We can keep it to 45 seconds or 1 minute or something like that. So transfer time should be less, and the drug should be maintained into that vessel. It should not wash out into the circulation. So drugs should stay into that cell. So that is important thing, and we should find a drug. So there are so many animal study has been done, and then the drug-eluting balloon were evaluated. And of course, the safety, we know the sirolimus is a relatively safe drug compared to Taxol. That's why most of the stents are the limus coated stents. So this is important technology. So DEB, one thing when we do a DEB, drug-eluting balloon, and how to implant that I'll discuss later. But important advantage, we are leaving nothing behind. Another thing is thrombosis rate is low. Once we put a drug-eluting balloon, we have to keep in contact. Each company gives the idea 45 seconds to 1 minute. And once you open a drug-eluting balloon, once it should be in the circulation, you have to be sure that balloon should go to that site. So lesion preparation is a must. So transfer time within 2 minutes. Some say that 2 minutes is the time you should finish your you should reach to that target area. And 2 mm at both the edges, it should be covered. So you have to, and 1:1 ratio is a must. So that's something. And once you are open, suppose you have not crossed the lesion and then you are coming back, never put that balloon again, because your drug has lost. So that is one of the important things while using a drug-eluting balloon. Previously, older balloons where got a profile was bad, but the newer balloons, they have got a good crossability profile. So these are some of the commercially available drug-eluting balloon. Among the Paclitaxel, some are nowadays, I think, FDA approved is the Boston Scientific and Medtronic. These are the available balloon. And of course, the oldest balloon was the sequent please B. Brown. B. Brown was the first company that has launched the Paclitaxel, most of the data with the sequent please balloon. And nowadays, sirolimus eluting balloons are available. Among them, the good study available is the sequent please SCB balloon, and that is a crystalline sirolimus. And this balloon has shown that drug remain inside the coronary up to 30 days. So that is one of the important thing. And some of the one or two Indian company, that is Magic Touch. But data, we have to see more data needed in that balloon because the last study has failed in non-inferiority compared with the Paclitaxel balloon. So that we have to keep in mind with the sirolimus. So sirolimus eluting balloon, it is not a class effect. We require more data. So which are the various indication where we should use a DEB? Because DEB nowadays indications are expanding. One important thing is that
whenever you implant a DEB, always we have to accept angiographic result should be acceptable. So at least we have to dilate to 1:1 ratio. So preparation of the bed should be very well. Suppose it's a calcific lesion, you have to burr it, rotabur, then do a balloon dye with a semi-compliant, non-compliant. Prepare the lesion very well. Some say FFR of 0.9 is up, but data say up to 0.8 FFR, less than 0.8 FFR is there. Then more than 0.8 FFR, you can implant a drug-eluting balloon. So we have to prepare the lesion very well. In case of ISR, it is better to go do a imaging and then to decide whether to go for DEB or something like that. And if there is suboptimal result, we have to see for the TIMI flow and we have to see the dissection. Up to 1, 2, you can, up to, some say up to 3, but 1 to 2 grade dissection, you can put a DEB. And suppose flow is compromised and dissection is major, you have to implant a drug-eluting stent or whatsoever stent you want. So one indication where it is, this is a class 1 recommendation level of evidence A is an instant restenosis. There are data available with BMS instant restenosis. There were data initially with the drug-eluting balloon and plain balloon. Of course, the drug-eluting balloon is better compared to the plain balloon angioplasty. And with bare metal restenosis, I always and most of the people prefer that DES is the first choice. So first time. But if the second layer is then it is always better to go with a drug-eluting balloon. And some people even advocate that even the first time drug-eluting stent restenosis, why to implant a second stent? We can give a try of a drug-eluting balloon, so we can in the future we can get an option of second drug-eluting stent implantation the same lesion. So class 1 recommendation is ISR. These are some of the data, some of the studies, and some of the data and meta-analysis. I don't want to go into detail of that, BMS versus DES, but all this restenosis, it is nowadays better to do imaging because the BMS and DES restenosis is a different thing. And these are some of the meta-analysis they carried out and conclusion what I have told. Another expanding indication is the small vessel disease. Small vessel disease nowadays, we are doing so many multivessel angioplasties. So small vessel disease, vessel less than 2.75, some say up to 3 remaining a challenging. But of course, world is divided. We have seen that even the DES technology, even up to 2.5, 2.75 or 3 DES are of course a good choice, but people are moving in their small vessel. Even the small vessel data are available with a drug-eluting balloon, particularly paclitaxel-eluting balloon. And it has shown that 3-year long-term data is available. And of course, this is also one of the good alternative in a small vessel, particularly side branches and all. So small vessel, these are the studies, particularly basket small 2 trial. And this has shown that these are good data with this one. Another now one thing is newer thing is the larger vessels. People now started using the DEB in larger vessel. We know that in a larger vessel, 3.5, 4 mm, 3.25 mm, people have tried the DEB and they have shown that large vessel, they have shown that even some of the dissection we can leave it and we leave no metal. So there are the small data available with a larger vessel also. Suppose long lesion is there, then larger vessel people have tried using this drug-eluting balloon also. Another most important thing is a bifurcation. We know that the European Bifurcation Club recommendation is always we know the provisional stenting. So what to do for side branch? So they say that main vessel drug-eluting stent, side branch, you can finish with a kissing balloon with a drug-eluting balloon, or prepare the side branch very well and finish with a drug-eluting balloon. So this is the one thing where the drug-eluting balloon has got a good role. Second thing is that suppose you have got a bifurcation, you have implanted DES and DES restenosis, then what to do? Then some say that rather than implanting a second DES into same site, you can compromise the side branch. That is always a worry because 2 metal layers are there. So they said in care, why not 2 DEB, main vessel and side branch? So this is also one of the concept which is going on. So side branch DEB versus both the DEB, that also one of the things to be considered, particularly for the bifurcation lesion. So that thing is also going on. Another thing is particularly country like India, where the diabetic population is more. And diabetic patient, they have got a small vessel, diffuse disease, multiple stenosis, and the diameter mismatch is there. Some say that to put a drug-eluting stent, longer stent, there will be a drug delivery will be not the same. Rather than you put a drug-eluting balloon, then probably the lower the restenosis rate, and then later on you can give a chance for a DES. So for the diabetic patient, the small vessel, you prepare the lesion very well, and in that small vessel, long lesion, you can try a drug-eluting balloon. This is one of the indication, expanding indication for the drug-eluting balloon. Another important thing is high bleeding risk group of patients. DEB, they recommended that DAPT to be given up to 4 weeks is enough in selected cases. After then, suppose patient have got atrial fibrillation, they are requiring NOAC or something like that. So you can give single antiplatelet plus NOAC or something like that. Or the patient suppose requiring a surgery in near future. Then if you want to give a shorter term DAPT, then this is one of the good thing. Even they have given a single antiplatelet and they did a DEB, the thrombosis rate is they say 0.2 to 5%. So lower thrombosis risk with DEB. So DEB carries the lower thrombosis risk. So patient with a high bleeding risk requires urgent surgery. So that group of patient data is there. Then this group of patient, probably the DEB is one of the good choice. Another people have now started using drug-eluting balloon, even ACS situation. Of course, this area is very tricky, little controversial, because the ACS carries a thrombus, and the vessel diameter, we cannot exactly judge what is the vessel diameter. Another, thrombus is a barrier. And third thing is a flow. So even though they have tried in the non-ST elevation MI, drug-eluting balloon, STEMI, they cleared the thrombus, and they leave the patient once the flow has been established and defer DEB. Or if the patient got a no flow, something like that, then optional stent. So even the ACS situation, people are trying. So this is one of the expanding indication, and some more data is needed, but small data around 100, 200 patients for the efficacy and safety. People have tried and they are not gone situation. So thrombotic ACS situation also, the probably DEB will be the option in the future. So these are some of the small studies which are available in ACS situation, non-ST elevation MI, ST elevation MI, deferred stenting, or deferred DEB or DES as an option. So we know that these are the slides showing the advantage and disadvantage of DEB. As I was told, one important thing is that lower DAPT, less implant. So this is one of the biggest advantage. And disadvantage is that sometimes flow limiting dissection, there you have to implant a stent. So DEB should be tried first in most of the situation. So when we see that, to finalize my talk, so paclitaxel eluting balloons are nowadays one of the most investigated balloon. And of course, when you use a DEB, we have to implant it properly. So lesion preparation is a must while you use a DEB, and we have to take care that balloon should be delivered. Sometime what happened? We are going to use a 40 mm balloon. Then sometime it is better to check with another long balloon whether we can pass that balloon to that lesion site. Otherwise, that drug-eluting balloon will be wasted. So that we think we should keep in mind. And indication, class 1 indication is the ISR, particularly DES ISR. Another indication is a bifurcation, followed by small vessel. And expanding indications are the diabetic patients, and of course, long vessel and ACS situation. I can say it is early to say whether the DEB should be used or not. Thank you so much.
Thank you, Dr. Jayesh, for a very comprehensive review of drug-eluting balloons, or drug-coated balloons as they are called nowadays. First, a comment, I mean, for the younger audience that are here, that over the years we have started to, use the terms angioplasty with stenting as, completely inseparable. The first conceptual change that your generation of interventional cardiologists have to bring in mind, be it acute coronary syndrome when you are doing primary PCI in an ectatic vessel, or be it a small vessel or a bifurcation disease, stenting is one of the components of angioplasty done for a specific reason. So you should not really have, you should not use the term PCI and stenting as synonyms. And that goes on for the data that the initial data, POBA in a chronic setting, chronic CAD setting, POBA is not such a bad thing. There's data from Antonio Colombo's group way back in 1997 that says that even non-flow limiting dissections caused by POBA, plain balloon angioplasty, non-flow limiting dissections, the restenosis rates were lower than bare metal stents. So POBA was performing better than bare metal stents way back, and it has been documented. So in various conditions where putting in a stent may cause more problems than solutions, for example, small vessels, heavy metal bifurcations, long diffuse diseases, and things like that, I think drug-coated balloons have definitely got a role. As far as the paclitaxel and sirolimus debate, of course, the initially paclitaxel was lipophilic and smaller molecules, but nowadays with advanced technologies and crystallized forms and phospholipids incorporations, probably sirolimus is a much more potent drug. So maybe the results may. So what are your takes on paclitaxel versus sirolimus if given a choice?
Yeah, one controversy was, I think some meta-analysis or some data has been published that paclitaxel-eluting balloon in peripheral, they have increased somehow the mortality.
Yes.
They say that distal embolization of the paclitaxel is a more toxic drug. But what the literature for the coronary says that it's a less amount and not really it's so. Even the peripheral also, that data, some say that it's a wrong analysis, something like that. But still controversy with paclitaxel is there. But the sirolimus, if some, I think Sequent is a good balloon and they've got a good technology, crystalline form. You are rightly told. That's probably that technology will refine and we can transfer the sirolimus in a proper manner. So we'll stay and transfer time. Both things is said, then probably sirolimus will be a future. Like the stent, initially paclitaxel, then limus has taken over paclitaxel in stents.
Yeah, that was a very important registry that you raised. I mean, there were some concerns about increased mortality with the use of drug-coated balloons in peripheral vessels, most especially paclitaxel balloons. But later on, counter studies said that these patients were inherently very sicker patients, so it cannot be attributed to paclitaxel. But there was this controversy. Any comments from our or any questions from the audience, sir? Yeah.
Very rightly said, Dr. Sethi. The most important thing is Dr. Shah sir said, the toxic dose is 100 and what we are using is 2 to 3.5. So I think that what is there is peripheral may not be true in the coronary. Nanotechnology is coming, so I don't feel there is a much difference. The most important point, which already Dr. Jayesh told, I want to reiterate, is many reports which I see come from the peripheral centers, 2.5 artery, ballooning done with the 2O, and then drug-eluting balloon with the 2.5. That is absolutely wrong. 1:1 ballooning has to be done. And I had a great chance to co-chair the session with Dr. Antonio Colombo last year, CSI. He does the diffuse diseases, and in up to 3 mm artery, he does all the ballooning. And until unless there is a big dissection, he don't put a stent. And even he said dissections are not bad. Even type A and type B dissections are good because it put a little crack and it allows drug delivery to go into the deep. So type A, type B is good. Type C, depending on your experience, but beyond type C, definitely it requires stenting.
I'll just take a minute to extend this conversation because it's also a very important point. Way back like 10, 15 years ago, when I was training myself, when we were using paclitaxel balloons, they always used to fail in instant stenosis. Now I realized that they were not failing because of the technology. They were failing because we were not preparing the bed adequately. We were just in instant restenosis. We'll do a half-hearted dilatation and then then think that just the regulating balloon will work. Preparing the bed and preparing the lesion with the most aggressive manner short of causing perforation and grade 3 dissection should be the technique before you use any drug-coated balloon for two reasons. One, as Dr. Jayesh said, that if you are not able to cross the balloon and you take it back, that balloon is wasted. Another important reason is that after you have done the balloon, nothing further should be done. So you can't post-dilate lesions after you have put a drug-coated balloon. So that should be the final step before you take everything out of the system.
After this, don't take multiple shoots, because if you take multiple shoots to just check, because that we are insecure about the dissections. So taking 4 or 5 shoots, I think more drug will flow with that. So minimum shoot after the drug-eluting balloon, maybe 1 shoot that show that there is no big dissection is good enough.
Yeah.
Very valid point.
The
I think
last comment was good.
Yeah.
So that was the main. Initially, we have tried 7, 8 years back. So with that particular Sequent balloon, we have just half-heartedly did it. Just put a balloon. We don't know proper technique. And lesion preparation is a must. That is important. Thank you.
I think Dr. Jayesh has to leave so we can have his felicitation before we take the next talk, please.
So may I invite Mr. Pradeep Dubey to please felicitate Dr. Prajapati.
Thank you, Dr. Jayesh, for this talk and for being here. Have a safe flight back home. It's really a pleasure to invite next speaker, my senior and my dear senior friend, I can say, if I may take the liberty. So, Dr. J. Shiv Kumar, a senior interventional cardiologist from the chairman of the interventional cardiology at Apollo Hospitals here at Hyderabad. He'll be speaking about the guide wires. Dr. Shiv Kumar is a graduate from my institute, the Department of Cardiology at King George's Medical University, a very acclaimed interventional cardiologist. And right now, his area of interest are also diversifying into the use of advanced computing and artificial intelligence in the use of cardiovascular field. And he has been working on developing a new cardiovascular risk score, which is linked to the artificial intelligence, the AI-CVD risk scoring system. I heard it just got published at BMJ. So congratulations for that, sir.
Thank you, Rishi. It's really again a pleasure to be here. And I see a lot of my friends, and of course, my Dr. Shastri was my senior, and then he was my teacher in Nizams, actually. Okay. I know you're all, before I really start, I would like to know that all of you are DM final year, second year, post DM. What is the status? Sorry? Final, most of them final year students? Okay, good.
Can we request the students that are sitting there in the corner to please come up here? You will learn more and the speakers will feel nice. I think we can shift some of the students that are right there at this corner. Yeah, I mean, we can remove the faculty, they themselves are. Guys, would you like to move up a bit, please? Ladies sitting in this corner, would you like to come here?
Okay, it's okay. Fine.
Yeah.
Anyway, settle down wherever you are. It's fine. Okay. How many of you are going into the cath labs? Okay, so not you guys. Oh, why are you hesitant then? Okay, fine. It's not an exam here, right? Okay. Okay, so I've been asked to talk on guide wires, and I can say one thing is that unfortunately the topic of guide wire is not interesting, is not exciting the way you can see the angiograms and angioplasties and other things. But one thing I can say is that if you want to be a good cardiologist, good intervention cardiologist, I'm not saying successful, unsuccessful, famous, non-famous, and all those things I'm not saying, but I really feel that if you want to be a good intervention cardiologist, you have to pay attention for the next 20 minutes. Please go through that. Okay. I'm saying that with confidence that today, many of the cardiologists, I'm not criticizing, but I'm telling you, many cardiologists are performing complex angioplasties without much understanding of the construct of the wire or what exactly is how the wires are handled. So this is why I would say that, please pay a little attention on to this, and subsequently also. And I was told that even in Hyderabad and in Delhi, or probably in some institutes now, during your exit exam, people are shifting. A few of my colleagues are shifting towards your grand wire on only to the catheters and wires and balloons. So coming to the point is that, okay, so this is, okay. So basically that's what it is, what is the structure and how do the wires behave? And this is what happens basically if you're a lone operator in your lab, then you're in trouble. And that's the time all these things will help you. So basically, I'm talking about the angioplasty guide wires, because the guide wire can be anything. Even for the catheter, you can have a guide wire, and for so many other things, right? So restricting myself to the angioplasty, coronary angioplasty guide wires is basically what are the functions. These are the four functions: track through the vessel, access the lesion, cross the lesion, and provide support. What do you mean? I'll go through those things a little again after this. So before I explain, there are few terminologies which you should be aware of it and you should understand what exactly they mean. Okay. The first thing is the torqueability. What is the torque control? So to describe torque control is the amount of rotation is given at the proximal end of the wire and the amount of rotation which happens at the distal part of the wire, that is the tip of the wire, is called a torque control. So this is the torque, because how much rotation you're giving at the proximal part and how much it is twisting, this is called as a torque. So you must know what would be the torque, because if the torque is not there, then you don't have any control on your wire because it will go whatever way it wants. The second is the trackability. Okay, trackability is again, what trackability means is that the body of the wire should follow the tip. Okay, so wherever that, if the body is not following the tip, that means if it is buckling, if it is kinking, if it is not going through that, it is not taking the curvature of the arteries or the tortuosities of the arteries, that means the wire is not trackable. Okay, because trackability is again a character of the wire, which is again determined by the construct and by the design of the wires itself. So this is again a trackability. Steerability. What is the steerability of the wire? Steerability means this is what happens, that you should decide. And another thing I would say is that most of you want to really become, it's a standard that every cardiologist who is coming out has to be an intervention cardiologist by default. And the moment they come to, because I have trained a lot of post-DM fellows in my lab in the last 20, 30 years, and everyone wants to do an angioplasty on his first day. Okay, that's very good. Enthusiasm is nice. But I would say that before you really start going on angioplasty, don't jump into the cath lab and then ask, oh, which lesion I have to do, what is it I have to do? Please don't do those type of things. Don't build that character. Okay, spend at least 5 to 10 minutes in console room, study the anatomy of the lesion, what is your strategy, what you want to do, think that and then go inside. Please directly, until it is an acute MI, that's a different story, but otherwise, if it is a primary, think, don't just jump and you're not doing plumbing there, okay? So please think about it. And then, so steerability of the wire is, you should know where you want to position your wire at the end of it. Okay, fine, it has crossed the lesion, will you leave it there? Or you want to go into the branch, or where exactly? So steerability is where exactly you want to park your wire. The flexibility of the wire. The flexibility of the wire, it is an ability to bend the wire. So by pressure, okay, by whenever you're taking it into tortuous things, and whenever you want to give a little turn, by pressure, it flexes. That's called the flexibility of the wire. Quickly, I'll go on these 4 points because they are important. Okay, one is a prolapse tendency. What is a prolapse tendency? That means the tip and the body. It's like a tractor in the trolley. Okay, the tractor goes somewhere and the trolley is not following it. So that's what it is, a prolapse actually. So both are not aligned, and this is a property of a wire. Okay, prolapse is not a default; it's a property of the wire. So many times you utilize this property to get into the branch. Okay, so understand that the prolapse becomes a positive thing when you really want you to get into a smaller acute angle branches. Radio opacity and visibility is extremely critical because the wire should be visible. You should know where it is parked, especially if the person is obese and if your cath lab quality is not good. So radio opacity and the visibility of the wire has to be, especially the distal part, which is radio opaque, and we should know where is it parked. Tactile feedback. Tactile feedback is an art which needs to be developed over a period of time. It is not a theoretical thing. And you will, once you do some few hundreds of angioplasties, you will definitely come to know where your wire is, because you start getting feel, okay? Especially when you have a complete total occlusions, then also you know whether you are in the lumen or you are dissected it, you have gone out of it or whatever it is. So this is, of course, a tactile feedback which you develop. But of course, again, the construct of the wire also determines when we will have a tactile feedback and when you will not. Okay. Crossing the lesion, of course, you want every wire to be atraumatic without causing any dissection, without raising any flap. It should be able to cross the lesion. That is again a property of the wire. And support, last is the support of the wire. Support of the wire becomes important because many times you have seen you have crossed the lesion, you have parked the wire pretty well, but you're not able to take your things there. You're not able to take your balloons. You're not able to take the stents and other things because the wire support is not there. That means you need a stronger wire. The body of the wire has to be stronger to support to take these devices. It could be anything. It could be a microcatheter, it could be a rota, it could be a balloon or stent or whatever it is. So with that, I would say that please spend few minutes before you really start using your things into the cath lab. So coming to the guide wire, per se, I'll just deal with this only. And I try to, there are various ways of classifying guide wires, various ways of describing guide wires, but I try to do the way I understand the best. And I felt that, it's a little useful and it helps you in a longer run as well. So basically guide wires is a 0.104 diameter is each guide wire. And it has got three basic components: the core, the tip, and the coating. Okay. See, the core is the one which can be of two materials. One is a steel and another is a nitinol. Okay. Again, we can have a little theoretical discussion, what is better and what is not better, but I'll tell you one thing is simple. Nitinol is a material which is kink resistant, which is more flexible. You can give a shape to that. Okay. Whereas steel is not, it is hard, but it gives you a great support. It gives you a great tactile feedback. So if you really are using a steel core wire, I'll go into that. Those are the few examples I'll give you. What are the wires which are having a steel core versus the wires which are nitinol and other things. But generally, if you are really, so these are the two basic things in the core material as such. Before I wanted to tell some more point on this steel, yeah. Anyway, come back to that. So the second is a tip. Okay. Tip is usually the softer parts between, it could be between 3 to 20 centimeters, the distal part of the wire, which is usually a tip. Tips are usually softer in nature. And the tip has got, usually most of the tip will have a spring coil at the end of it. You can see this is the spring coil. That is what it is, a spring coil. Okay. And this could be anywhere between 3 centimeters to the 20 centimeters. Now, this tip again can be of, it is the one which is the softer part which can be bent. Okay. Now you can have a core which is all the way to the tip, which is called a core to the tip, or otherwise core can finish much before the tip. Okay. So the advantage is when the core is all the way up to the tip, it gives you an excellent support. It gives you a trackability. It gives you a tactile support, but it doesn't bend. Whereas here, it is the flexibility. Last three is ribbon only is there where you do the core doesn't even reach up to the tip. So this part becomes more flexible, which is usually the normal core. So most of the workhorse wires are the ones, I'll come to that. That's the point I just wanted to tell, that you may come across your seniors, you may come across other colleagues, you might attend some conferences, you may hear 100 wires. But my sincere request is, once you are into the business, once you are really doing a serious intervention business, kindly stick to one wire. Make your 1 or 2 wires as a workhorse wires. Don't keep, initially you try whatever 3, 4, 5, 6 wires, but stick to 1 wire or 2 wires, because once you are habituated, you can achieve a lot of good results with your workhorse wires rather than shifting on every now and then. So most of the workhorse wires, basically this is what happens. Then BMW is a classic example where the tip is softer and the core doesn't reach up to the tip, and this is a flexible. Okay. And the second, another thing is the tip. The tip may not be the same. It may not be a 0.014 all along. Many times you can have a tapering tip also. So that's what it is happening when you're attending a CTO wires. The tip doesn't remain the same. Here it becomes maybe a 0.09, maybe 0.08, and so on and so forth. So 0.09 is the last to which it can get tapered. Okay. And the weight, of course, yeah, that is also one important point. The tip is the weight. The weight is it is basically described the amount of force required to bend the tip is called the weight, which is usually in the terms of grams. Okay, so normally the workhorse wires are the softer wires are usually less than 1 gram tip. Okay, most of the wires like the workhorse wires we have a BMW floor, the Whisper or whatever, these wires are usually less than 1 gram, and whereas you have the CTO wires, the tip weight can go up to the 12 or Hornet 20 also, so 20 grams also. So the good part of it is that it can transmit a large force in a small area. So that's the reason the larger the weight, it is better it is to cross the CTO lesions. Of course, there are a lot of complications for that as well. Okay, and this comes the coating. Now, primarily, I believe that most of the wires should be divided into on the basis of coating rather than on the basis of a tape or rather than the basis of the construct of whether steel or nitinol or whatever it is. Okay, so the coating, I personally feel they are into two divisions. They are one is a polymer coated and another is a non-polymer coated. Okay, here I would say the polymer coated is that there is a polymer layer which is coated all along the wire. Of course, most of the time, this polymer coated, they don't go up to the tip of it. They fall short of it. Or sometimes half the body is polymer coated, and after that, of course, you have few hybrid wires, especially the BMW. BMW is an hybrid wire where it is basically up to the tip, it is hydrophilic, and the tip is hydrophobic. But the most important point which I wanted to bring it here is that please don't because many of my own colleagues, many of the cardiologists, they say hydrophilic and hydrophobic. What they mean to imply is hydrophilic is polymer. No, there's a difference between a polymer coated wire and hydrophilic wire. Polymer means in extreme degree of slipperiness, extremely lubricious wire is a polymer coated wire. Whereas most of the workhorse wires are non-polymer coated. They are highly hydrophilic wires, but they are non-polymer. So please don't use these inter-exchangeable words and think about hydrophilic is polymer and polymer is hydrophilic. No, there's a difference it is, okay? So polymer versus non-polymer, that's the basic things. And after that, of course, that's what I'll go on to the classification of it. Before I go on to that, so this is what happens when, what exactly means if it is a hydrophobic coating or no coating, it will have an extreme degree of tactile feedback. Okay, beautiful tactile feedback. When you really want to have a hard, strong supported wire, you take a hydrophobic wire, which generally we don't use it that often. To the other extreme is a polymer coated super hydrophilic wire, which is lubricious and trackable and which can easily go into the small branches as well. So this is the two axes in which we play around. Intermittent is a hydrophilic coating. And then, of course, you have a hybrid, which is hydrophilic coating with a hydrophobic wire, which is normally most of the workhorse wires can have either hydrophilic or it can have a hybrid, which is hydrophilic with a hydrophobic coating. So these are the two, the riders you have, lubricity, trackability versus the tactile feedback. Whichever you want, on that basis, you can select your wire. Before I really go into the divisions, I will quickly, as I said at the beginning, the core can be stainless steel versus a nitinol. Stainless steel gives you a good amount of support. There are some specific wires where the body is made up of, the core is made up of the steel. And whereas the only run-through wire is the one good wire, which is basically a combination of a steel and the nitinol. Okay, that's where the core is made of the both. The run-through is a combination wire, but otherwise most of and BMW is again a nitinol, and you have the other wires which are stainless steel. So nitinol. Basically, I prefer more nitinol because it's more elastic, deliverable, trackable, it's more lubricious, and you can really take onto the bands and other things, and probably it's more steerable rather than the core steel. But when you really want a support, many times you have gone the wire, but it is not giving you the support to take your material at that time. Generally, what we do is I don't remove that wire and put this wire. So you use a body wire of a hard steel wire, and then on that you can exchange, keep putting your things below. Okay, so this is the slide. I would say that just spend few minutes here on this, because this is the important slide, which basically gist up my whole talk is that primarily I feel the wires can be divided into non-polymer versus a polymer wires. And non-polymer, I said, are often hydrophilic or hybrid. Okay, and most of the workhorse wires are non-polymer wires. Okay, BMW and Minamo. You can see both the weights they are low weight wires. It's 0.6 grams and 0.8. As I said at the beginning, that run through, Pro Water, Samurai, Cyan Blue. Cyan blue, I'm sorry. These are all the steel ones, where the core is made up of the steel. Of course, Rantu is the only one which is basically a combination of a steel with an nitinol. And these are all good wires. They're all usually a low tip, a low weight workhorse wires, non-polymer coated. So generally, again, choice is yours. But basically, I would say pick up one wire and keep it as your workhorse wire. Then, of course, you have a polymer coated wire. Polymer coated, as I said, that the whole body of the wire and the distal part of the tip can have a polymer. And polymer again I have subdivided into 2 to 3, which is a low tip weight, intermediate, and the heavy weight. And so most of the polymer wires are the low tip weights, which you can see it's hovering between 1 to 1.31 grams. Actually, Pilot 50 is the only one which has got a 1.3 grams, but otherwise Cyan Black and Fielder FC, these are all the polymer wires. Okay. The advantage of polymer wires is, again, whenever you have a tortuous calcific lesions, probably the polymer the wires would do the trick for you. And if I see I'll go on to those examples again. I'll show you in the pictorially also that in non-polymer segment, if after your workhorse wires, after the BMW and other things is, then comes your non-polymer when you have heavy tips CTO wires. Okay, the CTO wires are again a non-polymer wires, and they usually can have a steel core, and which are again, these are again very, very famous wires. Most of the conferences you will see them, Gaia 2, Gaia 3, Zudo, and Miracle 3 is the one which is usually used. And of course, if everything fails, you go with a Confianza Pro, which is 12 grams, and or Hornet 14 and Hornet 20 also. So basically what is happening is, an important thing is, these are not only heavyweight, they are also tapered. You can see Gaia 2 is a tapering to 0.011, and whereas the 0.012, and these are all for the Gaia third, and whereas the Confianza goes to the tapered to the 0.09. So in a very small area, a heavy weight, an extreme degree of force can be applied. So when you really have a bad CTO, a chronic CTO, of course, at your stages, I would never recommend you to venture into CTOs and other things. You can, this is only for more for an information sake, because attempting a CTO will definitely, I personally feel at least the learning curve should be at least 3 to 5 years before you really start going and attacking the CTOs. Don't start jumping onto the CTOs, even though it may be an anti-grade or retrograde is, of course, pretty tough, different. But initially, I would say that, stick to yourself to the regular interventions. Okay. And one wire, I would say that even I used to get confused, Cyan blue versus Cyan black. And Cyan blue is a workhorse wire, non-polymer, normally used in a normal regular as a workhorse wire, but it has got a low tip weight. It's a very, very soft tip. Cyan and there's another wire. I'm forgetting the name of it. Okay. These are the two which usually are used for the collaterals crossing. Actually, they're extremely soft tipped. They can cross through that. Whereas the Cyan black is a polymer coated. Whenever you have the first degree CTOs, that is the first choice. If you really want to use a polymer coated wire, probably you can go with the Cyan black. I don't know. I think running out of time. Is it Rishi? Okay, I'm already out. It's okay. I'll just finish it up. Okay, in 5 more minutes. 3 more minutes. So basically, if you really want a trackability, flexibility, deliverability, you need to have a high polymer wire versus and obviously you will lose a tactile feedback. That's the problem with these polymer wires. And whereas if you want a high tactile feedback, you need to use a stainless steel with a core to tip with less with a nitinol. And as I said, if you really want a good support, you need to have a heavy core of a steel. So directly I'll jump onto the 2-3 situations where I would like to use watt wires. If you have a critical 90% calcified stenosis, probably I'll start with a Whisper. Whisper is my workhorse wire. Okay, probably I take the liberty because Whisper is a polymer wire, but it is one of the best wires I personally feel, because almost for more than 20 years now I've been working on Whisper only. So Whisper is my first wire, and it has got a beauty that, you know, if you have a critical calcified, or if you have a tortuous, you have more than 2 vents, probably you can go with a Whisper wire. Cyan black, as I told you, it's a Whisper polymer wire. Again, it helps you in a calcified stenosis. When you have a thrombus situations, probably you can go with your regular workhorse wire. If it is an acute thrombus, like you have a primary, you are doing a primary angioplasty is again very gratifying. But again, you can get into troubles with that if you are a little careless. So be careful with your wire handling, even in an acute MI situations. So you can go with a safer workhorse wire. Oh, I missed 2 slides are missing. Okay, fine. Maybe it's summing up. So basically, but if it is a chronic thrombus, then obviously I would say that, you know, workhorse wires may not be helpful. So probably again, the Whisper can be used. Okay, the reason why I'm saying is that probably if you are careless with polymer wires, you will never know when you are dissected, when you went out of the lumen. Okay, and it's very common. I have seen, so for other things, fine. But if your wire is buckling while crossing the lesion, stop there. That should be your fundamental. Okay, please don't keep pushing it. I've seen few of my younger colleagues who come and other things, they try to push. Don't do that. If you are, there is a resistance, there is definitely a resistance. Many times you are doing a bifurcation, you cross the first end, you're going to the side branch, and you know that the wire is not going, it's buckling, and still you push it. You are in for a disaster because you're dissecting the flap there. You're definitely dissecting it. So please don't push. That should be a normal thing. So buckling should not be there. Even in a thrombus, if it is buckling, I've seen recently, 3 days before, there was an organized thrombus. Somebody did. He completely dissected it out because it buckled. He just went out and ultimately there was no flow at all. The flow didn't restore. We left it for 2 days. Then after that, there was a collateral and through which, and then somehow we could save the patient. So kindly don't push those things. So with that, I should sum up because there is no end to these wires. We can keep on talking, but at your level, I would say that, you know, basically have this classification. CTO, I don't want to really check, but go through this. But one thing I would say that this is the 4 wires which I would go with, Fielder XT with. I would start if you have a tip of that means if you have this tip. Then okay, it's a acute one. You can probably go to with primary wire. But if you have a blunt tip with a smart side branch, then probably either Pilot 200 or Gaia second. And if nothing goes, then of course Confianza Pro, and they're all for only discussion purpose, not at your last slide. This is that when you have, because many times you come across this, that you have crossed the lesion, you have done everything, but nothing is going through because this is then you take a guideline, you try to give all supports. Fair enough, those fancy things are good, but I would say use your common sense. Okay, you know that many times I still feel that cardiology is more of a mathematics and an intelligence. It is not just a dumb procedure. Okay, think about it. You will definitely get through that, and you will see many times maybe the body wire is helping. Your support is not there, and you're trying to push with anything. It won't go. Okay, you will only waste a lot of material. So these are the 4 things. The only one, the Grand Slam and Iron Man, is the one which really gives you a great strong support. If nothing is, if you think the support is a issue. Okay, so for everyone outside, intervention cardiologist looks so beautiful, but the road and everything is extremely tortuous, calcific, and difficult. Thank you.
Thank you, sir. Dr. Rajesh, what will be your workhorse wire of choice?
I am using BMW from last around 15 years. Before that, it was a Cougar wire from the
Yeah,
metal. It
Cougar,
got
Cougar.
stopped now. So these are the two good wire. Um, that is, you have rightly mentioned about the efficacy of various wire for crossing complex lesion. For the fellows, will you like to talk something about the safety of these wires? You have rightly mentioned the experience and the feeling of the wire, which do come with the experience. You have rightly mentioned about integrate wire escalation for CTO. Is there any integrate or wire escalation practice to be practiced by fellows? When should they go ahead for the high tape, high load wire vis-a-vis workhorse wire? When should they start doing the complex cases? What are their learning experience? Something like that. Because it's very important for these fellows to understand about they cannot go ahead with the iron wire or Gaia wire at the straight away.
Absolutely, because I said at the beginning that definitely this is a talk primarily because you're all in even still in third year. Probably you can go through your exams, and at that time you may keep mentioning them because you're not aware of these words and nothing. That's the reason I really brought them, but no purpose of saying that start using them. I would still say that initially few couple please initial 2-3 years I would always say that all my whichever and other things, we are all from same batch and the same time and other things. Initial 3-4 years we used to do a learning part, and by the time all of you think that you have become a great intervention cardiologist and you're ready to do anything, but I still, after that, you need to know what you need to unlearn. Because learning is one stage, unlearning is more important. Okay, you should know what you should not do, where you should not touch. And this is what it is. I would say that don't attempt all these fancy wires. Okay, go with your workhorse wires. Okay, and only one fundamental I would always say that, if you respect the artery, artery is going to respect you. If you don't, if you mess it up, if you are just in hurry, you just want to push up, you just want to do, you will get into the complication, if not today or tomorrow. Definitely you will get into the complication. You might succeed in that particular case, but subsequently you will get into that. So take your time. Don't take too much of a time also, because that is also an art. Because I've seen few of my colleagues, they have crossed the wire, they have put the stent, and now they're debating whether it is missing the lesion or not missing the lesion, and not seeing that the flow has completely stopped. So that is also ridiculous. Okay, so you really have to be alert. You have to, your team has to be alert. They should know. One of your colleague or your sister or technician or somebody should always keep an eye on the hemodynamics, because hemodynamics is, I've seen a lot of, no disrespect to anybody else, but I've seen the other interventions, peripheral interventions by non-cardiologists. Okay, they do a lot of procedures, but they never bother for hemodynamics. At least in Hyderabad, I've seen that, they just don't even look at that point, what is happening to the hemodynamics, because that is the crucial thing. So I think in your beginning stage, yeah, be gentle with your wire, try to cross it should be atraumatic, park the wire properly. And again, we have seen so many things, okay, that you do everything, you cross the lesion, you have put the stent, and your result was extremely good. And you have shifted the patient back into the ICU, and everything is fine. And by evening, you went back to home, or you're on duty, or whatever it is, 4, 5, 6 hours. After that, you suddenly come to know that, the patient is in hypertension, patient is going down. Okay, and you are in trouble now. And then you start seeing, and probably you do an echo, and you see a tamponade, and you may not tamponade, you may see a pericardial effusion. You go back to the lab, and then you see that basically when you left the wire there at the distal part, that slowly went into a smaller branch. You never bothered that because you were so busy with your stenting and ballooning that you really didn't see where that distal tip of the wire went. And it just perforated at that moment of time. And you concentrated on the lesion, came out, and then, it slowly trickled out in a couple of hours. In fact, few people have lost the patients there. So I would always say that distal part of the tip of the wire one eye has to be there all the time while performing your procedure. And coming to the escalations, I would always say, like I said, BMW, even I was using a BMW, now I'm a Whisper. That's my normal workhorse strategies are there. If I really don't, then of course, I go on to the Fielder FC and a Fielder XT. And if it is a complex ones, and then I start taking a balloon support and other things. And then after that, of course, you keep escalating, but not to this Shinobi, Iron Man, and other things. It should not be, at least until unless you are being guided. As he said rightly, Empla's catheter. Actually, that was a point I wanted to tell during his talk, that the Emplat is the one catheter. It works differently. If you push it doesn't go in, it comes out, and if you pull, it goes inside. So this is the commonest thing when you do, when the pressures are dropping, you suddenly try to do, and you will dissect it out when bringing it out. So that should not be done. So I think.
Yeah, I think 2 points to take away from from the point is that many times when you're talking about few of the dictums that we follow in our cath lab is that in all the frames that you are doing, except sometimes that you have collimated and you are focused somewhere importantly in bifurcation and CTOs, at all point of time, distal end of the wire and the tip of the guiding catheter should be visible to you when you are doing your angioplasty. Both the ends are important because if you focus just on the lesion, so in every angiographic film when you are doing PCI, the distal tip of the wire and the tip of the guiding catheter both should be moved. And the point about using force while the wire is not crossing, another dictum that I want all of you guys to remember, that more things move in cath lab by application of mind than by application of force. So if you apply your mind, you are more likely to be successful than you apply force. Please remember this, and I'm sure all of us will have a safe learning. Thank you so much, sir. Thank you for your time.
So now let me invite Dr. Sastry for his talk on stent, various type of stent, their evolution type and influence on the PCI outcome. Dr. B.K. Sastry, please.
On pen drive issue, I think. One second.
Good evening, everyone. Before I actually get to, first I would like to thank Srinivas Kumar for inviting me. I am an odd man out here. The reason is I would like to call myself a general cardiologist than interventional cardiologist. I think being a general cardiologist is more difficult and challenging nowadays with the advancement of the technology and hardware. The interventions are, I don't say easy, but they are quite a lot different from what they used to be a couple of decades back. Probably I suppose I'm the senior most here, so I can take that point. Now, they're struggling with my pen drive, though I get much before. One quick point about the wires, couple of points. Most of you people sitting here would probably be using gassed or G wires, so-called Oxford wires or gas wires. Shivkumar said his preferential wire is Whisper. I'll be hesitant to do that, especially to tell you the juniors, freshers. Whisper, especially if you use, you make sure in the initial days that some senior is there with you, and make sure that always keep the eye on the distal. It has a tendency for perforation. And most importantly, a gassed Whisper wire loses its coating. It loses its coating. All the wires lose their coating. So they are not like what the new wires are. They tend to be sticky. Balloon gets stuck to the wire. When you pull the balloon, the wire also comes out many times.
In my institute, we don't use any Oxford wires. And as he said very rightly, never use an Oxford Whisper, because coating will go away and it will struck. And in fact, this whole movement will be very difficult. So if you are using an Oxford, I would say, don't go to the Whisper. Whisper is only a new wire has to be there all the time.
Yeah. Yeah, I think I'll move with my talk. The, the history is very important to understand the evolution of the stents. Evolution is after all history. The first angioplasty, plain balloon angioplasty, was done by Grunzig in 1977. He's a Swiss international cardiologist. Unfortunately, he died premature. And that is a great milestone in the practice of cardiology. He did only plain balloon angioplasty in a proximal LED lesion, and the patient did remarkably well. Thankful to him, there is no acute dissection or thrombosis, and it caught the attention of the international cardiologist. But plain balloon angioplasty is problematic because there can be acute vessel dissection or acute thrombosis. And the days when we were doing plain balloon angioplasty, the surgeon used to be on standby. I remember one of my relatives asked me to recommend to Dr. Somaraju to get the procedure expedited for RCA, type A balloon angioplasty. That is in 1989 when I was doing my DM in Chandigarh. I came home to Hyderabad and my relative said, please ask Dr. Somaraju to do it fast. Why? He has been waiting for 3 days, and all the 3 days for a RCA plain balloon angioplasty, patient's blood group was O negative and 6 donors were standby. 6 donors standby, O negative group for plain balloon angioplasty of RCA. You know, when suddenly patient requires surgery, anything can go wrong. This is an era where stents are not there. So the two main problems with the plain balloon angioplasty are the dissection, sometimes which can be very nasty, closure, or acute thrombus formation, and sometimes you have to send the patient for surgery. So to bail out, the bailout stents have come, the Giantarco stents and Victor stents. And later on, 1984, Sigvart have started a self-expanding stent, which is a plain metal tube. It is very difficult to negotiate the plain metal tube through the tortuous arteries. Then later on in 1987, the balloon expandable stents have come. The Giant J Pama stent. That is, I think it's about 94, yes, 94. Then the bench stent and stress, they are the two studies which compared the bare metal stents with the POBA and demonstrated superiority. I think that if I remember well, the bench stent restenosis rate was 32%, 16%, but later on it became 32% because more and more type B, type C1, type C lesions they started doing. Then we realized that the bare metal stent is the problem is you tackle the acute dissection and acute thrombosis, but you are stuck with restenosis. And to prevent restenosis, 1999, Cypher stent was first used. And in 2002, the Cypher data has come. You know what Cypher means? Zero. The first Cypher stent, diluting stent, the restenosis rate at 6 months is 0. Cypher means 0. And Cypher, that is the sirolimus stent, then simultaneously very soon, paclitaxel stent has come. Both were shown remarkable chance of restenosis. Then what happened in 2006, European Society of Cardiology, this is a big warning, big commotion, because very late stent thrombosis was there. Even the Times magazine said walking time bombs, because the people with Cypher stents may have stent thrombosis any times. So this is actually a big commotion in the general news media also. And people studied it and they modified the drug-eluting stents. And today you have got various safe stents. As I mentioned, the main problem with the bare metal stent is the instant restenosis, which can be there in 20 to 30% of the patients. So what does the stent contain? The basically stent in the center has a stent platform, which can be cobalt chromium, platinum chromium, or stainless steel. That is covered by polymer. Various kinds of polymers are there. I'm not going into detail. And anti-proliferative drugs to inhibit the smooth muscle endothelial cell proliferation. There have been tried many, but the main today what we are using are sirolimus, everolimus, biolimus, and jetrolimus. They are the 4 most commonly used. Now, as I mentioned, the drug-eluting stents versus bare metal stent data, you can see both in the Sirius study, Taxus study, and Endeavor study, the restenosis rates are much less. And I mentioned the basket late study raised alarm that the late stent thrombosis is very high. If it occurs within the 24 hours stent thrombosis, it is said to be almost always operator dependent. That is acute stent thrombosis. Within 1 to 1 month is subacute thrombosis. 1 month to 6 months is late thrombosis, and after 1 year is very late thrombosis. So very late thrombosis can occur with first generation regulating stents. This is a busy slide. This is a representative of so many, I mean, we have got so many stents in the market. This is a representative of the various stents. You have got Biosansars, the Biofreedom, the R0, Premier, Resolute, Synergy, Ultimaster, Zynes, various parameters, some of them which I will go into it. And you should also know about the Indian stents, the stents manufactured in India. There are 3 main companies. There may be more. I think there are definitely more than 3. For representative purpose, I have taken 3, the Sahajanand and SMT, Relicis and Merrill. The stent characteristics, if you see the physical properties, they are no less than the so-called imported foreign or branded stents. You should go into these details, minor details, to understand what they are. So what is the composition? The composition can be stainless or iron platinum, cobalt chromium, chromium L605, cobalt chromium L605. There are various metal alloys. The composition varies depending on the stent platform. Now, what is the main purpose of this? They provide the radial strength. They give the opacity. You can see the stent there. They prevent the recoil, but they're also prone for strut fractures and thrombosis. The first 3 are important, safety and efficacy. The last 2 are the safety points. And the bare metal stents, the stent platform, as well as the way it is made, physical properties are also important, because in the very early studies you see, the various stents, depending on their structure, platform, the restenosis rates vary quite widely. So what does the stent contain? You obviously look at the cell length. There are so many cells are there. You see the cell length. What is the crests per ring? What is the kind of links are there? What is the stent made up of? And what is the thickness and width of the strut? So all these things are important biophysical properties which decide whether what is the cell size, what is the radial strength, what is its tendency for longitudinal stent deformation, what is the opacity. All these things matter. So this basic information, you be familiar with, as Sivakumar or others were saying, you be familiar with few stents and know their characters thoroughly. And the links are also important, because you can see links can be in phase or out of phase or mid strut connectors or offset peak to peak, various kinds of designs you can have. As you can see, where is the laser? This is the one. Yeah, as you see, the strength of the longitudinal strength increases towards this, whereas it becomes weaker as it goes to the right side. And radial strength of different regulating stents changes. For example, here some sample is there, Zyne, Synergy, R0, and Resolute. They, depending on the characteristics I said, the radial strength changes. And what is longitudinal integrity? The stent is a metal tube, isn't it? Thin metal tube. It can get deformed. It can get deformed either when you are pulling or pushing. Suppose the stent is in the left main or the proximal LED, the guide catheter can get sucked inside and can deform the proximal portion of the stent. That is commonly seen with the Promus stents, and that led to a lot of problems. Similarly, once you have placed the stent, not necessarily there only, suppose you have placed the stent in the mid LED or mid RCA, and you want to do post dilatation, there is a guide wire bias, or for whatever reason you are using a G balloon or whatever, the balloon doesn't go, it may go and hit the ostial portion of the stent and it may get deformed. Similarly, you have done a post dilatation, or you are exchanging a wire, or you are removing a balloon after the dilatation. If the strength of the longitudinal strength of the integrity of the stent is not strong, it may get deformed while pulling. In the upper chamber, the push pressure, and here they put a hook and saw how much pressure is needed to deform the stent. So depending on the pressure that you use, either pushing or pulling, you can distort the stent and that will lead to problems. So we should know about the longitudinal stent deformity. Then you have put a stent, you want to go into a side branch. Now the side branch should be accessible. Different stents have different cell sizes. So if the cell size is big, then it's easy for you to cross into the side branch. And not only side branch, if you want to do a later balloon dilatation of the side branch or a kissing balloon, you want to pass the balloon, it is important to know what is the cell design where the side branch is arising. So nowadays, some of the stents have got open cell in the center. So larger the cell, it's easy for you to pass the wire and balloon subsequent to this one. This is one of the, you can understand more clearly here. This is the cell size. Look at the cell size. It is so big. This particular 5 stents are of the same length and magnified to the same extent. So this gives you an idea whether you have got a large side branch and you want to preserve it or cross it, you can't sacrifice it, then you should use a open cell design. Then the stent markers are there. Stent markers in the giant stent and are very at the very starting of the stent, whereas in Synergy slightly delayed and Onyx slight gap is there. So you can see when you expand it, the giant stent just expands where you are inflated, where the stent is there, marker is there. But in Synergy and Onyx, there is a small gap. This becomes very important when you precisely want to put a stent at the ostial lesions, at the ostium of the vessel. So you should know what kind of stent you are using there. Now the strut thickness becomes an issue. The strut thickness in the early stents used to be more than 150, 120, 150 millimeters, microns also. But now we have got microns, ultra thin struts, about 60 to 80 microns. So does it matter whether what is the strut thickness? It does matter. Why? Because if you have got a thicker strut, it takes more time for the strut coverage to occur. If strut coverage is delayed, there is a uncovered stent with fibrin formation and inflammation. So the thicker struts take more time and they are prone for thrombosis. The same thing was shown in the meta-analysis of the many stents. Here in this study, in this meta-analysis, me stent and biomime were studied, and stent thrombosis is significantly less, though the the TLR rates are equal. The stent thrombosis is less in the ultra thin stents. So it's one of the useful points, and also ultra thin stents will give you more flexibility, more you can position the stent easily. Trackability is more, but the radial strength will be less. And there are one of the important problems with the stent is the late stent fracture. What are the factors which are associated with the stent fracture? RCA stent, stainless steel, longer stents, hinge motion, overlapping, stent vessel damage, this one, multiple stents. So these are all various factors which influence the occurrence of stent fracture. In the bench testing, these integrity element and premier have at the even 10 million cycles, the strut fracture is less. This you can see in the graph here. So the late stent fracture is one important factor in the late stent thrombosis or restenosis. So it's always a trade-off. If you've got a thick strut, you get a more radial strength. If you've got a thin strut, it is more flexible and trackability is more. If you've got an open cell design, you can access the side branch. But if you've got an open cell design, the tissue prolapse will be more. So here you can see there are the various characteristics. Some trade-off will be there. So in a given patient, you have to select which one you want to choose. So what are the desirable features of a stent? It should be low profile to cross the lesion. Nowadays, it's not difficult. Earlier, we used to have stents. It will be difficult to cross. If you prepare the bed very well, there should not be a problem in crossing with a stent. If you have a problem with the crossing with a stent, generally means you didn't prepare the bed well. It should be flexible to go through the tortuous vessels, should not get distorted or displaced. Enough longitudinal strength should be there, radial strength should be there, especially if you're using for the ostial or calcific lesions. Excuse me. You should have uniform expansion. Side branch access should be there. Block prolapse should not be there. and it conformed to the vessel curvature without vessel distortion at the edges. Otherwise, you may have vessel dissections or late stent fractures and should be enough radio opaque. Now, the second important component of the drug-eluting stent is the polymer. I mentioned to you the Cypher and Taxus stents had serious problems with the very late stent thrombosis because the polymers used were some obsolete polymers. I can't even pronounce polyethylene covinyl acetate, poly and butyl, blah, 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 blah. So these are all assured with, they are not biocompatible. They produce long inflammation. So patient was prone, there is no complete healing anytime. Patient were predisposed for thrombosis. So later stents nowadays, we use a polyfluorinated polymers, which are highly biocompatible. They use phosphocline, copolymer of polyvinylidene fluoride, and hexafluorpropylene. So these are the commonly stent used. Nowadays, except for the Cypher and Taxus, most of the present day stents, the polymer is biocompatible. And the polymer on the stent may not have uniform polymer coating. It may get webbed polymer surface leading to stent expansion issue, or polymer may delaminate. So durable coating potential for inconsistent drug delivery, flaking and embolization. These are the problems if your polymer coating is not uniform. Now, people said, why keep the polymer? Why biocompatible? We will degrade it. So you use a polymer which gets degraded. They typically use the PGLA that gets metabolized to carbon dioxide and water. So after 3 to 6 months, the polymer just disappears. So there is no problem with the polymer. Once the healing occurs, it is as good or as bad as a bare metal stent after the healing process. So there is no further restenosis there, but you got the result. But when they compared in a meta-analysis of nearly 84,000 stents, the so-called bioabsorbable polymers are not superior to biocompatible polymers. Sorry, biodegradable polymers are not superior to permanent polymers or biocompatible polymers. There is no difference in TVR, there is no difference in cardiac death, no difference in MI, no difference in stent thrombosis, and no difference in short or long stents. Now, they said, why polymer at all? We do a polymer free stent, and there is no polymer. It compares better with the. This is because in high bleeding risk patients, you don't want to give anticoagulants for a long time. So remove the polymer and give the short duration dual antiplatelets. It is superior to the bare metal stent, but it's not superior to the biocompatible polymers. The pooled data of different polymers doesn't show any difference in the efficacy endpoints, and it does matter. The drug does matter. Everolimus or sirolimus, etc. Sometime back, there's a discussion about the paclitaxel. In the drug-eluting stents, sirolimus or everolimus stents are shown to be superior to paclitaxel drug-coated stents. Nowadays, we hardly get any drug-coated stent with paclitaxel. When it comes to drug-coated balloon, till today, the data in randomized controlled trials for drug-coated balloons is only the paclitaxel-coated balloons. The sirolimus coated balloons may be attractive, but you don't have data. Be careful about using that. As far as the stents are concerned, paclitaxel is inferior, but we do not know about the drug-coated balloons. Now, what are the causes of the main problems with the drug-coated stents? Early and late inflammatory hypersensitivity reactions, polymer irregularities that result in inconsistent drug delivery or nidus for thrombosis, mechanical issues like strut fracture or longitudinal deformation, very late issues with permanent metallic implants like vessel straightening and loss of cyclic strain, vasomotion is not there, and prone for neoatherosclerosis. This was mentioned earlier. In the bare metal stents, in the first 1 year, you see much better results with the drug-coated stents, first generation or second generation drug-coated stents, compared to the bare metal stents. But after 12 years, there's not much difference. Whatever the stent, after the 1 year landmark analysis, there's nearly 2% event rates per year. So stents are not suitable in a long run. With metallic stents, persistent risk of stent thrombus and need for antiplatelet agency, that is a case that we want to avoid that. You don't want strut fracture or late malapposition. Prevent future CABG with complete metal jackets. Some of our intervention colleagues are very fond of converting every vessel into a metal jacket. Do you, any guess how many, what are the number of, maximum number of stents implanted in any human being on the earth? Any guess? 54. 54 stents. There is one patient with 54 stents. But we don't want to do that. That is crazy. So when you convert the vessels into metal jackets, at a later time, you can't do a CABGS. The side branch is compromised. Sometimes a complete occlusion or near total occlusion of a side branch from a instant restenosis is very difficult even for experienced operator to go. And long-term issues with two stents in bifurcation lesions, aorta lesions, concerned young patients, issues with imaging, you can't do a CT coronary angiogram, concerned with endothelial function and vasomotion. So all these things are long-term determinants for the drug-eluting stents. So there is a promise of the bioresorbable stent in which there is a phase, earlier you require support, then the drug elution occurs very early up to 3 months, then it gives support, restoration of the vessel wall occurs, the metal is not there. The polymer is the metal here. So that gets resolved. For a period of time, the stent is resolved and you are left with the open vessel here. So it is like probably drug-coated balloon and drug-coated stents will compete with each other. So with these ideas, the Abbott has come with BioAbsorb BBS. It is a semi-crystalline circumferential sinusoidal ring. Strut thickness is 150 microns. Because it's not a metal, it doesn't have enough radial strength. So this is a polymer. To give that enough radial strength, they have used 150 microns. And because it's not radio opaque, you require markers at each end. And everolimus is the coated stent, and the stent. The 3-year outcomes were not good. 2.3 versus 0.6 compared to the meta-analysis of 4 BVS, ES, or RCTs. Most of you would not have seen the 1-year results of BVS. I'll tell you a problem there. This paper was published in NEJM. Most of the studies use the what we call non-inferiority. The non-inferiority margin for the first RCT for BVS is 4%. 4% is not acceptable. Be careful when the companies want to promote the products. The company knew that BVS is not going to do all along. I'm sorry to say this openly. They used a 4% inferiority margin and said it met the non-inferiority margin and pushed the stent only to recall it back after a couple of years later. And you look here, the meta-analysis of 3 years target lesion failure, 11.2 and 8.1. The Abbott has to withdraw it from the market. Now, there is one point here. Suppose the landmark analysis at the end of 3 years, after 3 years, there is not further problem. So the first problem is only in the first 3 years. So what is the reason for that? Now, some of the interventional cardiologists who are, I don't claim to be one, who are very die-hard interventional cardiologists, they say, if you use a proper technique of the BVS implantation, you get a better results. So what are these good techniques? PSP. What is PSP? Anybody? Huh? Wonderful. Pre-dilatation, sizing, and post-dilatation. So it's a bed preparation. You prepare the bed well, you take the appropriate size and do a proper post-dilatation. Imaging, you see that there is no under-expansion or malposition. Use the prolonged DAPT, use the thinner struts, and improve the mechanical properties. Probably that will do better. So in this direction, surprisingly, our own Indian company was working on this. Maris 100, this is a Merrill company. From observe towards this, there is a change in the geometry, change in the strut thickness from 150 to 100. Crossing profile is decreased from 1.4 to 1.2 millimeters. More radio opaque markers. It is sometimes you have to struggle in the lab with BVS to position. And size matrix is more. You can have pick and choose many options. And storage conditions are more friendly. So this is the stent diagram. You can see it on the net. Same thing was what I mentioned. Central open cell, closed cells at the ends, then all these high visibility markers, etc. Now, we don't have a randomized control trial. We have only clinical evaluation trial in about 101 patients. And this is 108 patients. And they did only imaging this one, all quantitative coronary angiography, OCT, IVUS, CTA, everything was in favor, was very optimistic. Only one patient had MACE in these patients. So how do you select the stents in a given patient? Younger patient, probably in another couple of years down the line, we'll be using drug-coated balloons or biovascular scaffolds. We don't want to put a metal stent in the patient for long run. Elderly with high bleeding risk, you can choose a so-called polymer-free stent, or even onyx stent is good enough. Some of the stents, Synergy also, you can get away with 1 month dual antiplatelets. If you If you have a small vessel with less than 2.5 millimeters, you use the ultra thin stents like Orsiro or Onyx. If you've got ostial or calcific lesions, use a stent with good visibility and radial strength and less chance of longitudinal stent deformation. Probably Zynes will do good. If you're doing a crossover stent, especially across a big branch like circumflex or a large diagonal, you should have access to the branch. So choose one with open cells like a Onyx or Synergy. If you're putting a LMCA to LED, sometimes there is a significant mismatch. You have a 5 millimeter LED and LMCA and 3.5 LED or 3.5 circumflex. Your stent should be good to expandability. That's the Onyx is one of the good vessels. Again, trackability, you should have a ultra thin struts. And if you've got instant restenosis, as far as possible, avoid a drug-eluting stent. Always do OCT. Results won't be good if you deal with instant restenosis without OCT. See what is the mechanism of instant restenosis. You use a cutting balloon or something, rotablation, and get away with DCB. If you are desperate, use a drug-coated stent of a different make, different drug. And patients with STEMI may be DUS with biodegradable polymer, but this is it's a debatable point. Maybe if the presentation is delayed, if you have got a TIMI zero flow, if a large thrombus burden is there, if you're not sure about the vessel size, if you're not using imaging, maybe you can do a plain balloon, establish flow. If there's no dissection, come back and then go back and can put a stent little later. So we talk about all the time about the clinical evidence. We talk about evidence-based medicine, but when it comes to stents, there are a lot of problems. If you look at the randomized controlled trials, most of the time, whenever you do read a randomized controlled trial, look at the inclusion-exclusion criteria. You want to apply RCT findings to your own patient, ask yourself, will this patient be included in this study or not? So most of the times, these pivotal studies are done in low-risk patients. I'll tell you one more secret. I can take 1 minute. I was doing looking at the data of the driver stent. You may not, probably it's not available in the market now. Medtronic made the driver stent. It's a popular bare metal stent. If you look at the FDA data for bare metal stent of driver was 3 and 3.5 millimeters diameter and 16 millimeter length. With that, you get excellent results. If the lesion length increases, if the diameter of the stent decreases, you get worst results. So don't be tempted to use long stents and shorter diameters. So BMS driver used that data. With that data, they presented to the FDA and took approval. But surprisingly, the BMS driver, the FDA data for driver for 6 months is 16% restenosis. When they did angiographic analysis of all the stents at 9 months, the restenosis rate is 32%. It is there in the FDA website. If you are interested, you can go back and search that. So be careful when you are looking at these RCTs. They use typically in a low-risk patients, and they exclude patients with lower GFR, elder patients, acute coronary syndromes, etc. And they never look at the superiority or equivalence. They look at the non-inferiority. So all stents look alike. And often compared with earlier generation DS or BMS, you saw the BioLeader study. They compared with a bare metal stent. It is not even available in the market now. And they use combined endpoints of target vessel revascularization, MI, stent thrombosis, cardiac death. They're all lower in number. So you will not get meaningful decisions. Not powered enough to look at the late stent thrombosis. That's why I require meta-analysis. And more importantly, if you look at the Giants family of stents and again go to the FDA website, they don't do an RCT for all the iterations. The platform will remain same and some minor twinkling will be there. You know, they change minor changes. And meta-analysis has inherent deficiencies. Thank you very much.
Very elaborate presentation of various stent and how the thing has improved over the time. I would like to comment that you as a fellow are fortunate enough to be here with the advance in intervention technology. Like Dr. Sastry has mentioned about in the past, you used to have a stent which has to be creamed over the balloon, and then it used to get deployed here and there instead of going at the lesion site. There don't used to be the sheath available for hemostatic sheath, and every patient should used to be ready with a 2 or 3 unit of blood standby before going at for the PCI. So that used to be the practice.
One of my seniors says, nowadays, if you don't put a stent and want to leave with POBA, be prepared to come back in the night or sleep in the hospital.
So late night comfort with putting the stent, which is there nowadays, which don't used to be in the past. Dr. Sastry, a brief comment about we have achieved, possibly we have achieved a plateau where there is no need to have a further advancement in the drug-eluting stent technology. What do you feel like in the future? We have achieved a radio opacity, we have achieved the struct thickness of 18 micron, we have achieved the biocompatible or bioavailable polymer with the Limus family of drug. Do you feel like any future development is going to be there with the drug-eluting stent, which is presently available?
Unlikely. People may be working on biovascular scaffolds or drug-coated balloons. If I have to put my money into any industry to change, probably I have to change the platform so that it will prevent the future stent fractures. Stent fractures are more common than we think, and they can produce the late thrombosis as restenosis. And underexpansion is a problem. So I think probably, as you rightly said, you invest more in imaging related. I'll tell you one thing. To give a different example. You know, some of you may say, I like bangan curry, I like some bendi curry or something else. If you cook properly, all vegetables taste good. Similarly, if you put a stent properly, all of them will be good. You prepare your stent well, you position it well, you take the proper size, diameter, and length, you do a proper stent dilatation, you check yourself with the imaging technique. 2 years back, I have published in Indian Heart Journal. I have followed 3,500 patients, consecutive patients with various drugs for 1 full year without any loss except 2-3 patients out of 3,500. And there is no difference between different stents in the 1 year event rates. All are same.
So,
Thank you.
any question from the audience? Otherwise, thank you, Dr. Sastry. Let's move forward to the next presentation.
I would just add on one more point is that excellent presentation, sir. And I think it will take some time for you really, because he has shown more of his experience in the lecture. I really am thrilled with his lecture. The whole thing is, and few salient features, I think you should note of it, that because I've seen a lot of youngsters, you are so fond of, making a cosmetically looking good artery. Get rid of that habit, please. It's called sofa effect. Sofa effect is you brought a good drawing room and other things. You got a new sofa. Everything looks good. Then after that, you change. Oh, the curtains are not looking good. So let's change the curtains. Okay. You change the sofa and curtains, and after that. So this is what happens. You do a critical block clearance. After that, there is a 20% lesion. You want to cover it up. And as he said rightly, if you put all these trials are pretty good when you have a 3 millimeter stent, 3.5 millimeter stent with a 12 millimeter length or 15 millimeter. And nowadays, I see the youngsters coming out with a 48 millimeter stent with 2.5. Ridiculous. So kindly get rid of this habit. It's not going to be good for you in the longer run. And similarly, I do agree with him that okay, because nowadays, unfortunately, there are hardly who go through any trial. Let us be honest. Okay. You people don't see it all. And then, just see whatever the company guys comes and then, you get, happy with it and other things. Go spend time and see the trial. As you said rightly, most of them are non-inferiority. Never it is a superiority trial. And with that, what are you trying to prove? So please, at least your generation, I am only hoping that you will wake up and then, start seeing things in proper perspective and use it. So with that, thank you. Sure. Okay, so with this, I invite my close friend, Rishi. Rishi, not only being a professor of cardiology at KGMC, my alma mater, he's a dynamic guy. He has a multi-talented abilities. In addition to an excellent academician, he's a great operator. And you really want to, because at one time the numbers were pretty less, but now almost nearly they're touching 1,000 plasties a month there in their center. He's going to be the head of the department very soon in a 6 months time. In addition, he's also attached with IIT Kanpur, and a lot of work along with, we both are also doing on artificial intelligence and so on. So I really suggest that, after you finish your things, please go visit him, try to be his fellow for a few months and pick up his points. Rishi, please.
Thank you so much for the kind words. I hope I deserve them. So, post-lunch session and 4 back-to-back exhaustive lectures. I am not sure if you guys are still, in alert state of mind. So, let's do some physical exercises and see if we can wake ourselves up. Because what we are going to speak today next is something that is a little complex. But if you give me your attention, if you promise to give me your attention for the next 20 minutes or so, then I assure you that I would try to make things as simple as they possibly can, if not simpler. So how many of you are in the final year of your DM, DNB trainings? Final years? And how many of you have completed your DM, DNB trainings? How many of you have been doing independent PCI procedures, if I may ask? Okay. Okay. And how many of you have seen a PCI of anomalous coronary artery happening in whatever labs that you are practicing? No one? Raise your hands if you have. Rest of you have not seen PCI of anomalous coronary arteries happening in your labs? That's rare. As I said, a little raise of hand will... How many of you have seen PCI of anomalous coronary arteries happening? No. So that's an inertia effect. So I'm sure all of you would have seen one or the other cases where PCI of anomalous coronary arteries happen. It is no doubt a challenging situation, and it requires a little bit of philosophical understanding of PCI in order to approach, because it is not only purely application of skill, it is application of skill, knowledge, and a little bit of wisdom. So let's step back a bit from PCI to embryology. This is important because until and unless we understand this, we would not be able to understand the course and the various combinations of anomalous coronary arteries that happen. And trust me, there are very limited combinations that can happen, very limited course that can happen. But just because we have not studied them and understood them and read about them systematically, every time we see anomalous coronary arteries, our blood pressures start to go up and we start to feel a little jittery about doing the procedure. So essentially, in the developmental phase, the first thing to develop in coronary arteries structure are the sinusoids that developed in the first week of intrauterine life. And later on, all these sinusoids get reabsorbed or fuse with the stems that are developing in the grooves of the myocardium, that is the interventricular groove or the AV groove. So they become, either the sinusoids will get resorbed or they will become part of the microvasculature of coronary arteries. Now, when these sinusoids attach, the second component are these stems. The stems are 3 stems They developed in the interventricular groove that later will going to form the LAD. The right AV groove, another stem forms, which later is going to form the RCA, and the left AV groove, which later on is going to become the circumflex. Now, further on in the development, there occurs the bulbs that developed in the bulbous cordis before its division into aorta and pulmonary artery. So there is a right bulb and there is a left bulb. That's you can call it bulb, you can call it bud, and they developed in the right and the left posterior quadrant of the bulbar cordis before it divides into pulmonary artery and aorta. And so the left two stems will fuse with the left bud. So left main will become left LAD and circumflex artery. The right bulb will fuse with the right AV groove stem and it will become the right coronary artery. Now, why is it important? Because some of the developmental anomalies of the coronary arteries are because of the non-fusion, non-resorption of the sinusoids. If the sinusoids do not get resorbed, what you will get? You will get a coronary cameral fistula. So the coronary cameral fistula is the non-resorption of the sinusoid, and that's why the fistula continues to happen. Another thing to remember is that since these stems are developing in the AV groove separately, embryologically and pathologically, they can never cross. So the coronary arteries, when they are taking an abnormal course, will make sure that they will never cross each other. And that's why it becomes, this fundamental knowledge becomes very important in deciding the course of the coronary arteries and you doing your procedures adequately. So these things we need to remember. And let's see, for example, the anomalous origin of the left coronary artery from the pulmonary artery. Now you have to remember that the buds develop before the bifurcation into aorta and pulmonary artery. So at the division, if the buds move forward, they will form the part of the pulmonary artery. And if the bulb continues to remain in the same position, they will form the coronary artery. So all this is very important before we step on to the percutaneous coronary interventions of the same. So there are various anomalies, the anomalies of the origin of the coronary arteries from the pulmonary artery, both left and right. There can be anomalies of the course, that is myocardial bridging and coronary aneurysms. There can be anomalies of the termination, that is coronary AV fistulas and coronary cameral fistulas. But for the purpose of our discussion today, we will limit our conversations to the anomalous aortic origin of coronary arteries, that is left originating from the right or right originating from the left. Are you all with me till now? Okay. So this is the conclusion slide. And let's put the concluding slide first. Just remember three things: that epicardial arteries can never cross each other. Whenever you are confused, the view to decide the course of the anomalous coronary artery is the RAO view. Whether it's the right or the left, it's the RAO view is the most important view. And the two biggest challenges of PCI and anomalous coronary arteries are guide engagement and guide support. Just remember this. Let's move forward. So let's take the example of anomalous circumflex from the right sinus. Now, the first thing that you will see whenever this anomaly is, you will see an abnormally long left main. Now, that is something that should at least raise a suspicion in your mind that it can be anomalous origin. It's not always the case, but it should raise your suspicion. So this particular branch coming out, is it a long left main and this is a diagonal, or is this a circumflex? What is the view to decide the anomalous course? The view, as I said, always and always, most of the time, the view that you have to fall back is the RAO view. You see the RAO view, and you decide here, this is the place where the coronary sinus should be. This is the place where your circumflex artery should be. That view is bald. So you know that this is a diagonal and you are not seeing a circumflex. Now again, what can be the three possible combinations? The three possible reasons here can be, there's a short left main and you have deeply engaged the left system and you are super selective in LAD. That can be one reason. Another reason can be twin origin of LAD and circumflex, separate origin close by, again a super selective LAD. And the third can be anomalous circumflex from the RCA, from the right coronary sinus, RCA, or close by RCA. So what you do, is you disengage the guide, try to take the non-selective injections, and if on non-selective injections you still don't see the circumflex either coming out from a short left main or from close by to LAD, your diagnosis is fairly certain that it is the anomalous circumflex from the right coronary artery. You go ahead and engage the right coronary artery. You will not see the circumflex. 9 out of 10 times you will not see the circumflex because your RCA RCA guiding or diagnostic catheter would be deep seated inside the RCA. And until and unless you pull the catheter back and try to clockwise rotate it, taking the posterior view, you will not be able to engage it. So whenever you are suspecting and you are not seeing it, even in the RCA injection, pull back your guiding or diagnostic catheter, give it a little clockwise loop, and then you would be able to engage an anomalous circumflex coming out of the right sinus. Anomalous circumflex coming out of the right sinus will always have a posterior origin from the origin of the RCA. Either it would be from proximal portion of the RCA or the ostium would be very close to the ostium of the RCA from a posterior location. Okay, now coming to the course. Can anyone of you tell me what are the possible courses of anomalous circumflex coming out of the RCA? How can it reach? What are the various courses it can take? Anyone? This is an important question. That's why I'm asking. Take a guess. How many courses anomalous circumflex can take to come back to the left AV groove? Any number? Yes, please. That's correct. There's only one course. There's only one course it can take. You try to see this embryological image again. The anomalous circumflex has to take its origin from the right sinus somewhere here. And if it takes any other course apart from the retroaortic course, it will have to cross either both RCA and LAD or just the LAD or the left main system. As I told you earlier, major epicardial arteries can never cross each other. That is the first fundamental embryological principle of coronary arteries development. So there is actually, if you realize, you don't have to remember anything. There's no other way anomalous circumflex can take to reach the left sinus except a retroaortic course. And here again, as I told you, the second caveat, the second important principle was RAO view. When you see the RAO view, it's a poor cartoon, but in RAO view, the RCA falls like this straight with the RV branches going forward. What the circumflex will appear like, it will take a sharp bend posteriorly and come back to the same plane because in RAO view, you realize that the AV grooves, both left and right, are superimposed on each other. So whatever course the RCO was supposed to be taking, you will see the circumflex taking the same thing. I hope you understand that. So in RAO view, the left and the right AV grooves are superimposed. So this part of the portion looks like an RV branch, and this is the turn that the retroaortic anomalous left circumflex has taken. So some examples, again, you see here, abnormally long left main, a bald coronary sinus segment, you don't see a circumflex, all the things that we have talked about. And that's inferior wall MI. When you try to pull back this tiger catheter, you see this faint contrast filling somewhere here, giving an impression of 100% occluded abnormalous circumflex artery. You try to engage it by Emplat's catheter, and then you do thrombus aspiration and standard PCI. Now coming to the second anomaly, that is the right sinus, right coronary artery from the left sinus. Now question number 2, anyone else? How many courses RCA originating from left sinus can take to come to the right AV groove? How many? 2, 3, 4, 5. Any guesses? Any number comes to your mind? Anyone? Madam, any number that comes to your mind? An RCA originating from left sinus, what are the various courses it can take? So that's the importance of knowing. You see, the RCA from the left sinus will arise from the anterior superior aspect of the origin of the LAD. And once it's there, you see, right coronary, right cusp is here. So RCA will always arise anterior to the left main origin. And if it is anterior to the left main origin, there is no other way. Here again, it's only one way.
There's no other way except the interpulmonary, interarterial course that is between pulmonary artery and aorta. The RCA originating from left system, left sinus, will have to cross between pulmonary artery and aorta to come in the right AV groove. Because if it does any other course, it will have to cross the left main. And as you realize, major epicardial arteries cannot cross each other embryologically. So again, as with circumflex, RCA, even when it is anomalous, is a very disciplined artery. It will only have only one course. However, it's not always so dangerous, because many a times it is picked up. Of course, if it's an acute myocardial infarction, you will have to engage that anomalous artery and do all sorts of primary PCI. But many a times we catch an anomalous RCA from left sinus as an incidental finding during angiograms with no symptoms, no ischemia, and it is a benign artery usually. And even when it is interarterial, which I want to replace the term usually by always, RCA arising from left sinus is always interarterial course, but it is rarely malignant. It is almost always benign, but sometimes if it causes angina, if it causes blocks, if it causes VT, sometimes there are chances of sudden cardiac arrest. If all these things are present, then it is considered a malignant artery, and ischemia is produced not only by this anomalous, by compression between the aorta and pulmonary artery, but by variety of other things like slit-like ostium, intramyocardial bridging when it is coming between the aorta and the pulmonary artery, angulated origin, and associated CAD. So a lot of things combined make this artery malignant very rarely, but when it is malignant, then it needs to be treated surgically. The two big challenges in anomalous RCA PCI when it is originating from left sinus are guide engagement and guide support. Although a lot of guides have been described for guide engagements, but usually these guides are not present in most of the cath labs. So you can try with implants 1 or implants 2. That is the first choice. But many a times, if it is not happening, there is a trick of actually modifying your JL or your implants in the cath lab, giving the tip an off-course 90 degrees turn, which faces anteriorly. And normally it will not happen. You have to warm the catheter up. You can either dip it in the autoclave hot boiling water, or you can do a blower, the hair blower kind of thing, and you can put it over a guide wire and make the shape pointing anteriorly off course to the plane of the guiding catheter. And when you do that, then probably your chances of engaging an anomalous RCA are increased. And every year, probably once or twice, we will have to do this in our cath labs. So this is an inferior wall myocardial infarction. RCA is not found anywhere. And finally, by using implants, we are able to engage the RCA. And then, implants or angulated catheters, implants or Judkins may be used in this scenario. So the first problem is guide engagement. The second problem is guide support. You can do it by putting 2 wires, buddy wires. You can do anchor balloons. You can deep throat the guide by balloon support. And you should always use taut, short size, and very, very deliverable stents in such a scenario, because if you take long stents, if you take stents that are not very easy to deliver, then you will end up wasting a lot of time, a lot of contrast, and you will get a lot of radiation on the way. You see here, this is an example here. Anomalous RCA coming from left sinus. By great difficulty, you could engage it by an implants catheter. But you see the wire angulation coming. It is a very difficult wire, but every time you proceed forward, the wire comes back, the guiding is pulled back, the devices don't cross. When you put the buddy, just the 2 buddy wires are sufficient to push the catheter back. So again, you take a hydrophilic wire. I think this is Fielder XT. You take a Fielder XT across, take a buddy wire forward, and then you inflate the balloon while the 2 wires are inside. And when you inflate the balloon, it anchors your guiding catheter. Then you clockwise rotate your guide catheter and deep throat that guide catheter inside the coronary, inside the artery. And that is safely done sometimes even with RCA catheter, if you can engage it with it. And then you can deep throat, and then you can complete rest of the procedures. So guide engagement and guide support are 2 issues, but they should be, and it becomes really, it's too simple to look at, but it becomes very challenging when you do these cases. Coming to the third anomaly, that is the left sinus, left coronary artery from the right sinus. Now, unlike the anomalous circumflex and anomalous RCA, left artery is notorious. It can take any route. It can take a route that is anterior to the pulmonary artery. It can take a route between pulmonary artery and aorta. It can take a retroaortic route, and it can also take an intramyocardial route, the septal route, as it is called as. Which is the best angiographic view to decide the course of anomalous LAD? RAO. See, you guys know already. RAO. So there were only two things you have to remember. The the coronary arteries will not cross each other, and RAO is the view to fall back on whenever there is a confusion. So what do you see in that RAO view? You see, it's very simple. And if you remember, how do you decide the course? Of course, CT is the gold standard, but if you don't have CT, one trick is you can put in RAO view, it's not a clear RAO, but somewhat RAO-ish view, your pulmonary arteries would be somewhere here. So one trick is you can put a pigtail in your pulmonary artery and then you can decide. But anyhow, the other view is the course of the artery. Now, if the artery is coursing, making a dome in the right superior quadrant of the artery, then the course is anterior to the pulmonary artery. This course is anterior to the pulmonary artery when it is making a dome in the right upper quadrant. And you see here, right at the tip where it is crossing the pulmonary artery, just the anterior-most segment of the heart, you see a critical lesion here. The other courses can be, if it makes sort of a sharp U in the left inferior quadrant, then it's the retroaortic course. If it makes a small U shaped upwards in the right lower quadrant and make a sigmoid curve and comes back like this, it is the intramyocardial, the septal version. And if it makes a sharp turn here, runs between the intracoronary artery, what is defined as, at this point of time, the arteries becomes end-on, which is defined as the I sign. If you see the end-on artery here as the I sign, and it makes a sharp bend and comes forward, this is the interarterial way, which is between the aorta and the pulmonary artery. So in contrast to RCA, interarterial course of anomalous LAD is usually malignant and should be surgical treated even in the absence of symptom. This is written in literature, but many a times we get, I recently remember I got a patient who was like 60 years old and who has some, mild degree of TMT changes. He has survived with this vessel for 60 years, mild degree of, ischemia on stress testing, nuclear testing. So I really don't know what to do to advise a surgical, treatment to him or not. He has survived with this artery for 60 years. So I'm scared. But generally speaking, malignant interarterial course of LAD should be surgically treated, even if asymptomatic, especially if you catch them in younger age groups. So there's again a myth. Sometimes we see that whenever we see anomalous coronary artery, it is only the right guiding catheter. It is not the case. You see here the anomalous LAD arising from the right sinus with the anterior to pulmonary artery course. We are struggling with implants. We are trying to get ahead, but it's not. The things are backing up. As soon as you change it to a right guiding catheter, then things become easy and you could complete the procedure. There are other rare cases where you have single coronary arteries, large size artery, which gives rise to both RCA and the entire left system. And we have this case where both LAD and RCA were diseased in a single coronary artery, and we finished the case in one setting. So I would like to just close by saying that anomalous circumflex from RCA from right sinus is always retroaortic in course. Anomalous RCA from left sinus is almost always interarterial in course, but rarely malignant. Interarterial course for LAD is usually malignant and rarely for right coronary artery. Most important view to decide to fall back on when you want to decide the course of anomalous arteries, of course, only in the left side, is the RAO. And the two biggest challenges of such PCIs are guide engagement and guide support, but that can be overcome by a little bit of wisdom, experience, and a little play of hands. Thank you.
Great presentation. Yes, as rightly explained about, it's an experience and challenging, of course, to do the PCI of the anomalous coronaries. For fellows, it's important to recognize that you are dealing with the anomalous coronaries instead of spending too much of time in localizing the anomalous origin of the coronary artery. One should think about that you are dealing with. There are certain signs like that the city has rightly mentioned about a bare area for the L6 is the one you are not able to see the left coronary in the left sinus, and at that moment of time you should start searching for that are we dealing with the anomalous coronary, and then to go ahead. Here, I just want to add that sometimes the echo is also important to know about, especially for the anomalous LCX or anomalous left coronary from the right sinus, which is having a retroaortic course. You can have a straight line which can be visualized. So whenever you do have a difficulty in the cath lab, you can have a look on the echo, where is the origin of this anomalous coronary, and then you can accordingly go ahead. There are certain cases when there is a need to go ahead for the CT angio done in case patient is not of acute coronary syndrome, just to become more wiser, to have a less of contrast and less of the fluoroscopy time to plan the intervention. Any question? Yes, Dr. Sastry, please.
Apart from the 2D echo or CT angio, sometimes you can do a IT root angio, DSA, to know things may be there. And second thing, after the advent of guideliners, it becomes easy. If you can pass wire, the guide support, you just pass a guideliner, your job is much easier.
Yeah, that's true. Guideliner adds to the support. Anything that adds to the support, guideliner, buddy balloon, buddy wire, anchor balloon helps. But what happens sometimes, we also have to realize that the first angulation of the anomalous coronary artery is not normal. It generally takes a very acute bend. So sometimes taking just the guideliner or balloon sometimes, or a large size balloon, or let's say a pre-used balloon, itself by its weight, disengages everything. So guideliner, if you can get it across the lumen and to a respectable distance, then it adds to the great. But sometimes just pushing the guideliner itself might pull it back. So this is the two counterpoints that you have to take care of.
Another point is sometimes the RCA, it comes down
Yeah.
and takes. In my experience, Amplat's right.
Yeah.
Or sometimes it gives a very good support. It just sits there.
Yeah.
And then things becomes easy.
Yeah. So as I said, you should not go back with the image that for this particular anomalous coronary artery, this particular guide is better. You have to improvise, and whatever is helping you. One of the examples that we showed right from left sinus, it was RCA that helped us get across. So any catheter that helps you get across is beneficial. And those times when RCA is looking downwards, it sometimes, catheters that look down, like multipurpose, might be able to help you.
I'll just add on that excellent lecture. And the one of the important points which I really want to highlight again is that normally we tend to, as he said rightly, although guideliners and other things they help, but if the initial ostium is diseased, they don't allow anything to get in. Actually, everything gets backed out. Even if you are able to do it, the moment you put a thing, it gets backed out. But if you push your guide catheter thinking that, it's going to somehow get engaged, you are in for a disaster. So he said one very good point is, when your wire is through, put a balloon. Whenever you have a balloon inside, not inflated, even just a balloon shaft, the lumen, the catheter remains in the center of the lumen. It doesn't hit the walls. So dissection possibilities are minimal. So don't manipulate your guide if you don't have the balloon array. Only just by plainly, if you manipulate, you will dissect out quite often.
Just having a balloon, yeah.
Second thing is that you said complex science and but what other thing I should quickly point out whether it is an diagonal or circumflex is the lateral view. Because the lateral everything that goes posterior is always circumflex.
Yeah.
The anterior portion is a diagonal.
That's true. So I mean in the lateral view, the diagonals are going to, the LED is going to, and it helps us, as Dr. Rajesh lectures also pointed out, sometimes deciding between LED and diagonal, because the LED will follow this entire course retrosternal, and the diagonals will fall down, and the circumflex would be behind. The only challenge of taking a guideliner over the balloon is because the principle is that guideliner has to be taken over the wire and then the balloon has to go inside, because then otherwise it changes. But the only thing is that I think just as Dr. Shiv Kumar said, the balloon, if it's inside over the wire, you have to imagine that it will act like a large, heavy, thick guide wire. The balloon shaft will act as a guide wire, and on that guide wire, you can clockwise and push the guiding catheter in. Yeah.
Thank you.
Thank you.
Okay, thank you. Let's close this session. We have completed this afternoon session, and there is going to be a tea break to be followed by next session on the imaging.
Uh, So please give a loud round of applause to our faculty for this session. I think it was a wonderful session.
I just request all the people who are moving out to come back within 5 minutes, because our senior guest faculty from US would be joining in 7 to 8 minutes. So please be quick, huh? Don't.
Yeah, so it's our duty to felicitate our faculty. So I would request first Mr. Sandeep Jagdale to please felicitate Dr. Rajesh Vijayvargiya, sir. Thank you so much. Next, I would request Mr. K.D. Rao to please felicitate Dr. J. Shivkumar. Next, I would invite Mr. Tapas Mukherjee to please felicitate Dr. B.K. Sastry, sir. And I would also request Dr. Sastry to please stay on the stage as the chairperson for the next session. And also Dr. Rajesh Vijayvargiya, sir, to please join Dr. Sastry. Thank you so much.
check, 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 check.
Hello, check.
Check, 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 check. Under. Check, check, check. Check, 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 check. छोड़ दे. Check, check. म्यूट कर, म्यूट कर, म्यूट कर.
कर लो बोलो कर रहे हेलो हेलो Ajay?
Hey, Ajay. How are you?
Fine, fine. You want to test once the slides? Maybe just.
Yeah, it just says the screen sharing is disabled. Host
Okay.
disabled participant screen sharing.
He was giving you rights. Thank you for taking time to join us in spite of all your schedule. This is.
No problem.
Thank you. And
Hope it's going well.
yeah, but the hall is full because we thought we will have it slightly later. We gave tea break before your talk.
Oh, yeah.
Back, no problem.
You can see, right?
Yeah, we can see the slide. Just give us 5 minutes. Then people are assembling back.
Yeah, no problem.
Thank you.
Mhm.
We are announcing. If you want, you can somebody ask doubts regarding rotablation technique or something. You'll be okay, no? Just people sum up.
Yeah.
Okay, right. Thank you.
They can ask any questions. It's totally
Yeah.
fine.
Okay. Yeah, good evening, everybody. We request all of you to assemble back. Now we have a important guest lecture coming up. Ajay is already logged in. Request all of them to join back. I think all is almost getting full. Ajay, we can start off with me. We have Dr. Rajesh Vijayvargiya sir. He's a professor from PGI Chandigarh, one of the famous teaching institute. And we have Dr. Rishi Shetty. He's again professor from KG Medical College, Lucknow. They'll before you start your lecture, they'll say a few words of introduction. Then you can go on. Rajesh sir.
Okay. So we are going to have a talk on calcified lesion. Then there are various hardware which is available before going ahead for any balloon dilatation, or it's always an extra backup support of the guide which is required, whether it's a 7F or so, 6F or 7F, depending on the situation. And then various armatorium is there, various devices in armatorium is there to deal with the calcified lesion, which includes the cutting balloon. Um, uh, then the laser therapy is there, IVL is the another one. And so let's go ahead and have a talk with Dr. Ajay Kirtan regarding the case and technique review approach to the calcified lesion.
Thanks so much. Sorry I can't be there in person, but I'm happy to give this presentation and also happy to answer some questions at the end or if in the middle if there are any specific questions. Just wanted to say that I do have research grants to CRF and Columbia from a variety of sources, but I'm also the PI of a large trial of calcified lesions. I will talk about that a little bit later. I think that one of the key things that people know is when you have calcium, it's difficult to get stents and balloons across. But beyond that, what is also really important to recognize is that you can have stents that are underexpanded because they're constrained by calcium. If you think of calcium as concrete or a tube, it prevents the stent from expanding, and that is the bigger problem in some senses than even getting a stent there in the first place. So this is just an example of a case like that. You can see this proximal LED in this woman. A stent was placed. It actually rotoblader was done to try to remove the stent, and you still have this problem. And so we were asked to take care of this. So we did start with a more aggressive guide because we thought we were going to have to be pretty aggressive in terms of what we did. And even the IVUS would not cross, and this is a low profile IVUS system. We then went with a 2.0 balloon, which wouldn't cross. Finally, a 1.25 balloon crossed. So you can think that, okay, the best way to treat an underexpanded stent may be IVL or other things like that. But if you can't get a 1.25 or even a 1.5 balloon to cross, how are you going to get anything else? And so this case may be one where you have to do something like atherectomy. Ultimately, what we ended up doing in this case is we were able to get these balloons sequentially across, but even at 30 atmospheres with NC balloons, we simply could not dilate this lesion because the stent was constrained by the calcium. So the question is, we did solve this problem ultimately, but how or why did this happen? This is an extreme example of a case. And I think the reason this type of thing happens is because people don't recognize calcium, and they don't recognize the type of calcium that's going to cause this problem. I would say that with the boom in imaging in India in particular, but even other places, I think people are seeing a lot more calcium. But what I do see is happening is people are not having a sophisticated approach to the calcium. They're now sort of saying, okay, now I see calcium, so I'm going to use some atherectomy, or I'm going to use IVL or something else like that. But there's actually further understanding of the type of calcium that's more likely to lead to this problem. And so I'm going to get into that in a second. But also, it's important to recognize that there's a greater instance of heavy calcification that we're seeing. This is partly aging. It may be, frankly, environmental. It may be statins. Who knows? But in the Syntax trial, about 50% of patients had heavy calcification, so significant calcification during the coronary angiogram. Now, these are patients with left main or three vessel disease. They have a greater disease burden, but we're definitely seeing that. I think it's unusual. For instance, in India, if you have a 25-year-old coming in with an MI, for that patient to have severe calcium. But I think we've all seen cases where with a big disease burden, they might. So you have to be attuned to it and know what to think about. There's certain populations that are at higher risk, diabetics, elderly, end-stage renal disease. Those are important things. And if you see it on a CTA, you should be clued that they may have it. So how do we define it? Well, historically, it's just been on angiography. You just see something with motion, some haziness there, or some shadowing. That's one way of looking at it. If it's severe, you see it on both sides of the vessel. You see the vessel outline. But this is somewhat crude. And in fact, sometimes, for instance, patients with end-stage renal disease, they may have severe calcification, but it may all be external. It may not be within the lumen itself. That's one of the reasons why patients with high calcium scores oftentimes may be at risk for coronary disease events, but they might not have calcium within the vessel itself. So we can do better. We can actually go into the vessel itself. And I think we all know what IVUS detection of calcium looks like. You're basically seeing shadowing here, so this bright and then nothing beyond it. That's an example of calcification. This is an example of what we call the reverberations, and that typically means the calcium is a little bit thinner. But the point is because IVUS doesn't go through the calcium, you may actually not be able to see how that's going to react with a balloon, because sometimes if it's superficial, it might crack. OCT is advantageous in the sense that it shows you the thickness of calcification as well as the excursion of it. The challenge with OCT is you have to give contrast, and obviously your catheter has to get through the calcium in order to be able to see this. Now, what is the correlation between OCT, angiography, and IVUS? Well, it turns out that you will typically detect important calcium if you have a good eye almost all the time based on the angiogram. You will detect calcium in more cases with OCT and IVUS, but it turns out that those are usually thinner layers and layers that are not going to necessarily change what you do. So there are a lot of algorithms you see out there that employ the use of IVUS and OCT, but that's the problem I spoke of before. What ends up happening with many of those things is that people may overtreat with adjunctive devices, and particularly in a cost conscious environment where money is important, you might not need to do that. So you want to confirm that you have a fracture once you've dilated, but you might not need a specialty device to cause that fracture. Now, what does calcium do? Well, everybody knows it makes it hard to deliver your stents. We also know it is harder to expand your stents, like I showed before, increased procedural complications, but then there's also increased rates of stent thrombosis and restenosis. It turns out that calcified lesions are among the highest risk lesions we treat when it comes to adverse events. The reason stents don't expand, we talked about it before. You have a sort of concrete tube. If you don't crack that wall, How is the stent going to expand? The stent is just metal within a tube, so it can't crack, it can't expand. And that's one of the reasons why, as you have more and more circumference of calcium, it becomes harder and harder to expand your stents, unless you create a fracture in the calcium. And in my opinion, the identification of fracture with imaging, and that's usually going to be done by IVUS or OCT, is the most important part of the imaging that you do. It's not, do I see it in one way or another? It's you have to identify a fracture after dilation, and if you don't, then you know you need to do something different. So specific ways, and we'll get to the cases now, of how to do this is you have to modify the calcium, and that can be done with balloons, it can be done with other devices, and this is basically what you see if you don't modify appropriately. You can get stripping of the polymer, you can get stripping of the stent entirely, and you can get the scenario I showed you before where the stent doesn't expand. Many options out there, but these are all potential options to treat calcium. And I think that what ends up happening in interventional cardiology is too many people get wedded to one option. They use their one thing all the time. And that's not the way we should practice. What we should practice is use the tool that's needed for the right lesion and the right patient at the right cost at that time. And I will tell you that the most frequent tool that we use for calcification is, in fact, the NC balloon. We don't take compliant balloons because they'll have differential expansion. They won't expand in the calcium area. They'll overexpand in the non-calcified area, and that can be dangerous. But certainly NC balloons, they're cheap and they're very effective in many cases. And I'll show you some examples of that. In terms of using other tools, we'll show specific reasons and why you might use them. But I'm not saying that use this for only everything. I'm saying think about the lesion, look at the imaging, and then figure out what the patient needs. There are many algorithms out there. Many people commit these to memory, but I would say that the most important thing, number one, is to identify the calcium, what the extent is, and number two, did you cause a fracture? And so this is just an example of what a fracture looks like and how that's so important. Basically, this is an OFDI image where you see this concentric calcification. If you try to expand a stent without cracking like this, without this crack, the stent's not going to expand. It's just going to expand to this circle itself. Once you have this disarticulation, if you will, of the calcification, well, now the stent can expand bigger. And this study showed early on that if you got fracture, you more frequently will get better expansion. Now, there are other scores to sort of predict, can you get fracture? And this is just the one from our lab and the St. Francis Collaborative that showed that if you have a greater angle of calcium, a greater thickness, and a greater length, you're less likely to get fracture with a balloon, an NC balloon alone. There's similarly an IVUS system, which we published as well, basically very similar characteristics, length, arc, also the presence of nodule. And if the vessel is too small, it's going to be hard to get a fracture, and it's going to be hard to expand stents without the use of atherectomy. So in general, though, all these algorithms tell us when an NC balloon is not enough. So if you have a long segment of calcium with a lot of thickness in 360 degrees, well, then it's going to be unlikely to be able to get cracks throughout that whole segment with an NC balloon. But the corollary to this is that it also means that NC balloons may work in many cases that calcium is actually detected, and you should reserve your use of specialty devices for those cases that are at the highest risk. So let's just go through some cases really quick now. So this is just a patient who has this LED lesion. There's some calcium in the LED. And the question is, how do you treat this? And so many people just sort of guess and they say, well, I think I'm going to treat this way. So what we actually are doing is we've completed randomization in this trial, the Eclipse trial, and this patient was randomized to conventional angioplasty versus orbital atherectomy. And so we'll be presenting this hopefully at TCT later this year. But basically this patient was randomized to the balloon arm. So if you're going to do this with a balloon, the way you have to do it is you get a supportive guide, you get your wires down. We wired the diagonal side branch and we pre-dilated with a 3.0 by 15 NC. So a balloon that's not greater than 1:1. In fact, it's usually down a little bit, and we go up to 20 atmospheres. We then imaged it, and based upon imaging, what we tried to see is if we could appreciate fractures. And there's some fractures up here. I can try to pause it where we see it, but here, in this area here, you don't really see it. This is drop out of the wire. You don't see fracture, and the lumen is still constrained. And so the problem here is that if we had simply just put the stent in there, as many people would do, we likely would have under expansion there. So what we did is we went back more proximally and we sized it with OCT and went with a 3.5 balloon. And once we did that, we then were able to expand the stent adequately. Now, one of the problems with the ECLIPSE trial is that if we do all conventional balloon angioplasty this way, where we're confirming fracture, et cetera, you might argue we might get very similar results in this case as we might with a strategy of atherectomy, because most people don't do balloon angioplasty this way. But the reason I'm showing this case is because if you're going to use balloons, you have to do it in the right way. Confirm the presence of fracture, confirm that you're actually adequately sized, and in this case, adequately post-dilate. Even with this technique, though, you can see that there was a little bit of a hindrance of MSA here. It's still 5.7, so it's actually very good. But I'll pause it at the area right there where you can see that things are perhaps a little constrained, and that's because there was so much calcium on this side. The stent essentially expanded to the opposite wall. But nonetheless, we confirmed with OCT, and this is why we're doing the study. This is what the final result looks like. So that's a balloon-based approach, conventional NC balloons, size it, confirm fracture, and go from there. Now, there's some cases where you could struggle with a balloon or you could try using an IVL, but with long segment calcific disease like this around bends, you're going to struggle a little bit. And so this is the type of case where we took a more supportive guide. We thought we were going to have issues. And so we wired it with a workhorse wire, but actually even a microcatheter would not cross so well, even with spinning. And so, if you're going to struggle crossing a microcatheter, this is a case that goes straight to atherectomy. You shouldn't bother anymore. Your case will be a lot more efficient if you do it this way. Could you put in 1.5 balloons and slowly inch up and put guide extensions? You could, but it's going to be a lot more work than just doing atherectomy. So in this case, we actually thought of doing this. And there used to be this term roto-regret. And the idea of that was if you think about it, and then don't do it, you learn to regret that. And I think it's still true. And in a case like this is a perfect example of it. So there are two different roto systems. There's Roto Pro. There's actually the old rotoblader with the pedal at the foot. They don't sell that in the United States anymore. I wonder if they probably still sell the old roto in India. I don't know, but I like the old roto. It was fine, but this one's an upgrade, and you don't have to use your foot. And then there's the CSI, which is the Diamondback, and this is all based on the table as well. There's strengths and weaknesses of both. I think personally, it's best to know how to use both because I use both routinely. But nonetheless, that's beyond the scope of this talk. The idea here, though, is you need to understand how to exchange and how to do these basic techniques. And so we remove the Xian blue. We then exchange for the atherectomy wire, whether it's the Viper wire or the roto floppy. That's advanced through the microcatheter. We'll be careful that we don't poke it out the end. We then remove the microcatheter and then do atherectomy, and then we exchange for a supportive wire, in this case, a wiggle wire. Now, after you do atherectomy, there's a lot of talk out there, rota shock, rota cut, all this stuff. The old-fashioned way of doing this, and remember, it's cost-conscious as well, is just take NC balloons after atherectomy, dilate 1-to-1 and make sure it actually dilates. And you can even IVUS then to confirm that you have a fracture. Frankly, that works really, really well. And it's worked really, really well for 20, 30 years. So there's no reason to start spending a lot more money at this point just because something has a really cool name. So in this case, we protect the diagonal. We take the NC balloon, go up high, make sure we have expansion. We would typically re-image there and make sure that we have fractures throughout this vessel, that the IVUS going back in. This is what it looks like. I'm not going to go through it in too much detail other than to show the calcium is actually pretty eccentric. There's some areas where actually there's not a ton of calcium. And then in the areas where we see some disarticulation, we know it's going to expand. And then basically we try to stent. Now, in this case, you can't really advance the stent easily, so you still need a guide extension. So we put a guide extension down, stent is deployed, and then, sorry, this is the final after post-dilatation and final IVUS confirming everything looks fine. So what about other types of cases? So this is the case, again, that like the first one I showed, underexpanded stent in the proximal RCA. You have a stent here. We can start with NC balloons first, but when we image it, we see how severely constrained this is. Right here, the stent, there's neointima in this area, but the stent is constrained and there's calcium behind the stent. And so this is actually, in my opinion, even though it's what's called off-label, an ideal case for IVL, because with a single layer of stent, you typically should be able to crack the calcium behind the stent. I'll be honest, with double layer, triple layer, it's hard to actually reach that wall. But in this particular case, after we did IVL, it actually looked like there was almost like a bomb that went off inside the vessel in this area. And clearly you see calcium fracture behind the stent here. So that expanded very well. And then at that point, we basically ballooned further and got great expansion. The MSA is actually, quite large in this area, which was the underexpanded stent. Now, in the United States, we don't have drug-coated balloons. In India, you do. So I would probably have done this with a drug-coated balloon at the end. Here, we didn't have that, so we just ballooned it in. Actually, the patient's done very, very well after that time point. There are other cases where IVL can work very well. This was a case recently, an 83-year-old guy. He actually had a very, very severe lesion with a nodule at the distal left main. You can appreciate the number of branches here. But interestingly, if you look in this view, you'll see what this distal left main and the osteo-LAD and the ostium circum look like. Now, historically, this is the case that we would have done atherectomy in both branches. The challenge is it was actually very difficult to wire, and so the wire into the circ in particular. So what's your strategy here? Well, we did something a little bit different, and I'll show you what we did. Basically wired everything. It was very difficult to wire the circ and even advance a microcatheter into the circumflex. We wired the ramus as well. And after IVUSing from the left main and the LAD back to the left main, you'll see there's eccentric calcium here, a big nodule here, and that's the circ coming in. So the nodule is basically, if you look here, right where the circ wire is coming in. The nodule is here, the circ wire is coming in here. So what I thought might work is if I did IVL and sort of cracked this nodule a little bit and broke things up a little bit, maybe that would open room for the circ. And so basically, here's the IVL in the left main, the LAD into the left main. And after IVL, I don't know if you can appreciate, but this looks actually more open, and this certainly looks better than it looked as well. And so we went back, and here's the IVUS once again from the LAD coming back into the left main, and you'll see this. There's a nodule, and now there's a wire of the circ, and that area got pushed aside, and so now the ostium of the circ is more open. And so with that in mind, I thought the patient's 83 years old. Maybe we can just now easily balloon the circumflex and simply just cross over. And that's what we ended up doing. And so here you see there's wire in the circ, that ostium is more open than it was. And then after doing this ballooning, the circ is actually pretty wide open at the ostium. And so ultimately just stented from the left main into the LAD, potted. And then here's the final IVUS that comes back from the LAD into the left main, which basically shows that your LAD is, this is distal, now the LAD stent is here. As we come back further, there's that nodule, that's the ostium of the circ. There's a little bit of malapposition here, but that's okay, this is still big, and everything looks fine, and the area was large. So this is the final result. You can see the circ is wide open and the LAD was stented. So this is the use of IVL to facilitate nodular, the nodule moving aside. You don't need IVL for every nodule. In fact, balloons, NC balloons, cutting balloons may work very well. But in this case, I figured I wanted more bang for my buck, specifically at that area to open up the ostium of the circ. The final case I'll show you really quickly was a learning case for me. I think I've showed you imaging on every single one of these cases. The reason is because it's not just to make the diagnosis, it's to prove that we've done what we needed to do. This is a patient that came in with a presentation where the anterior forces were down, came into the ER, had an echo that showed an EF of 20 to 25% and akinesis of the anterior wall. There was no thrombus. We actually did a right heart cath because the patient looked like they were in some heart failure. Overall, the patient's blood pressure was low, but they were generally compensated. The wedge was up a little bit. Here's what you see. That's calcium, not stent in the LAD. The LAD is a large vessel, completely occluded. The circumflex isn't that big. You can appreciate here, it really just supplies the marginal zone, but the whole LAD is out. And then this is the right coronary, showing this large, nasty thing in the mid-RCA, and that supplies the rest of the RCA and also collateralizes the LAD. So we actually stopped, took the patient off the table, discussed with surgery, got a viability study. There's no viability in the LAD. And the reason we did viability, whether you believe the data from other studies, was to prove that it didn't make sense to send this patient for bypass surgery if their LAD territory was dead. So I do still think that there's a room for viability in these cases. We ultimately opted to intervene, and so you can see the output's not great. And so we used hemodynamic support in this case, even though the hemodynamics tended to be a little bit better when the patient came back. Did basically an AL guide, and I was worried for reason I did hemodynamic support is the circ is small, and I was worried that whatever this was going to be in the right, if we caused problems and had no reflow, the patient would just, not do well. And so actually ended up doing atherectomy up front because of this issue of the roto regret. Turns out the wire crossed, the microcatheter crossed pretty easily, and that should have been a sign, because when I did atherectomy, really you heard no sound and it flew through the mid RCA. And the reason it did is because when we took a picture post atherectomy, you see things look maybe a little bit different, but when we imaged, it actually wasn't calcium at all. It was thrombus. And many of you may have guessed that already, because I know there are many more ACS presentations that you all see. But for me, it looked all the world like this was going to be calcium. It turned out to be thrombus. And in fact, we did thrombectomy, removed it. And then after that, it looked better, and then ultimately just stented. So the reason I show this case is, and why am I showing thrombus in a calcified lesion case? Well, because sometimes the two can be mixed up, and you have to, in your mind at all times, think, is it thrombus? Is it calcium? And then if it's calcium, the way to treat it. And so this ended up being a very good result. Patient tolerated it fine. I was happy I had the support device, because if we had embolized the thrombus, he would have gotten pretty sick. Basically, to conclude, I think number one, calcium is more and more prevalent in the modern day cath lab. This is the era where we sort of medically manage a lot of patients up front. So when they come, they're more advanced disease states. They're on statins that actually hardens plaque, causes an increase in calcium. There's an aging population with comorbidities as well. So we're seeing more calcium. They're among the highest risk lesions we treat, highest rates of short-term pain and suffering that we all struggle with, also risk of the procedure, and then worse long-term outcomes. We know that there's greater incidence of stent thrombosis, also restenosis. So we have to do a good job the first time around. The way we do that is, I think imaging is a must. If you see severe calcification and you're trying to decide in your cath lab when to use imaging, when not to, use it for these cases. You don't have to use it for every case, but for these cases, especially heavy calcification, use it. You'll usually know the calcium's there, but you can diagnose the type of calcium, decide which strategy to use, and most importantly, confirm that you have a fracture after you go in with the NC balloon. Because if you do that, you might not have to, you may save on the IVL balloon. So you spend money on the IVUS, but you may save on the IVL balloon, or you may save on the atherectomy, depending on what you do. These algorithms are based upon length, arc, and thickness, but they're all predicated on trying to modify that calcium so you can expand the stent. And I will always go back after the lesion prep with the IVUS to be sure that we've caused this fracture. And then finally at the end to check your work. And then the last thing I'll say is calcium is an area of hot interest right now. There are many trials coming out, new devices. As I said, we'll be presenting Eclipse later in this year. So I think that there's more data emerging soon, and that makes things exciting in our field. Happy to take questions at this time. Sorry I went a little bit long, but I hope this was what was useful to you.
Yeah, thank you. Great talk, Ajay. Actually, his case-based approach clearly highlights what to do in many of these scenarios. We have a lot of young cardiologist colleagues here, but it was enlightening. It was enlightening even to very senior professors who are sitting along with me here also. But I think before we ask others, I wanted to ask you one. Our decision-making goes on imaging, but sometimes we find it difficult to take these imaging catheters inside because of calcium. Can you just tell what are the tips? Each of us could have one body wire, things like that. But what is your approach where you're not able to take the guiding imaging catheter inside? Can you tell us some of the tips and tricks you use?
Yeah, so one thing I don't do is, if it doesn't go easily, I don't try to force the imaging catheter down. I make because you can get it stuck, especially with very short monorails with the higher imaging, higher density, higher definition catheter. And if you're taking the Volcano Eagle Eye, it's so bulky that it's not worth pushing it through, and you can dissect and cause problems like that. So what I tend to do if it doesn't cross is it really leans more heavily towards atherectomy. Because that's going to be the most efficient way to debulk the plaque and do things that way. Now, there may be cases where it looks more focal, or the vessel's larger and it just doesn't cross because of angulation. In that case, I would probably balloon it first, and then maybe re-image it. But if you're looking very quickly to see if the balloon is expanding, an NC balloon, and if the NC balloon is not expanding, or the NC won't go, then you're used to going with lower profile balloons, then I would tend to default towards atherectomy. And I think that's honestly why younger interventionalists, you need to know how to do atherectomy, because if you don't know how to do atherectomy, there's just a segment of cases you're not going to be able to do, and you may get into more trouble. So everybody will tell you that, irrespective of what strategy you use, that you need to do that. Now, there may be more technologies coming on the horizon, sort of forward-facing IVLs, things like that, but we don't have them yet.
Orbital atherectomy looks little more user-friendly to me. What are your preferences? When do you prefer orbital versus root ablation?
Yeah, so actually, I just was asked to write a debate in neurointervention on orbital for most. That is my strategy. I do find that orbital is easier to use. It can be done in a 6 French. It can be done through a guide extension. But there are people who are so familiar with rota that they find it's harder to use orbital because they're just not used to using it. I think for me, I tend to default to orbital. The reason I do that is because I feel that there's less hemodynamic instability with it, but there are cases where I don't use it. And those cases are very tortuous anatomy, because it orbits. If it's very tortuous, you can certainly run the risk of causing a very deep cut or even a perforation. You can also do that with rotablator, but I think rota is a little bit more controlled that way. I think if you're in the subintimal space, that's also an area where I would favor rotablator. And then finally, if it's in stent, you have to do stent ablation, those are cases where I would favor rotablator as well. But again, I think it's better to know both, because then you can pick what you need for a specific case. And there are other cases where there's an angulated segment and you want to be really precise with the ablation. Rotablator is going to be preferred hands down. They've also made some improvements to the rotablator with wire, et cetera, that make it the RotaPro that make it easier to use too.
Rishi?
Yeah, hi, Dr. Ajit. This is Dr. Rishi Sethi. So, for the benefit of our younger audience, what will be your tips and tricks for a nasty-looking nodule on intravascular imaging? So, how do we approach that? What are the various options and tips and tricks?
Yeah, so first with nodules, I will tell you that I'm going to be honest. 10 years ago, I didn't even use the term calcified nodule. We just thought it was calcium. We call it nasty calcium. I think the reason that we're starting to recognize more and more about calcified nodules is because we used more OCT in imaging, and then people started describing it. And of course, in our cath lab with Akiko and everybody around, we start talking about it. I think though, if you're good, you can actually tell it's going to be a nodular calcium lesion without even using the imaging. You can sort of just see the appearance and know the protoplasm of the patient, and you say, I think that's going to be a calcified nodule. And you put the IVUS down or the OCT down, it's a calcified nodule. So I think you can train yourself to see it on the angiogram if you know this concept exists. So that's the first part. The second part is, it's interesting. Many times you'll see a nodule, it might not even be flow limiting, because the nodule's all on one side, but there's room around the nodule, around the sides and on the opposite side. So I personally think it's good to use liberal use of good clinical judgment. So if the patient's not that symptomatic, just because you see this hunk of calcium, you don't necessarily have to treat it. And the reason I say that is because calcified nodules, even more within calcium, often come back with restenosis, reprotrusion, all kinds of problems. And so we try to treat them and we think we did a great job. And then 3 months later, the patient's back with the nodule coming through the side of the stent. So make sure you're treating it for the right reason. In terms of how to treat it, there are a variety of strategies. I think that right now, nobody knows what the best strategy is. There's a lot of marketing out there for specific technologies, but we don't know in a comparative sense if that works any better than a balloon that just pushes it to the side, or atherectomy. What I would say is, if the nodule is really bad, it's protruding into the lumen, and you can't get things past it, it typically is going to use atherectomy of some kind. If you can get past it, you can try cutting balloons, you can try IVL, that kind of thing. But just remember that there's a pretty high chance that the nodule is going to reprotrude back through the stent. So just be judicious about what you do.
Rajesh?
Yeah, very nice presentation. I'm Rajesh from PGI Chandigarh. Two comments of yours. One is, do we supposed to chase the calcified nodule, or it's the MSA, which is important after the PCI? Second is regarding efficacy of NC versus scoring balloon for calcium fracture. In few of your cases, you prefer to go out for the NC balloon instead of scoring balloon, and then it's literature where it's well proven that the cutting balloon is the one which is going to have more of stent fracture, more expansion, and more MSA compared to NC balloon.
Yeah, so first about the nodule, I think your point is actually absolutely right. You're not chasing the nodule itself. You're never going to get rid of the nodule. You're really trying to get your stent the full MSA and then hope that the nodule doesn't re-protrude. So that's a really, really important point. The point about the specific NC and cutting balloons, I mean, I would actually say it's well proven for an overall sample that you'll get a slightly higher MSA with cutting or scoring balloons. But what you don't know in that distribution of patients is which individual patients that's driven by. So there may be many patients in whom the NC balloon works fine. And the reason the data looks the way it does is because in the 5 patients that are driving the mean up, that cutting balloon or scoring balloon work better. So I do think in general, you'll get a larger area with a cutting balloon across a population, but it may not be that every single patient needs that. And you can actually measure it, where you can actually look at the IVUS afterwards and see, did you get a fracture or not? So, and remember also, cutting and scoring balloons don't always deliver as well as an NC balloon works. So my practice, what I tend to do is I use an NC balloon first and then assess what's happening because the NC balloon is very cheap. And then if I need to use a cutting or scoring balloon, I will use it subsequent to that point. So that's, I think, a reasonable way to approach it. We're also running a randomized trial right now looking at cutting balloon versus IVL because of the cost difference of the two things to see whether that makes a difference. So there'll be more data right now, but I personally think if you go into the studies and look at the comparative studies, the data is not as strong as you might think, but we need to do more. Even the COPS trial, which came out not too long ago, that's using a cutting balloon at 20 to 22 atmospheres, which is not what most people do. Most people take a cutting balloon in and they put it up at 14 atmospheres and they think that they've done a better job than an NC balloon. I think if you randomize 14 atmosphere cutting balloon to 22 atmospheres, 26 atmosphere NC balloon, frankly, they'd probably look pretty similar.
Is there really a concern about having the dissection with the NC balloon, which is going to be, say, 70-80% of the artery size, and then not able to go the rota instead of, say, going for the smaller NC balloon and then to go for that?
Yes, exactly right. So you don't want to take a 1-to-1 NC balloon and go up to 26 atmospheres and have a dissection because you can rota through a dissection, but it's not a fun situation to be in. So what you typically need to do is you take the half size down, go up to high pressure, and then see what you're dealing with at that point. And by the way, you'll know very easily when you're going up, is it expanding or is it not expanding? And if you don't see it expanding, okay, then you know that you need to do something different.
Yeah, so one more thing I would like to come back to the conversation about rotablation versus orbital. Despite the fact that the ease of use and the safety is a little higher with orbital, but whatever limited experience we have with orbital, and forgive my naivety, we have very few cases. Personally, I feel it looks like a little weaker cousin as far as the aggression of plaque modification is concerned. Do you share the view about it being little weaker in terms of the aggressiveness of calcium modulation, or is it my naivety?
No. I actually think when I first started doing orbital, I think I was not certain it was doing anything because things seem to actually, that's funny. So Sheila's calling me at the second. Just give me 1 second. But I basically I would go through and I said, did it do anything? But it turns out because it not only does it ablate this way, but it also kind of goes like this. When you actually go in with an NC balloon, you get the same fractures, and that's what you need to have. So I actually think that when we don't have good comparative head-to-head data, but for atherectomy type cases, in my experience, it actually does very similar things. Sometimes also people feel that it's not going to cross because it doesn't have a front cutter on it. It many times does cross because it's spinning, and so that defeats the friction of the system. But there are cases where it's so stenotic that it's not going to cross, and those are the cases where you need rotablator. I also don't know if it is truly safer than rotablator. That I'd be a little bit caution on that, and that's why also, especially on bends, I think the rotablator on a bend is probably safer than orbital on a bend, but I don't have the data to prove that. One thing you do also note with orbital is because it orbits, there's a chance that you can actually disrupt normal tissue. So you don't necessarily get the effect where it only ablates calcium. And by the way, rotablator on a sharp bend can do that too. Rotablator on a sharp bend can even cut the wire. So I think that The problem right now is not people don't have enough experience with any technology to necessarily know all the pros and cons. So if you use something a lot, you know exactly when it's going to fail, when it's not going to fail, and that's the advantage of using one thing a lot. I do think, though, as we see more and more calcium, though, there's room for both, and as you do it, you'll see that there's advantages to each.
We do see, Rishi, that it creates a good lumen. Ajay, actually, we are at loss before for osteal LCX lesions. Of late, we started using orbital atherectomy to osteal LCX, and then probably, if needed, a Wolverine type of balloon, and just do a regulating balloon and come out without getting into complex bifurcation strategies and all. This is working out quite well, I feel. LCX isolated osteal lesions, we're just doing an orbital atherectomy, then followed by regulating balloon and coming out without stent. Hopefully, it should work. We don't know. You have
Well, you should publish. You should definitely publish it. The one thing about osteal circ that you have to be careful is you often want to go in and then ablate on the way back, because if you go in, you can get a very, very deep cut if there's a straightening of it. And the same thing can happen with rotoblader. You have to, one technique with atherectomy, very important, is once the atherectomy wire is down, take a cine with dye and look at where the wire is in relation to the vessel, because if it's very tortuous, sometimes the wire almost looks like it's outside the vessel. That is a strategy or recipe for perforation. So just be careful.
Thank you. I think any other questions from, yeah. Now we have Dr. Anil Sharma from Mumbai. He wants to ask one.
Dr. Ajay, good morning. In the small question, in underexpanded stents, which patients you use high pressure balloon or open balloon, and which patient you directly go to for the IVL? Because IVL is very costly. Now the new this thing is 3.75 lakh is very costly here. So which patient IVL?
It's even more expensive in the United States, but I would never go directly to IVL. I think it's the most effective way of doing it is you go with the NC first and see what happens. Then if you need to, then you can use the OPN, and if it doesn't, or choose OPN versus IVL at that point. My sense, though, is that if it's multiple layer, then you're probably going to have to go more OPN than IVL, just because the shockwave doesn't necessarily penetrate through the multiple layers of stent. But yeah, I don't think there's anything wrong with, and that's why I'm similar to the question about the cutting balloon. I don't think there's anything wrong with using an NC balloon first, because the balloon is cheap, and it may work. If it doesn't work, then as long as you haven't caused a major dissection, you can typically quickly go up to the other strategy.
Dr. Shastri, sir?
Yeah, it was very good talk. Thank you very much. I have a couple of questions. One is there any role of CT coronary angiogram before planning how to deal with calcified lesions? Number one. Number two, talking about the NC balloon versus cutting balloon. Suppose you you change the sequence. First, use a Wolverine cutting balloon. You have a controlled dissection. Then do a high pressure normal NC balloon for long time. The results may be better than first using a NC balloon and then going for cutting balloon.
Yeah, what was the first question again, really quick?
CT, role of CT.
Oh, CT. So CT can be useful because it can give you a clue as to what may be going on. There are some studies looking at, can you look at the CT thickness of calcium and then predict the use of atherectomy? And it's hard. We don't know yet. So, but I think that's going to be emerging. Many more patients are having CTs nowadays. So, but I think that if you see somebody with a calcium score of 4,000, you know going into the case that you're probably going to have to do something more aggressive in terms of plaque modification. I don't know if changing the sequence would matter. And frankly, if you think about it, for most cases, the cutting balloon doesn't deliver the same way as a regular balloon does. So I think in real practice, it's more common that you try to get the cutting balloon there and it doesn't necessarily go, but then you don't want to inflate it, because once you inflate it, it's certainly not going to go. So that's why in clinical practice, it ends up being a balloon first, and it may be just even a compliant, and then the cutting balloon next. I'm not at all opposed to using the cutting balloon up front. I think that's fine. I just think in a cost-conscious environment like yours, that might not be the best strategy, just because if the NC balloon is going to work 6 out of 10 times, then you've saved the cost of 6 cutting balloons.
Agreed. I think in India it is applicable, Shastri sir. We also agree. And Regarding the CT, I feel, Ajay, it worries us a lot. You feel large chunks of calciums on CT, but many of the times when you go to lab, you will be able to manage those things.
Yeah.
So that is why it worries us. Anyway, thanks for your time and a great talk. We really appreciate a big round of applause to Ajay because he has to go to his work. And always a great support. And many of you know already, but this happened during our last TCT time. Ajay got promoted, elevated as chief of interventional cardiology in Columbia University. Big round of applause again. And in spite of all his things, he still supports us. And even it is a fellows course, still he made it a point to come and take his time. And thank you very much, Ajay. And we really appreciate your help always. Thank you.
Thank you so much, sir. So before we move on to the next session, so we have a short felicitation ceremony. So first, I would request Mr. Rohit Mandro, sir, to please felicitate our course coordinator, Dr. A. Srinivas Kumar, who has designed a very thoughtful agenda for these 2 days. So I would request you to please wait. So I would request Mr. Jaideep from Life team to please take the further proceedings.
Sure. Thank you, Dr. Vivek. I am sure you all are waiting eagerly for the next scientific session. But before we move ahead, a short ceremony. We represent to call our CEO Siddharth from Lupin Digital Health and senior leadership team members here, Rohit Mondo, Rohit Nair on the stage, and also our faculty members, senior faculty members here. It's a short ceremony where we want to really acknowledge the contribution of Dr. A. Srinivas Kumar sir, because he's been recognized by ACC as a digital pioneer in India, because he has been adopting the remote cardiac rehabilitation to serve more number of patients and to help and bring better outcome in patients. So if I can call the senior leadership of Lupin and all the faculty members to kindly felicitate sir and hand over the certificate from ACC to sir, and that would be great. Yeah, thanks.
Yeah, thank you, Lupin, for this. But this was a surprise to me also. Honestly, the doctors here shouldn't mistake. I didn't know this, that they were doing this. And I always felt there's definite role for digital monitoring of cardiac patients. We know histories where there were sudden deaths happening after PCIs, after the myocardial infarctions, after heart failures. So that's personal approach, and probably you have many newer devices coming up, and Lupin, one of the pioneers in this, and took it forward. And initially, they were very helpful to patients also, even though they're not paying. When they requested, they were helping the patients, and maybe could actually save some patients from getting into trouble using this technology. That's how I got interested in it. And I didn't know that ACC something was being given. Anyway, thank you, Lupin. Once you take up something, you will not leave it. Thank you again. We'll proceed with further talks because doctors are again waiting, I think. We'll have interesting talk. All of you must be waiting for to hear Professor Rajesh Vijayvargiya sir. He's actually very passionate about imaging and physiology. I requested him to cover up little basics regarding that for the sake of all the fellows. Please come.
Okay, so imaging and physiology. Angiography and intravascular imaging has the limitation to assess the functional significance or ischemia of a particular coronary lesion. And then FFR is the one which can accurately identify lesion which is responsible for ischemia. What is FFR? FFR is basically a maximal achievable blood flow in the stenotic coronary artery distal to the lesion, and which is divided by the maximum blood flow in the same artery without stenosis. So it's basically a pressure distal to the lesion, which is over here, and then a pressure PA, which is at the aorta level, and this is what the FFR value is, and this is always been with the maximum hyperemia. And most when there is no stenosis, it's a normal. The FFR is going to be the 1. So your P distal pressure distally and pressure at the aortic level is going to be equal. And when there is a stenosis, it's going to be say less than 1. In this case, it's 100 over here and the 70 millimeters. So it's going to be FFR of 0.7. Less than 1 is the one which is having the stenosis. It's also important to look for how much is the perfusion area distally, and with this say 60% of the lesion over here, in both the condition, the pressure is 60, turn out to be say 0.6 FFR, vis-a-vis pressure is 85 because of the small perfusion area distally, and the FFR is going to be say 0.85. Hence, it's very important that a small vessel like OM2 or OM3 or a diagonal D2, D3, which has a small distribution area, doesn't require any intervention when the main vessel is going to be intervened for. Now comes the same area, but then in case there is the scar tissue, then it's again going to be the FFR, which is on the higher side and doesn't require. So it's a FFR is basically the ischemia, which has to be demonstrated. And whenever there is a old myocardial infarction, the area is infarcted one, there is no need to go ahead for the intervention, despite having the similar area of distribution by the epicardial coronaries. How to achieve ischemia? It's adenosine or piperacillin. Most of the time, it's adenosine being used for the intracoronary injection, which is a common practice. 100 microgram for the RCA, 200 microgram for the left coronary artery, and the peak effect do come in 10 seconds. And duration is for about 20 seconds. In case it's an intravenous infusion, it's a 140, which can be increased to 180 microgram per kg per minute infusion. The peak effect do come in a minute and then wean off in a minute time. The main side effect, which is very important to observe about, is the sinus bradycardia, sinus arrest, for which one has to be ready with the atropine or the cough reflex, and then the bronchial asthma. And these are the various steps to go ahead for the FFR. You have to have a calibration. The aortic transducer should be at the level of the heart whenever you are going to have a pressure tracing. And then you have to connect this wire, whether it's wireless or physical connection is there, and to be followed by equalization of the pressure of the FFR wire in the aorta. with the catheter directed pressure, and then you proceed for pushing the wire across the lesion. There is a concern about say non-hyperemic indices and their efficacy to have an idea about how significant the lesion is. I would say that FFR, which is after the intracoronary adenosine with the maximum hyperemia, is the gold standard to demonstrate the ischemia, and the rest of the things, whether it's resting PD by PA or IFR, these are all having the accuracy of less than say 80 to 85%. And what's the guideline for the chronic stable angina? Definitely, there is a need to go ahead for the FFR to assess whether the significant lesion is there when it is going to be say 50 to say 80% of stenosis, and then one is supposed to demonstrate that, okay, this is functionally significant prior to going ahead for the intervention. And what about the acute coronary syndrome? Yes, for the non-culprit vessel, there is a need to go ahead for the FFR, and those with the culprit ST elevation MI, there is no need for the FFR because it's going to be fallacious. ST elevation MI, which is the older one, there is a concern about the scar tissue. But then it can be done, say, after 3 to 6 months of myocardial infarction. And those with a non-ST elevation MI and the culprit vessel, there is no need for the FFR because you are dealing with something else, maybe ulcerated plaque and significant luminal loss, which can be very well assessed with the imaging. Few word about the intravascular imaging. There is a role of intravascular imaging for the pre-intervention just to assess the plaque characteristic, to decide about which line of action or which intervention is to be done. Post-intervention, post-stenting, it's about the optimization to look for any stent as dissection, and at the follow-up in case you do have a stent failure like in-stent restenosis or stent thrombosis, to look for various technical reason which is predisposing to have late complication of stenting. What is IVUS? It's basically the processing the sound wave with this catheter. Sound wave been sent to the arterial wall, and it's been again received back and been transmitted to the electronic system to look for what the characteristic of the plaque is. These are the demonstration of the three layer of the arterial wall: intima, media, and adventitia. Intima is dense and will appear like white. Media is the equilucent, appear somewhat black, and the adventitia is because of the collagen, high collagen tissue is again going to be the brighter in color. How to differentiate various plaque for the fatty or the soft plaque? It's going to be the equilucent. Fibrotic plaque is eco-dense, and the calcific plaque again is highly ecogenic with the bright ecos and acoustic shadowing. So between the fibrosis and the calcification, it's more brighter for the calcium compared to fibrotic plaque. So in this particular case, the diagram shows about the eccentric fibrous plaque, and then you have the equilucent area, the black area in the plaque, which is very much suggestive of the fatty area, and therefore it's a fibrofatty. Here at the 6 o'clock, you can very well appreciate the highly ecogenic foci, which is suggestive of calcium, along with the fibrosis. Another diagram did show the calcification elsewhere as well, along with the fibrocalcification. This is the calcified plaque over here, and then this is the diffuse calcified plaque along with the fibrofatty tissue. And then, as Dr. Ajay Kirt again has mentioned about regarding the atherectomy, a arc which is more than 180 degree, and the calcium length more than 5 millimeter is the one in the IVUS, which do require aggressive calcium modification in terms of say rotablation or other atherectomy devices like and this is about the post stent with the IVUS, well opposed stent over here, and the mal opposition at this point, which can be very well appreciated with the IVUS. And this is about the calcified nodule, which is protruding, but then the stent is well opposed, which is well demonstrated with the intravascular ultrasound. This is about the dissection following following stenting, and then you can have the flap of the intimal flap over here. And this is the point which is very much suggestive of the dissection. Something, a few word about the OCT. It uses infrared light to create high resolution image of the tissue microstructure. And this is the OCT catheter, which do run like this in situ to look for the plaque morphology. And they are the two which is also there with IVUS B mode and also the L mode. L is the longitudinal and is the cross-sectional view is the B mode. And then there are few technical terms which has been commonly used for the OCT. Back scatter is the one that's the reflection or light wave of the tissue and back to the catheter. High back scatter means a brighter pixel, and low back scatter means a darker pixel across the lesion. Attenuation is again a commonly used term with the OCT, a reduction in the intensity of the light wave as they pass through the tissue due to absorption of or scattering is the attenuation. The high attenuation means the light cannot penetrate very deep, and the low attenuation means the light can penetrate deep into the lesion. This is about the normal arterial form with the three layer: intima, media which is somewhat darker, and the outermost is the adventitia regarding the edge or border. Border can be differentiated with the OCT when there is a change in the plaque characteristic, and in this particular case, the calcified border is very well demarcated, while it's a lipid border which is less demarcated. And this is the way to differentiate between the two. Fibrous is highly would say brighter pixel is there with a signal reach, and a high back is there. You can very well have a penetration of the light across the lesion, which of course is not there with the fatty plaque. Calcified lesion, very well demarcated, heterogeneous, and the light can travel across the lesion. And these are the few characteristics of the individual fibrous lipid and the calcium plaque. The way to differentiate between the three. The red thrombus is the one which is very bright with the high back is tethered imaging, while the white thrombus is the one which is having the low attenuation. It's a brighter, and you can very well see back to the thrombus. The wall or structure is very much clear. This is regarding the edge dissection, which is well demonstrated with the OCT compared to IVUS, and these are the post PCI optimization, which is very helpful to decide about. Whenever you have put the stent, it's the MSA, minimum stent area, which should be say more than 4.5 centimeters square, or it should be say 80% of the mean reference diameter of the vessel which has been treated. Regarding the malapposition, when the stent is not well opposed across the intimal wall, any malapposition which is say more than 400 micron or a length of say 2 millimeter or more is the one which do require the further intervention in terms of say NC balloon dilatation. There should not be extensive protrusion or a plaque through the stent structs. And regarding the landing zone, the plaque burden should be less than 50% for both proximal and distal edge of the stent. And regarding the dissection, you do have a minor or the major dissection following the stenting. Any dissection which is covering the 60% or more arc and having a length of say more than 2 millimeter and depth which is extending up to the media is the one which require the further intervention in terms of putting a additional stent at the site of the major dissection. This is a diagram to show about the struct malapposition and undersized stent. And then there are two cases which I will like to demonstrate how this imaging and functional physiology do help. So this is a case of 65-year-old hypertensive with the chronic stable angina, EF on the normal side. And this is what the angiogram, the LAD, which is calcified, and significant lesion is there. With the LCX ostium, which is more or less okay. So let me go ahead for the next, and this is assessment of the osteal LCX prior to going ahead for the intervention for left main to the LAD. You have an IVUS across the left main to LCX to look for the how much is the minimum area across the ostium the LCX, which turned out to be 6.12. And what's the FFR? FFR is 0.96, so there is no significant osteal LCX lesion. And then he went ahead and had now PCI and stenting from left main to LAD after having adequate calcified plaque modification with the rota followed by the cutting balloon. And this is what the result is across left main to LAD. You can very well appreciate a small pinching of the osteal LCX at this moment of time. Now the question is whether it's a significant lesion or not. So this is the epicaudal. Epicaudal is very fine. Spider view, there is some pinching across the ostium of the left circumflex, whether it's a significant need for the two stent or not. And again, we had now I was done, which turned out to be having the area of 6.04 and also the OCT, which turned out to be the 0.89. So this is the lesion which doesn't require the stenting, and the result is fine after doing the left main to the LAD stenting. Another case, 77-year-old fellow with the chronic stable angina. This is what the LAD, left main to LAD, there is a calcified lesion, but angiographically, if you see, it's not looks to be so significant. And then here is the RCA. You see the mid part of the RCA, there is a tight point, and then on the basis of the angiography, it seems the RCA, which is the lesion to be taken care of for the chronic stable angina. And then we had FFR done across both the vessel. The FFR across the LAD turned out to be 0.78. For the RCA, it's a 0.84. And then had a left main to the LAD stenting with the rota ablation with a good result across the left main to the LAD. And we had now OCT also done across LAD and also the IVUS. So, sorry, also the FFR. FFR post PCI turned out to 0.92. Ideally speaking, it should be more than 85 to 90, just to rule out any as dissection, plaque protrusion. Following PCI here, the FFR again turned out to be good across the stented left main to the LAD segment, and you can very well appreciate in the OCT run there is a calcified plaque which is well opposed, fractured with a good area across the left main to the LAD. So take home message: imaging to help in PCI optimization and improve the clinical outcome. I don't need imaging. Angiography is more than enough in my intervention practice. It's a unscientific statement. Few of the interventions do comment about FFR guided PCI has a favorable long-term outcome, like the second case where he is asymptomatic at 4 years of follow-up, despite having the RCA, which is seems to be angiographically significant, but the FFR turned out to be negative, and he is doing well on the medical treatment. FFR is an important tool in catheterization lab for functional assessment of lesion. Side branches, when you do go ahead with the bifurcation, like in the first case, LCX was not so significant, even after putting the stent from left main to LAD, though the angiographically it looks like significant osteal narrowing of the LCX, non-culprit vessel in acute coronary syndrome, and those with a post-PCI optimization. A combination of intravascular imaging with functional assessment should be an ultimate goal, especially in a complex coronary intervention. Imaging and FFR are complementary, additive instead of substitute for each other. And if you wish to do PCI, perform imaging, If not, then have an FFR. Again, is a unscientific statement which commonly been used whenever some intervention to go ahead for the intervention. Thanks for the kind attention. Any question, comment?
Anybody wants to ask any questions, feel free. It can be more interactive. Any doubts, we will be happy to clear. My talk is also similar, so we will finish that and
Yes.
probably we can encourage discussion. Many of you would have doubts when to use IVUS, when to use OCT. That's why at least a clinically relevant decision making, I made my talk. After that, we'll have some discussion. Thank you, sir.
Please.
Connectable. Put something here this morning. Remove that. Okay. No. It's okay. Yeah, good evening, everybody. It was great talk, sir. And after following after you, I thought basically some clinical guidance I would like to give to the younger generation. I think sir has made it clear that it's no question of saying that imaging is not useful. My eyes can see everything, and all that dialogues are not correct, unscientific. He was very clear about it. But many of you feel you have OCT and IVUS, which one to prefer when you have some things. I thought I would briefly cover up those. And this slide brings best wishes from Apollo Group of Hospitals before and my fax professional service colleagues, and we cover in multiple hospitals. The display is not coming, why? I don't know. Anyway, so we have written one article in one of those books that didn't come out. If you want, you can go through that article, when to prefer IVUS, when to prefer OCT. I can give it there. And some of the articles written by Professor Rajesh sir also sent to you in as soft copies. I think this question, whether imaging is useful or not, I think should be best kept aside, because Greg Stone, in the recent ESC meeting, had got published also, compiled all the relevant updated network meta-analysis, which included 12,428 patients, and then included both OCT and IVUS studies and combination, and showed what it showed. It showed very clearly that imaging-guided PCI, be it OCT or IVUS, will come to that comparison later, decreases TLF by 31%, and the target vessel myocardial infarctions significantly, and then probably TLRs by 29%. 1/3 patients, it matters. But only thing is you have to do it in right patient, not for a type A type of lesion. But in the complex PCI scenarios, it always helps. I think whether imaging helps or not, that is no question, no discussion on that. Further, after this network meta-analysis in 2023. And then what it also shows significantly is nowadays we do very complex procedures, long stent lesions, and stent thrombosis comes down significantly by 52%, and all-cause death by 25%. Stent thrombosis is a dreadful complication, which we all know, which is decreasing by half. It has to be given proper credence to it. So that's why I want all of youngsters to know, go out with this data, that imaging is useful. Now that we have, I think we should go to slideshow. It's not projecting there. Many of the things are not coming. Yeah, I think now the various modalities, the basics have been covered by sir already. I won't go into details, but suffice to say that they're complementary. If you can afford, you want to have both in your lab, that's the best. You can use it when you want it accordingly. But many of the times, many of the centers are challenged financially, keep asking which one to be used, then those details we will see. But as you understand, the OCT resolution is very high, so anything more superficial, more detailed things, you see it better. But IVUS has more depth of penetration, so anything deep in the artery, you would see it better by IVUS. That is understandably so, no? Something which can see deep, you can see. Welcome, Dr. Sandeep Mishra, sir. So deep one, you can see better by IVUS. Anything superficial, where the stent endothelialized or not, such things will be seen very clearly by OCT. That is, I think, in principle, you should understand sensitivity, specificity are a matter of semantics, but basically both are equally sensitive. This, I would like to throw some importance on this. This is a SKY statement which came recently in 2023, showing applications of IVUS and OCT, which is again mentioning clinically relevant things. If you have to assess the left main disease, which is very big vessel, probably IVUS scores over OCT. And if you are de novo lesions, then what is that you are trying to see? If you want to see the thrombus, plaque rupture, dissection, which are very superficial, you see, which is just within the endothelium, those are all seen better with OCT. If you see what is inside the vessel, that is plaque burden or positive remodeling, vessels expand, and aneurysmal situation, those are seen better with the IVUS. This is a conceptual thing. If you understand, it is better. And aorto-osteal disease, many of the times we struggle to use OCT also in osteal lesion. I will show some one or two examples. It's not very great. Osteal lesions, that's where IVUS predominantly scores over OCT. Whereas if you see stent optimization, expansion, apposition, the gaps between the wall and the stent, seen it better. Again, it's a micro level, millimeter levels that is seen better with the OCT. And then inside the stent, neointimal hyperplasia, again, when the patient is coming with ISR, OCT has an advantage. But renal impairment, again, people try with saline, various types of other modalities to study with OCT, but I don't think you need to do so much struggle. And if you have a renally compromised patient, there's no doubt that IVUS is preferred. I want to be unbiased towards companies, as clear as possible for the youngsters' sake, as please. So osteal lesions and the renal impairment and the deeper structures are seen better with IVUS, whereas superficial things, minor dissections within the stent, ISR, what has happened and all, seen better with OCT, clear. And this also shows the types of instant response. It's mandatory now to treat ISR patients with imaging only. If you do not have imaging, it's preferable to send patients to a center where imaging is there, because decision-making happens depending upon what was the cause for ISR. That's very important. If you have a stent which was under-expanded, then probably if you expand with high-pressure balloons and probably make it more optimal, that itself would be suffice. And whereas if you have such sort of neointimal hyperplasia inside, neoarthrosclerosis, that's where you need to work on it, and that's where you might need to help of putting another DES or DEB. How you decide, we will see it. This is possible both with IVUS, which is shown here, and also with OCT, which is seen here, but probably OCT scores shows it very clearly. Then the thin cap fibroathyroma also, which is again superficial thing, is shown better with OCT. Now that we know some of those things, the trials were conducted with OCT IVUS trial. with the 2,000 patients, 1,000 in each group, and try to analyze what is the target vessel failure and myocardial infarction, TLRs with a little bit different at 1 year. Obviously, it is very difficult to produce any significant difference. The result came out is there's no difference in both imaging modalities in this OCT IOS trial. Then that is why don't go always by trial results. We develop our own protocols. That's why I wanted to just throw you some more clinical information and highlight which one you prefer. If you see, when are this imaging is used particularly, we have diagnostic dilemmas like whether borderline lesions, you can measure directly areas apart from FFR. And then you also have a plaque characterization where calcium is more, whether you have to use what type of cutting things and all, you'll all get decide by that. And the PCI techniques, again, can be more precise. Now, your exact size of the stent and the diameter. In a recent NIC meeting, I was telling, everything, Gary Mitch was there with me. We measured the length, we measured the diameter. So he exactly told what type of stents to be taken, how much to be deployed. It is only becomes very easy to take that size of stent and go there and deploy it and come out. So that sort of precision is possible. Exact length, you may say that most of the stents you can expand either higher or later. That way you can do whatever you want, but you have to do it right means you have to follow these precision techniques and do right thing to the patient. Then pre-intervention, post-intervention stent optimizations, whether stent is malapposed and all that, again, you take this help. And follow-up assessments with ISR type of dealing, stent endothelialization, we see it. Left main, again, it's mandatory. Bifurcation disease, again, preferable or mandatory to use in the scenarios with imaging. Then IVUS advantages, as I was mentioning, it's easy to acquire images. You can take it catheter inside, come out. You can repeat many times, no contrast involved. That way it is easy to do. You can do it in sick patients and patients with LV dysfunction, patients with CKD. There's no problem because you can always image and get it out. Image from the start to end, right from the guide catheter till the guide catheter comes, osteal lesions. Again, how much ever length, you can do that. And then because of higher penetration, again, the arterial wall and you see it better inside up to the media, you get better areas also to calculate the stent sizes. That's why there are algorithms created to size the calculation of diameters. It will become bigger with IVUS compared to OCT. I request Professor Sars and the senior Sandeep and all to excuse me because I thought to cover it basics even for sake of youngsters. Then IVUS can visualize deep and the plaque burden overall also is better. This, I think, a standard cartoon which you all know. The areas I wanted to highlight. Initially, it was told 5, 6, 7, 8, but that's the minimum what he said. Now you aim for a little higher. The bigger is the better. 6, 7, 8, 9, 10 is what we should get areas by IVUS. That came through IVUS. Again, disadvantages of IVUS are you get some sort of images because of low resolution. Sometimes you may not be able to identify everything. Normally, many of the times you run the catheter, IVUS comes out, but you have a little longer learning curve. Unless you keep doing it in more patients, sometimes it becomes challenging for you to interpret. But with a better quality HD IVUS catheter coming up now, this sort of thing is a learning curve, so also can be shortened now. And sometimes you face a struggle to take the catheter inside the calcific structures that is there even with OCT. So, but easy to do, but slightly difficult, longer learning curve, and you are getting experience. Clinical scenarios, as I mentioned, sick patients, severe erectile dysfunction, CKDs, osteal disease. Now, CTOs also we started sometimes to get an idea, zero contrast or low contrast PCIs. Anyway, you can't use OCT there. And some of the ectatic aneurysms. Please remember these. These are the clinical scenarios where we prefer using IVUS or OCT. Then I'll show you one or two case examples before I go on to OCT. See this, this is a very critical left main osteal disease. If you, some of these views, you may totally miss it. That's why Rajesh sir has covered in the osteal left main, what is the image angles which you use. Elevocranial shows the best. See that it's the tightest thing. The patient had sicker LV dysfunction, we have to use impeller. All that is not the point of discussion here. But see that sort of thing you may miss totally if the catheter goes deep inside. So we did IVUS, then it shows very clearly large of plaque burden, I think because of the light, you're not able to see. Huge plaque burden, once, if you run it slowly, it comes, the tightest lesion comes and then the guide comes. That means immediately after that osteal lesion it is, you can measure the areas and then probably decide on it. There are multiple steps involved it. For the sake of time, I edited it. And we have worked on the LAD here and then probably worked on the left main and then finally optimize the results and check post also. When you get circular areas and 13.5 was the area, the patient did well and follow. Another example is osteal RCA disease. Sometimes you get a doubt whether it is spasm. Then if you see imaging catheter, then the probably area was less and we addressed it by stent. Then you get good stent areas post. Then you have no doubt that sort of things by IVUS. We tried to do in a conference live demonstration because we are already taking OCT. The people are trying to, such out of OCT catheter, contrast doesn't get washed out. You take this catheter deep inside, and we are nowadays using this guide extension catheter, especially telescope, which has a radiolucent thing and goes inside and images a structure like this. So you still get, this is a telescope inside, you can still get into the artery and then image this sort of thing, but it's very difficult. I don't want to use to trouble and try all this. If you have IVUS, you can straightly use this. And then we coming to the disadvantages of OCT, as we said, sometimes it is difficult for it to use. It can't be used in LV dysfunction patients and CKD patients. But where is it preferable? The ISR type of situations, whether you want to study whether endothelialized stent is done or not, or stent is expanded, malapose or not, then this gives a very clear-cut images for us, for all of you, for easy to understand. And then for bifurcation, again, it's a great advantage, I would tell you, to have the bifurcation views and things like that for OCT. So stable patients and smaller vessels, bifurcation lesions, then post-PCA assessments and assessments of dissections is a OCT scores or IVUS, because very easy for all of you to understand and see. I will show you some case examples. The plaque morphology inside, again, what type of material it is, again, also is slightly seen better. And you see such sort of clarity like histology, whether intima, media, and all that, but deeper structures, it fails to show. Like then depending upon the plaque morphology, which is already discussed extensively, you decide the modality by depending upon what type of calcium you are getting it. This algorithm is also covered by Ajay already. This is another case example I would show. This acute coronary syndromes is another area where we tend to use OCTs nowadays. 31-year-old young fellow coming with this sort of ugly lesion. Now you see whether you have to stent it or not. You nowadays do OCT and then decide. See, we gave heparin, waited for 2-3 days to restudied him again, but still it was persisting. Then if you decide, if this sort of only rupture plaque is there inside, then probably you need a help of stent. It won't go away. If it is only like erosion without much of plaque inside, then you can get away without stent. So this was having that sort of plaque ruptures inside with a plaque there inside. So we had to stent it. And once stenting is done, you had a good result. So decision making will be done by that, and you can calculate areas and other things. If you have to see stent whether it is expanded or not, it's under expanded stents. Very clearly, you see compared to this, you see the areas are very minimal, crumpled. We have no doubt in saying that stent is under expanded there. We have criteria, 20% of under expansion is okay. But if still that sort of horrible under expansion with minimal areas, you would clearly dilate it again, get a good result. Some sort of this sort of malappositions, minimum 3 mm distance is okay. But if it's more malopposed, then probably you would work on it with again high pressure dilatations and you would get it. In that process, sometimes you could end up with edge dissections. You should be careful to keep it the balloon width inside. And this sort of dissections and intramural hematomas is very, very clearly seen with OCT. And ISR type of pictures, what type of material inside, I can't go into details. With one more talk, I try to show more of ISR pictures. The decision making is done by it. So one or two case examples of ISR I'll show, and my time is up. It says I'll close. This is out of patient presented initially, long time back history of MI, RCA was done. Now he comes back and then he had RCA occluded like that. Then you wire it. Then you do imaging. Wherever stents were there, that's why I keep telling that stents work well. When there is no stent, then probably had more occlusions. So the philosophy behind this is taking long time to run, but basic philosophy I will try to project it here. If you have a stent
in which there is a restenosis which has come, we try to avoid a second layer of stent, if possible, do a regulating balloon. But the lesion is de novo, where there is no stent before, that's where we tend to take the help of regulating stents again, second time. If the already DES was there, we just use a DEB after preparation. And where there's a de novo sites where it is not there, so entire artery, that is the principle. We worked on it and entire artery became normal. Again, documented everything by OCT. That final result came out well. This is another patient which is recently done. His distal LCX was stented. Here he had developed a one more lesion proximally. When we did this, looked very mild to us an angiogram. But when he did OCT, see that intra-stent, the areas are very less. So sometimes this could be misleading, especially the more distal we go. So this patient, we prepared aggressively. Here we did a DEB and here we did a stent. This was de novo lesion. So idea is if you can avoid the stent with the DEB, it is better. This is another 79-year-old patient, came back after 10 years with the places where the stents were not there, we did tests. And then when the patient's osteal lesion, again, this preferred, we used IVUS in spite of patient coming with post-stenting restenosis. So these sort of pictures we can just document at the end with little contrast and work without much of thing. OCT, a word about OCT in bifurcation. A lot of advantages. You can see the ostium struts. I think sir has already shown this, one of those examples. But when you're not dilating, sometimes patients come back. That's what we say. It helps in this fly-through views, such sort of amazing pictures you get with OCT. That's to conclude. Don't know. Conclusion didn't come. Oh, sorry, man. This is an important slide. I don't know why this is not projecting. Is it coming now? Can you show? Can you connect again? Can you project this? Last slide. Yeah. So if you have osteal lesions, CKD, severe renal dysfunction, sick patients, CTOs, do IVUS. Then if you have ACS, morphology of lesion assessment, post-stent, you want to see whether the stent expanded, mal or post, in stable patients, and also on work bifurcations, probably you could see OCT. You could be, but by and large, I would say 80% of the times you could get away with either of it. But there are some preferences which I try to highlight, which will help you in selecting which imaging in your day-to-day practice. Thank you again. This was a highly successful TCT India South Asia 2023. And again, in 2024 July, last weekend, we do it here. Request all of you to block your dates, and Lupin will help you to get you through that meeting. Thank you again. We can have some discussion if you. We are already running slightly behind the schedule. I think my colleague, Dr. Karnagar, also has to leave. If there's anything we have to discuss, we'll discuss. Otherwise, we'll go on to the hemodynamic chip talk. Any questions? Thank you.
Respected senior faculty members, colleagues, and my dear students. Good evening, everyone. I would like to thank Lupin for giving us this opportunity, giving me this opportunity. And a special thanks to Srinivas Kumar sir for inviting me to this great meeting. My talk is on hemodynamic support in CHIP. This is a very big talk, big topic. I would like to cover a few basics. So as we all know, there is a continuous evaluation on PCI technology and techniques, so that in our day-to-day practice, we are doing more and more complex cases. So this is a continuous process. So that is enabling us in our day-to-day life to deal with more complex cases in current recent times. So even that is statistically proven in AHA studies that nowadays PCAs are more compared to any other revascularization techniques. And we are doing more number of, almost in one of the analysis, double number of left main PCAs compared to previous decade. And there is significant increase in interventions on LV dysfunction patients, as well as we all know now we are doing more and more C2O cases by various technologies like antegrade, retrograde, and multiple techniques. So this this has led to a high-risk PCI is emerging as an valuable therapeutic modality in a in some patient scenarios, and in a population, growing population of patients known as complex, high risk, and indicated procedure, that is the CHIP. So though the CHIP definition is not very clear and not uniform across the globe, we can take majority of the complex circumstances and complex scenarios to define the CHIP. But these patients actually who needs more interventions are most probably denied because of lack of support or because of high risk. But with hemodynamic support available nowadays in the form of mechanical circulatory support devices, we are attempting more and more PCI cases. Otherwise, we were ending up in doing incomplete revascularizations most of the times, or we were staging the procedures, one stage, two stage, where by doing a repeat interventions, we were inviting more troubles. So what patients are we talking about? What are those patients? So we are talking about the group of patients known as protected PCI group. The protected PCI group is a complex group. It's a confluence of patient characteristics, three major patient characteristics, like patient comorbid conditions, complex coronary anatomy disease, and hemodynamic subset. So if you look at the patient comorbid conditions like heart failure, diabetes, advanced age, or severe peripheral vascular disease, or presentations with ACS like unstable angina or NSTEMI, or patients who already had surgery, again going for a repeat surgery is a high risk for them. And if you look at the complexity of the coronary anatomy, we are seeing more and we are doing more and more, and we are seeing more and more complexities nowadays, like left mains, multi-vessel diseases, as well as bifurcation diseases. So, and we are using more and more gadgets like atherectomy. So far, we have discussed so many things, how to optimize the PCI results. So whenever we use all those gadgets, ischemic burden and ischemia time will increase, so that there are chances that patients may crash on table. So for them, we need a robust mechanical circulatory support. And if patients are experiencing already having a hemodynamic compromise in the form of low ejection fraction, then they are at high risk. So all these factors, if present in one particular patient, they are known as a protected PCI group. If you look at the these factors in more detail, if you look at the anatomy, if it is a last remaining conduit, definitely that's a high risk. So you cannot meddle with the last remaining conduit just like that without any support. And if you are planning more atherectomy devices, more atherectomy in a complex bifurcation lesion or left main, disc left main or something like that, then you need some hemodynamic support. And if you are anticipating high ischemic burden or extensive revasculation, sometimes we do multiple like bifurcation, two bifurcation at a time, or sometimes we are dealing with disc left main bifurcation that substance most of the myocardial territory, then it needs hemodynamic support. And especially if we are doing a CTV intervention, retrograde approach and all those things needs that. And looking at the patient comorbidities like COPD, severe anemia, and renal failure, these are all because we are doing these chip procedures in an advanced age group. All these comorbidities are we see more often, and peripheral vascular disease, where the managing the distal pulses and all will be a challenge. And we have special strategies for that. And hemodynamics, all these things are very, and this is a very simple algorithm. If you understand this, and it's better way, who needs the hemodynamic support and who can, without hemodynamic, we can do in a given patient. So if you look at the ejection fraction less than 40%, they recommend that we need right heart catheterization to understand the cardiac index, to understand the wedge pressures, to understand the EDP and PA saturation. All those things we have to calculate if EF is less than 40%. And we have to see all these factors like if cardiac index is less than 2 or PA saturation is less than 55%, it carries 2 points. And if syntax score is more than 22, it carries 1 point. Ejection fraction less than 25%, 1 point. And systolic BP less than 100 at baseline, 1 point. And if the presentation is like ACS, unstable angina, NSTEMI, the 1 point. And planned revascularization more than 2 territories, like disc left main or bifurcation, LED diagonal D1 bifurcation, something like that. And there is a likely prolonged ischemia, like you are attempting a retrograde CTO and atherectomy, complex atherectomy. All those things will carry 1 mark. And severe MR, if is present in a given case, again, 1 point you can take. And decompensation state by doing a catheterization, like if LVDP is more than 20, or if patient is experiencing new onset orthopnea, and high risk vascular injury or significant bleeding you contemplate in a given patient, or if HB is already low. So all these parameters you have to see, and you have to calculate the points. Then if the patient is scoring only 0 to 2 points, then probably you can get away without any hemodynamic support. You can do a simple angioplasty. But if there is a patient is carrying 3 points, consider support. More than 3 points, less than or more than or equivalent 4, then strongly recommend and strongly consider for hemodynamic support. So if you look at the benefits of mechanical circulatory support, it maintains the vital organ perfusion, and it reduces intracardiac filling pressures, so that patients will pulmonary edema on table and congestion and all those complications we can avoid on table. And it reduces the left ventricular volumes and wall stress. Thereby, it increases the it reduces myocardial oxygen demand and consumption. And it also augments the coronary perfusion. These are the basic principles, basic ideas behind the mechanical circulatory support. And the options for that, we all know IABP and Impella are on cardiology side, and we have tandem heart and ECMO, mostly used by our surgical colleagues. But nowadays, because of percutaneous device and we are using that often. So the first thing is a crucial decision here is whether to take IABP or Impella. So IABP, we are all well versed with the IABP placement, and it's easily available. So here the main thing to decide between these two is the availability, ease of use, and cost. Especially in India, the cost is the biggest factor deciding about between these two devices. If you see a patient who is having active ischemia, ongoing ischemia, then probably you can start with IABP placement. Then if need arises, you can convert them, or you can take Impella as and when required. But if they are already in failure, some sort of failure or end organ ischemia is noticed in the form of raising lactate, and better to take Impella device. So this is the Impella pump family. So like iPhones, we have iPhone Pro and iPhone Pro Max, something like that. We have Impella 2.5, Impella CP, and Impella 5. So these are all used by the percutaneous techniques, whereas Impella 5.5 is a surgical device placed by cut down from axillary most of the times. And we have even Impella right side RP for giving the right ventricular protection. Whenever there is RV failure, you can consider Impella RP. So these are all the heart of the Impella, but this is the brain, what is known as automated Impella controller. Lot of things we can control from this monitor. So if you look at the hemodynamic effects of Impella, it by increasing the flow, so it aspirates the blood from the LV and it delivers into the aorta. So by continuously pumping, this is the axial flow pump, continuously pumping the blood, so it increases the flow and it increases the mean arterial pressure. Thereby, cardiac power output will be increased and end organ perfusion will be better. And it decreases the LV EDP and end arterial pressure as well as volume, so that LV wall tension will come down, and it decreases the microvascular resistance, and it leads to increased coronary perfusion so that oxygen supply will be better. And also it decreases the mechanical work of the heart because it's pumping in place of the heart. Heart need not to work hard. So mechanical work of the heart will come down and oxygen demand will be less. So this is another simple algorithm developed by Mount Sinai group. Whenever you are taking a patient with LV ejection fraction of more than 35%, if it is a simple PCI, then probably no support is required. If it is a complex PCI, which is complex PCI defined as a long calcified lesion, bifurcation lesion, or unpredicted left main, or SVG lesions, these are all complex lesions. If you are dealing with a complex lesion, probably you may need Impella support. If the ejection fraction is between 20 and 35, simple PCI, sometimes you can consider Impella. But if it is a complex, definite Impella is needed, especially in high syntax score and high STS score patients with whenever you are planning high risk PCI. And once ejection fraction is less than 20%, so without hemodynamic support, we should not touch the patient. So this slide explains the simple principle, how Impella helps the patient. The patient's mean arterial pressure to start with is 86. Whenever we inflate the balloon without any support, so there will be a drastic decrease in mean arterial pressure without support. So it reaches to almost all half of the map in just 30 to 45 seconds. So if we are doing a pronged ballooning, or if you are doing like some atherectomy, then there are chances that the patient will crash on table. But whereas with Impella, then initially the map will be, the mean arterial pressure will increase. Then when you inflate the balloons, the decrease will be very less, and it reaches a steady state of whatever more than the required mean. And when myocardium will go into hibernating state, it will never will allow the patient to go to ischemic down cascading. And whenever you inflate, this is one important phenomena you notice on the table. This is termed as ventricular arterial uncoupling. So ventricular arterial uncoupling is your left ventricle pressure will go down, but Impella will maintain the pressure so that the end organ perfusion, mainly to the brain and kidneys and other, will be maintained by the Impella till the heart recovers. So other hemodynamic support, what we discussed is ECMO. So we all know what is ECMO and what are the various VA, VV, ECMO, but it's not routinely used for hemodynamic support in PCI unless a patient is having biventricular failure, or patient is already in SCI D shock, or probably at the SCI E with ECP or something like that. Otherwise, we don't routinely use ECMO. So these are all circuits possible with ECMO device. And so, yeah, I'll show you few case examples. 61-year-old male, a diabetic, old interval MI, he underwent PCI long back, again presented with ACS like presentation, unstable angina. So now EC showed old interval MI, echo ejection fraction is around 30 to 35%. And he developed acute LVF on table after angio. So then we decided to go ahead with the viability study, and viability was good. This is the lesion. You can see the distal left main, very calcific lesion with poor targets, diffuse LED disease, and distal left main disease. And this is a dominant circle. One more important aspect is whenever you are dealing with a dominant left system, you are attempting distal left main, always better to use the robust hemodynamic support in the form of impella. So yeah, this is the angio. You can see the distal LMC having a very protruding calcium nodule there. So we, based on the various risk factors, we decided to take the impella, and we are placing the impella, and with that support. So see, even the imaging catheter was not going. We were struggling to push the imaging catheter. Such a tight stenosis was there. So if you touch that patient without impella, probably he would crash. So we have done the ostial ballooning, and we have done the OCT run, and we have done the DK crash technique we have done, and POT. This is a final result. So to achieve such a good result without any complications, definitely we need a hemodynamic support. And this is the second case who is hypertensive diabetic post-COVID, anti-MI with severe LV dysfunction. Again, parented with TVD. PET, we have done the PET, showed the viability in all territories. But first, they have done here. They have done the staging process because LED is a CTO. So they did only the other hospital. They have done only RCA stenting and left the LED. But again, we have done the PET in April. So again, there was a viability. So we thought we'll attempt because he is having LV dysfunction and viable myocardium. So again, we took the help of impella support, and it was very difficult, almost tough, long ischemia time and all, and a lot of balloons, lot of gadgets we have used, microcatheters and all. So finally, we crossed the lesion and we stented from LM to LED with the help of guide extension there. And yeah, this is the final result. And after 6 months follow-up, his ejection fraction improved, and he's almost mild LV dysfunction now. This is a OCT after this thing. So in summary, routine use of hemodynamic support device is probably not necessary in our day-to-day life, but there are scenarios where we have to use, we have to individualize for each patient, and we have to make very early decision before going into the, before taking the case. We have to decide whether he needs any hemodynamic support or not, based on the one algorithm we have shown. Probably that helps in deciding whether he needs or not. Then in this, we are familiar with IABP, and now the usage of impella is going up. With that BCIS 4, after that, the IABP usage is doubtful, but impella is showing prominent results in real world studies and almost all random trials. Now I think they are doing a Protect 4 trial that will give more idea about the usage of impella in more number of cases. Thank you very much. Any questions about the?
Thank you, Karnakar. Question. Please, Mike, can you?
So recently, we come across EAC guideline 2023 cases. So IABP is class 3 recommendation in case of ACS with cardiogenic shock. So how will you have shown the slides that we can use, but it has shown that it increases mortality and no longer it is recommended. Only cases
Yeah,
where
that's
we have VHD or some mechanical complication we can use. Otherwise, any SCS cases with cardiogenic shock or hemodynamic instability, it is almost guideline clearly shows that it's class 3 recommendations. So I want to know your views.
Yeah, definitely after that BCIS4 and all. So usage of Impella is doubtful, but still in India, we consider cost is the first, not the, so Impella, if you take Impella in place of IBP, so the cost will go up like anything, 20 to 25 lakhs. So, but though guidelines are recommending, our personal experience is still sometimes, in some cases, IBP helps. And recently we have done one case shifted from other, some Kurnool area with frank cardiogenic shock after RCA stenting. Then we put him on Impella, IBP, slowly improved over a period of time next day, and we have stented him. So we have, though guidelines are generalization, not for a individual case. Still, you can consider Impella in India, especially the cost is the main factor. And I'm sure that all of us have experience with IABP, where it has saved so many cases of cardiogenic shock or ongoing ischemia, whatever.
Guidelines are generally broader, but like you have thrombectomy also now they say it is class 3, but we still use it. Suppose you have a large thrombus burden, you tend to use thrombectomy. Similarly, it depends. Suppose patient comes very late, then putting anything will be useless. But sometimes it gives us a comfort for the operator to use it. It may not change the outcomes. If you're seeing the trial-wise mortality reduction, all that doesn't happen. But providing the operator comfortable doing the procedure and giving little more time, all that cannot be calculated in the trials and recommendations. That's where I think clinicians are comfortable using some sort of support. But if your patient is very sick, that sort of thing, when you're doing elective procedures, you need to take all care. And your procedure should not create trouble to the patient. That is the bottom line. Patient may be more sicker, but if you do something and gets into trouble, that's where we have no business to create trouble to patients. That's why we take all precautions. Karnakar is very interested and they've done a lot of Impella cases in Apollo. That's why I requested him. One more thing which is useful is Impella using this procedure for elective PCIs is preparation of the patient also. So you stabilize the patient, give them diuretics aggressively, see that they have become as much stable as possible. In acute emergencies, it's not possible, but elective patients like how it is shown, that's also important. Pre-treating the patients, making them a little stable, then taking up the patients for procedure. And you should consider it equivalent to surgery. It's no more like such sort of complex cases. It'll take 2-3 hours. And I always insist that attendants, patients should understand, they should all decide with us and they should request us to do such procedures. Otherwise, there's no point wasting our adrenals and all that, taking so much stress in the patients and do not understand. This era of problems, unless they request, we don't. We explain to them if there's no financial problem, they can understand it and do such complicated procedures and try to do the best with support of imaging and all that. Once you put Impella, you can do, it gives you a lot of time. I keep telling that it's costly comfort like Mercedes bench while doing the procedure. So you can, once you put in, you can have the hemodynamic stability and you can do the procedure completely, do imaging, do a good job and come out. I think that's how Karnakar has shown the cases. Congratulations, Karnakar. I think we'll proceed further.
Thank you very much.
Thank you. We'll proceed further to the complication session again. That is also interesting.
Dr. Karnakar, if you can just please come back on the stage because we need to felicitate you. So I would request Mr. Rahul Chakravarti to please felicitate Dr. Karnakar. Please give a loud round of applause. Thank you, sir. Next, we move on to our session, which is on complications of PCI. So we are going to start first with Dr. Sandeep Mishra. If I can have Dr. Sandeep Mishra's CV. Yeah. So Dr. Sandeep Mishra is the Vice Chancellor of NIMS University. He is a former director, professor of cardiology, AIIMS, New Delhi. He's the first person to do a virtual histology case in India, involved in several multinational clinical trials like the Atlas ACS2 TIMI 51 trial, published numerous articles in various reputed national and international journals, and he is editorship of several reputed journals, including the Indian Heart Journal. So Dr. Mishra is going to take us through the guide wire fracture, stent dislodgement, retrieval of embolized materials. Over to you, sir.
Dr. Sandeep we are fortunate to have him. He's Vice Chancellor of University. Still he comes, so that shows his passion for teaching. I requested him. He gives very interesting talks on complications. That's why I requested him for the sake of all of you. Thank you, Sandeep, for making it possible. And we'll hear from him.
Good evening, everybody. I think first of all, I have to thank Dr. Srinivas Kumar for calling me here. And it reminds me of old days when we used to be there and present, interventional cases. So I hope you are having a very good session. I think it's all efforts of Dr. Srinivas Kumar and his others, Rishi Sethi, etc. Now, it's okay. Yeah. Okay. Okay. All right. So, coming to embolizations, they are one of the most dreaded complications that you can encounter in cath lab. So, actually, previously, you might not know that previously stents were available off the balloon, and you could actually crimp them on the balloon, and then you could put it in the arteries. At that time, the embolization rates were very high, but with the already pre-deployed stents or pre-crimped stents, this rate is now about less than 0.5%. Now, basically, the important thing to understand is that embolizations can happen in two places. They can happen in the coronary tree, or they can be extracoronary. Important to realize, once they happen inside the coronary tree, especially if they are in the proximal part, they will be very dangerous. Even if you don't see them clotting, no thrombus formation, and you think it is okay, you cannot leave embolized material in the coronary territory, especially the proximal part. If it is very distal, maybe you can get away with it. But more or less, even if nothing is happening, if something has embolized in the coronary territory, I think you need to fix it. And we will discuss how we will fix it. The other important thing to realize is, if that embolized material is extracoronary, so most likely it will not cause any harm unless it goes to the cerebral circulation or some very this kind of artery. Otherwise, it will not cause any problem. So basically, it remains benign, and maybe you can leave it alone. There is no point in trying to fix extracoronary embolized material. So I think that is important. Now, the commonest type of embolization, as already we discussed, was the stent embolization, which is the commonest type encountered in cath lab. Okay. Now, important thing is that you have to realize that before that embolization happens, there are certain characteristics which if you are careful enough to look at, you will realize that there are higher chances of embolizations. So whenever you do complex lesions, like some of the lesions you saw, CTO bifurcations, also when there is a large angulation, when it's an angulated artery that you are doing, or a tortuous lesion, or presence of calcium, or a very distal location, or most importantly, if you have to cross a already deployed stent to pass a new stent, then that is the area where embolization is very likely to happen. So if you have a pre-stented area, be very, very careful with it.
The other thing is, besides lesion characteristics, some patient characteristics are also are important, or procedural characteristics are also important. Once you go for direct stenting, there is a risk of embolizations happening. When there is inadequate lesion preparation, then there is also a risk of embolization. But most importantly, if you are unable to, there is a situation called balloon crossing, stent not crossing. And in that situation, if you try to push the stent in with some force, and then if it is not going, you try to retrieve, then this is a recipe for a certain stent embolization. So you have to be very careful once pushing a stent through a balloon part. And if it is not going, then you don't apply any force. Then, as I said, manually crimped stents have higher chance. Previous types of stents had higher chance, like coiled stent design and stents with low flexibility. So all of these were associated with embolization risk. Now, of course, once you see these characteristics, whether you see the lesion characteristics or you see the stent characteristics, then whenever you see those characteristics, you realize that there could be chance of embolization, and you be very careful with your hardware. So never use a reused material. Don't use a reused balloon, guide, or anything wire in this kind of situation. So this is another recipe for disaster. So never reuse material once you see these risk factors that I already told you. Then go for guide catheters with higher support, and go for extra support guide wires. So guide catheter should also have a higher support and extra support guide wire. Plus, pay very careful attention to the technique. So very important to prepare the lesion very well, maybe pre-dilatation, proper pre-dilatation with a proper sized balloon catheter, and if required, if it is calcium, then rota, or even use of cutting balloon. And then, very important, always remember, never deploy a proximal stent before deploying a distal stent. Always first finish the distal part, deploy the stent, and then you come to the proximal part. Because this mistake I've seen many doing, because proximal lesion is very easy to stent, and then you think that difficulties will be over, and so you stent the proximal part and then go for the distal part. Never do it. Always do the distal part and then go for the proximal part. Now, of course, once the stent embolizes, then you have to manage it. And the management depends on two important things. Number one, where the stent has embolized. As I said, whether it is coronary or extracoronary. In the coronary, whether it is proximal or distal. So site of stent embolization is very important. The other thing that is very important is the wire still through the stent? Because many times when stents get embolized, people have tendency to pull the wire, or somehow the wire gets pulled and then stent is hanging, but there is no wire. But if there is a wire, then I think that is a very important thing to know. So I think these two things help decide what and how you will manage it. Now, basically, as I said, two possibilities. One is stent is riding the wire. So I think then there are two options available. Number one is redeployment, which is the best option. Remember, out of all the options, redeployment of the stent in the correct position, if possible, is the best option. If not, then other options exist. The worst option is retrieval of the stent. That is the worst option. Many people think that, whenever things get embolized, retrieval is the basically thing to do. But always remember, retrieval is the worst possibility, because once you retrieve an embolized material, there is a huge chance that you would damage the proximal part of the coronary territory. Even left main can be damaged. So never be in this sort of situation where you try to retrieve when other options exist. But if the stent is not riding the wire, then the options are, of course, as I said, again, you try to cross with a wire and redeploy, either distally where you want to deploy, or if not, then even proximally with a high pressure balloon to achieve that size. But redeployment is the best option. The second option is crushing. And I will come to that, what you do. That is the second best option. The third best option is retrieval, or in some cases where you can't retrieve, then even cabbage. So these are the four options that are present to you once
the material embolizes. Now, this technique is very important. What you do is, when the stent gets dislodged, wire is there, you put a small balloon through that stent to the distal part, and then what you can do is slightly inflate and then try to take the stent to where you want to do. So that is called a small balloon technique. If not, then you can even go distally and pull back the stent little bit and deploy in a different part where it is easy to deploy. But as I said, deployment of the stent is the best option. This is one example. This is, as you can see, it has got two risk factors. One is CTO of the circumflex, distal circumflex. So one is, it is a CTO. Second is, it's a distal lesion. Third, you can see that the circumflex is arising at a huge angle. So basically 90-degree angle is there. So all the risk factors are present in this case, which could make you think that this case might have an embolization. So again, fortunately, CT was skillfully crossed. You can see the wire there and balloon with 1.5 and 2 millimeter balloon. So we can say that the operator applied the technique, is a skilled operator, and he could at least cross it and even balloon it. Now, the problem is, once you have these kind of lesions, you have to balloon it to the size of the stent you are going to deploy. You can't balloon 2 and then think that 2.5 stent can be done. It can be done in many cases, but in these, there is a risk of problems happening if you don't balloon to the required vessel size. And here is exactly what happened. The problem was, they took a 2.75 DVS, tried to cross it. So we came across this situation, balloon crossing, but stent not crossing. What I told you is one of the recipes for stent embolization. Now, what are the options in these cases? Once you have this situation of balloon crossing, but a stent not crossing, what are the options? Of course, you can increase the guide support. You could switch to EBU or XB guide catheter, or child and mother catheter can be used. In one of the previous cases, we saw that happening. Also, you can improve the guide wire support. You could use a heavy duty guide wire exchange to a heavy duty guide wire, take buddy wire, take buddy balloon, all these options to improve the support. And then obviously you have to better lesion prepare, because you can't just do with 2O CTO lesion, you do with 2O dilatation and you want to put a 2.75 or 3 stent, not a good idea. Now here again, what happened was, some force was applied, but there was no success. Then the operator withdrew the balloon, and you can see that a stent is proximally the stent sticking, which has been embolized actually, and wire has been removed, as you can see. But now this operator is very interesting. He thinks, I'll try to fix this circumflex later. Let me first do the LED. So he goes and actually, he wants to hurry and finish the case. So he puts a wire into LED and, tries to do the LED and is able to do LED because LED is a simple lesion. The problem is that while stenting, he gets into left main. So it is LED into left main stent, which has, now you can see, has also blocked the origin to the circumflex. So the stent has crossed the circumflex origin, and now you can see how difficult it has become to tackle this part of stent. And if you leave this stent here undeployed, this is the recipe for circumflex occlusion, maybe even left main occlusion. So this is the most dangerous situation. As I said, never leave embolized material in the proximal artery, ever. That is the recipe for disaster. And unfortunately, that is exactly what has happened, with very little ability to get into the circumflex now. Now, of course, the operator does all the things, but he realizes nothing can happen. The good thing is that he has this courage to call a senior operator. So he asks a senior operator to help him. And now more skilled operator is there. He's able to cross through the left main strut and then cross the circumflex stent also, which had embolized. And he knows it will be very difficult to push this stent distally because some of it might be even entangled with the left main stent. So he deploys it there at a higher balloon pressure and then takes another stent and crosses through it and then deploys distally. So this is what is done by the senior operator. The mistake was that this circumflex stent, embolized stent, was left in place and LAD was tried to be done, and this was not a good idea. So anyway, the downside is that the proximal stent may be slightly undersized, but I think this risk you have to take to keep the procedure simple and understand that perfect is enemy of good. So again, now because this is a very good operator, he knows that there is an overlap of stent in the left main. So he does a final kissing balloon dilatation. And so this speaks something of the meticulous approach. And okay, this is the final result. And as you can see, very good result finally. So, what I tried to show you was how through the case complications can happen, how you keep your cool, even call your senior or a junior even if he is more skilled, and then you get the final result, because the interest of the patient should be in your mind, not your ego. That I could not do it, why should I call anybody else? Because if you mess up with this, there is a sure recipe of disaster and person will die actually on table or outside table. So there are some other techniques also, stent recross technique, where you can partially deployed stent can be recrossed, and with a partially inflated balloon, the stent can be taken even distally sometimes, but it requires a very careful operator, very good operator. Then I think the second important technique, which is the most commonly used technique actually, as a matter of fact, is the stent crushing strategy. And this is the most commonly employed strategy. The simple thing is that once the stent gets embolized, you put another wire by the side of the stent, you balloon it, and then you put another stent from the side of the embolized stent and crush it to the side of the vessel. So that is one strategy, which is the most common strategy and most recommended strategy, which has got very low risk. Because if you can properly push the embolized material to the side of the wall and cover it with another stent, then most likely there will be no problem at all. So this is a thing, and as I already discussed the strategy, so I will not go. The important thing is, once you put the wire, sometimes wire can cross through the embolized stent and then go into the distal lumen. So to prevent that, you always put a balloon on the new wire and check whether it is going easily or not. Because if it is going through the stent stud, then balloon will get stuck and you will realize that wire is gone through the stent stud. So you pull the wire and again push it from the side of the stent and then take a balloon to crush it, and then finally a stent to crush it. So I think this is very important to realize. I'll show another case, 63-year-old male, lesion found in mid RCA and distal RCA also, PD, and you can see, so there is a slight lesion here and distal RCA also, you can see. Now problem is distal location, and also you see the guide is not coaxial. We are looking for a good guide support. Here the guide is not coaxial. So this is, I think, an important problem that you can notice. Anyway, lesion was wired, PD was stented, and mid RCA was also stented. And then, a stent through this was taken for the distal RCA. So now I think that is another recipe. I told you, always stent the distal part first before fixing the proximal part. And so what happened was, you can see that there is a problem of this stent crossing, and actually it has embolized. Now you can see. So again, the important thing is that retrieval is generally more risky. So crush is the best technique. So what was done was, see, you can see the stent was crushed with increasing profile balloon. to the side of the vessel, like here, and then another stent crossed, and then before putting the other stent, with a high pressure non-compliant balloon, dilatation was also done, and then finally the balloon was finally it was stented. And so I think also operator realized that now I have put one stent and another embolized stent has been crushed to the side, so it will be very, very difficult to put another stent into the PD. So then operator decides to leave this PD stenting, and actually operator knows where to stop. So I think that is another very important thing to know. When the things get very complicated, don't try to mess around and try to achieve the best result, because best is the enemy of good. Here it is a reasonable result, and so it was left like that. Now coming to the retrievals, as I said, they should be the last option because there is a high chance of re-embolization and also into a more proximal part and also injury to the proximal vessel. So these two risks are ever present. But many techniques can be tried: balloon catheter technique, two-wire technique, hairpin trap technique, homemade loops, small loop snares, Emplas gooseneck, and other types of snares. And so I think many options are there. But as I said, this is the last option. And you can see many types of snares are also available. Just show you one case. 55-year-old male diabetic presented with class 2 symptoms, echo ejection fraction 45%, taken for coronary angiogram, revealed OM lesion proximal to with 90% stenosis and OM2 diffuse disease, and mid RC 90% and PLV another 90%. So this was the circumflex OM lesion, as you can see, and it was, you can see that there are risk factors because there are two bends actually, if you carefully notice. So this is something which is of a problem. Anyway, the patient was taken up for angioplasty and stenting, and RCA was nicely done, no problem. But when circumflex, and it is an old case, so sirolimus stents were available at that time, so it was done. But once circumflex was tried, the stent got dislodged, and there was an uninflated stent there in the circumflex, as you can see. So a 1.5 into 10 mm pre-dilatation balloon was taken across the stent, and it was dilated, and it was attempted to pull back the stent into the guiding catheter. But as I said, very difficult to pull back normally, and retrieval is not very good idea. What they have done is gone distal to the stent, inflated balloon, and pulled the balloon, hoping that stent will come out into the guide, but it did not happen. Instead, the stent got into the catheter, and you can see that the balloon is being taken through the stent, and it's there. And this is how it is done. But actually, the stent came out a little bit, but then part of the stent was in the left main and part in the aorta. So this is the most dangerous situation now. And obviously, you cannot leave it at this. So finally, you can see that this stent is hanging in the aorta, part of it in aorta, part of it in left main. So the gooseneck snare was taken, and you will see how it is pulling out this stent. So this is the stent being snared out, and finally, I mean, this is that snare, and this is the stent that you can see. This is the actual picture of that stent with the snare. And ultimately, after removing the stent, then circumflex was retackled, and this is the final result. So I think this is another case of retrieval using another type of catheter, microvena catheter. Because I'm short of time, so I will not, I think, spend much time here. What I will try to say is that management is majority of cases, retrieval is possible, but best thing is to rewire or redeploy the stent at maybe the part that you want, or even the proximal part. That is the best. Second is crushing, but retrieval is the worst option. but definitely never leave the stent in the proximal coronary or in coronary circulation. If you can't do anything, then you have to send for surgery. You can't leave this patient alone. That is, I think, important thing to realize. Then there are some extra coronary embolization, and unless they are into limb, vessel, or into cerebral circulation, you can probably leave them alone and you don't do anything. Then other coronary hardware as the wire fractures, that's also happen, and they mostly happen when you use a Oxford material, and those are the situations where they will happen more often. Other embolized hardware can also happen in different locations. Again, the principles are same. If in the coronary, you have to tackle it. If it is extra coronary, maybe you can leave alone. So, but besides the hardware, some other types of embolisms also happen: air embolism, calcium embolism, and embolization of vegetation. So for coronary embolism, what you do is IABP insertion. I think this is one way, still use of IABP. Whenever there is embolization, air embolism, it is a good idea to put an IABP because it will support the circulation for some time, 100% oxygen. Because remember, bubble has nitrogen and 21% oxygen. So if you give 100% oxygen, the size will decrease. Then aspirate, if it is proximal, intracoronary vasodilators can be given, and always heparinize the patient. So once air embolism happens, these are the things you do. If RB embolism happens, air embolism into right coronary artery, you can take a right lateral position also. Then calcium, previously calcium embolism happened when you tried to cross AS, calcified AS. Previously, it was like every AS needs to be crossed. And once people tried to cross AS, some part of calcium could embolize, and then it could go into the right coronary artery. So again, trying to retrieve will not be a good idea. The good idea would be push it distally to the most distal part and even crush it against the wall. And this is one case, and I will not show its image because the time is less, but it is exactly what was done. Through inflated balloon, that calcium was pushed distally, and then it was crushed against the side. So finally, to conclude, friends, embolizations in cath lab are rare, less than 0.5%, but can be catastrophic, especially if they occur in the coronary circulation, especially in the proximal part. Clinical importance depends on the site of embolization, whether coronary or extracoronary. Management of embolism, as I said, is largely interventional, but sometimes you might have to end up with surgery. Riding the wire or recrossing the embolized material or stent and then deploying it is the best option. But if not, then crushing is the next best. Cabbage is the last option. But sometimes, people have tried different kind of things, but I will not recommend it. Trying triple antiplatelets if it is in a side branch embolized material or in the distal part. So I think, thank you for your kind attention.
We'll have another talk, that similar talk, then we'll have some discussion after end of complications talk. I think you can request the next.
Thank you so much, Dr. Sandeep Mishra. Next, I would like to call upon Dr. Anil Sharma. Dr. Anil Sharma would be taking us through peri-procedural coronary dissection, perforation, and rupture. So Dr. Anil Sharma is the professor and head department of cardiology, Bombay Hospital. And he has worked with the prestigious Mount Sinai Hospital. And also he has a great experience regarding the procedures since last 27 years. So over to you, sir.
Thank you and good evening all. Yeah, changing. So why complications occurs? Most of the time, the complications occur because we do not respect the artery. We do not respect the lesion. The Lord Rama, even in spite of the being avatar of Vishnu, he requested the sea to give path to reach the Sri Lanka. Though he did not give it, there were different reasons. He explained that I cannot accept your request because you are Lord. So you have to threaten me, then only I will give, and I will tell you how to make this thing nil and null. But the practice is that you should give respect. I can do it. Only I can do it. I can do anything, anywhere. I'll just do in 2 minutes. I need no the other partner and blah, blah, blah. So I'm ready now. So after your brown ward and all clinical cardiologists, when you appear your DM, after the DM exam, in the next 1 year, I request you all to finish 2 books. One is the Manual of PCI by Dr. Brilakis, and another is practical textbook by Dr. Ilyas Hanna, ELIASHANNA. These 2 books, if you read and that you keep it in the brain, I think the chances of all this complication will be very less. It will not be zero, because if you say, somebody says, I will not cause any, I have not done any complication, there are only 2 differential diagnoses. One, he has not done the procedure, and second, he is a liar. So these are the possible complications. Out of these 2, I'm going to talk about this coronary dissections and perforations. Dissections are not always good. It is very common, and we can see by the National Heart Lung Blood Institution classification, type A, B, C, D, E, F. In morning, we discussed the type A and B are not very important, rather may be good, as I was telling you that during my interaction with Dr. Antonio Colombia last CSI meeting, I was chairing session with him. He said A, B are good because it allow things to reach inside, like fracture of the calcium. So dissections A, B is good. C, depending on your experience, you can leave it, but D, E, and F are not good. So A is luminal haziness, B, linear dissection, C, extraluminal contrast, D, spiral, E, dissection with persistent filling defect, and D, the F is the total obstruction. So what are the causes? One is the spontaneous coronary artery dissection is CAD, which is more common in the younger woman, is less than 50. I'm not going to discuss about this. Acute MI, we all know. Again, this is spontaneous, but it is different. So SCAD is non-traumatic and non-iatrogenic. So third is the iatrogenic. The commonest is injection with dampened pressure. Ventriculation means it is the change in the diastole, while in dampened pressure means it is change in the systole and diastole both. So what are the causes? Osteal disease or non-coaxial guide, which may be too deep inside or maybe big, or maybe side hole. That side hole is dangerous. It gives you false protection because you are seeing the aorta pressure while you are injecting with the arteries, which is wedging the artery. So side hole diet is maybe one of the biggest reason for dissections. Then vigorous injections, extensive and aggressive guide manipulations, anomalous origin, couple of cases I will show you, tortuous and calcified lesions. These has to be handled very carefully. So that can be caused by guide extension. I said in morning also, guide extension should never be put directly on the wire. First wire, then put the balloon, and over the balloon slowly push the guide catheter extension. It may be balloon, it may be stent related, or maybe after stent, it is maybe because we are in hurry to finish it with the direct stenting or with the partial ballooning, we do stenting, then very difficult under expanded or malapposition stents are there. Or vigorous, sometime patient take deep vigorous inspiration, maybe coughing, that can cause sometime dissections. How to prevent? Never ever inject with the dampened pressure. Be gentle, give respect, size, imaging may be helpful, but not necessary in all the patients. So what is the diameter? Where we have supposed to put the stent to see proper preparing. It's 3.5 artery, big lesion, just doing ballooning with the 2.5 or 3 is not enough. Try to finish 1:1 artery ballooning, prepare the bed properly. Incomplete bed preparation, stent does not open, then you go for aggressive ballooning. I've written a letter in 2023 textbook of CSI, there is a article of mine. Dr. Anushri is here. She is my co-author in that article. You can find all the details how to tackle with this partially difficult to cross lesion and difficult to dilate lesions. And all dissections are not bad. You can see here. This happens, pressure is dampened, both systole and diastole are low, but operator is in hurry. So no hurry, no worry, no curry. So somehow this could be managed well with the stenting. This is a 60-year male diabetic hypertension, ACS LV of 45%, angiogram, syntax score 28, RC also lesion. Dr. Anushri Shankar both are here. One was on the right side, another was on the left side. I decided ultimately to do the 3 stents, one in the sarcoem, one in the LAD proximal here. You can see here 2 lesions, and third RC I want to finish it. So I did this reasonably well, just edited the sheets, very happy. I was thinking about this lesion. Yeah, here you can see. Just a yeah. You can see here the circle. Yeah. Just proximal to that stand, something. So I said everything seems to be okay. Before moving to the RCA, let me check that whether I should put one more stand. I am missing it or not. I was thinking about the proximal LAD, and I took one shoot only. Oh, what happened? Oh, I said, Shankar. And then Shankar came. What happened, sir? I said, I'm not remembering you. I'm remembering the Lord Shankar. So that you can see the guide-induced big dissection. Now, one thing is very important, whether how the patient is hemodynamically stable. Definitely mechanical supports are required, maybe fluids, inotropics, and supports. Then if wire is inside or not, don't be panic. You have supposed to just withdraw the guide, but don't remove it, because the panic is the most important thing. You remove the guide and wire comes out. Try to keep wire there. If wire is there, things are still not good, as Dr. Sandeep already said, that just relax and try to fix it there only. But these are the only cases, like Dr. Sandeep said, that fixed distal stent before. This is the only place where I would like to finish the proximal stent. Though this is, I've already done the distal things, but if at the starting of procedure, suppose this would have been occurred. So I am supposed to fix the first proximal lesion, because then what to do? Disengage the catheter, just slightly keep the catheter, don't inject, because injecting can worsen this thing. How to confirm that I am in true lumen? Wire advances easily, no knuckling, it is not a spiral movement, it goes into the side branch, it does not cause any extra ectopic, or it can be confirmed by the contralateral shoot, or imaging can be confirmatory. Just stenting, don't waste your time. Just whatever size your eye says, or imaging if possible. Otherwise, just stent it, and then you can plan it and overdilate later on. If not, then keep prolonged ballooning. If it does not work, then surgery is the answer. So I did this 436 stent. Then I did this. Then I planned for the RCA next day. This stent again, Shankar was with me, and this is now perforation of the femoral artery, somehow with the compression. It was this patient, I could say. Another patient, just a guide-induced dissection. You can see with the imaging. Again, we'll see. Again, one of the speakers said about the OCT, less than 60 degree. It is not the percentage, less than 60 degree. Up to 2 millimeter is small, less than 60 degree small. And if it is not going to the media, you can leave it. But otherwise, if it is more than 60 degree, more than 3 millimeter or more, or it is going to the media, then we should fix it. It was fixed. Another stent, the guide induced. Rapidly stent was put, but the stent was not very well opposed. And later on, you can say right side, it was very well fixed later on with the full expansion, this one here. So if wire is out, then what to do? Then try to rewire it. Try to take a wire guide which does not go deep like XB or something. Just take the JL or something outside. I call it an outstanding guide and outstanding wiring by outstanding operator. Then try the CTO techniques. Though this technique also can work sometime to aspirate from the false lumen. So this is the published in the JAC by Dr. Martins. RCA, ballooning done, dissection is normal dissection. But while this is tortuous artery, while putting the stent, he brought all the thing comes out. Then he tried, could not do anything, went to the false lumen. Then again, he used the various CTO technology, the string ray, and he could do it successfully. Another thing is, while this is the RCO CTO via the LED septals. Now you can see here big dissection in the proximal LED. So while anywhere you're trying for the collaterals like CTO operation, from the LED septals, another wire is better to keep it to prevent like a stepney for safety. This again, I said that stent edge dissection. This is again less than 60 degree. It is length is now 3.4 millimeter, whether it is deep muscular media or not. You can see here, this is white arrow, 1 millimeter, not going to the media, while the yellow, here you can see this is reaching to the media, and this is 4 millimeter length. So this has to be fixed. Another stent, this can be left alone. So then imaging can be very, very useful. This was the stenting done. Patient was asymptomatic by some other center, then shifted to the, then again that after the finishing this thing, this is the final shoot by the imaging. So it was done very well. So this is how it looks. Again, superficial things seen better by OCT. So you will do OCT or IVAS? In this case, dissection. OCT is better, but can be disaster because by injecting forcefully, you can increase the dissections. Aortocoronary dissection class 1 involves the cusp. Class 2, less than 40 millimeter from the cusp. And class 3 is usually disaster. These are some of the example. You can see the cuspal, aortic cuspal. It is very common during the one I showed you at the left main. This is about the right main, and this is the left alone. And even after the 3 months, this was persisting, but patient was stable. Now coming back to the other complication, that is the perforation. Perforations are usually bad, unlike the dissections. Alice criteria, severity, class 1, crater extending outside the lumen in absence of dissection. Because if it's a dissection, it cannot be called as perforation. Class 2, pericardial or myocardial brush with less than the size of the exit hole, less than 1 millimeter. Class 3, the hole size is more than 1 millimeter. And if it is a spilling to the cavity, it is class 3 CES. 75% by location are in the proximal artery. Then there can be other places like distal wire. This is commonly seen in the septals, diagonals, and then RV branches. And then there are various techniques. And this is those who are doing CTO, they understand this can be septal perforations or epicardial perforations. How to prevent? About the oversized stent and balloons, imaging may be benefit. So proper sizing, as I said, be gentle. And dissection, same thing. Avoid very high pressure balloon inflation. Always confirm guide wire position within the vessel architecture. This can be disaster. We're putting the wire in CTO or something very difficult lesion, and we take a small balloon it, and we find the distal portion was outside the vessel. It can perforate, can lead to the rupture of the artery. So make sure, already I told how to confirm multiple techniques. I've already shown how to confirm the distal true lumen. Pay attention to the distal guide wire position. As I said, India is neither Mumbai, nor Delhi, nor Hyderabad. India is from Kashmir to Kanyakumari. In the medical science, Kashmir to Kanyakumari means you should see the guide, not the lesion in the proximal vessel or distal vessel, and distal tip of the wire. If you are not able to do so, dealing with some difficult thing, you should have one assistant or something fellow with you. Like I have, now they are about to leave me, Anushri and Shankar. She is smiling. But you should have, not necessarily your senior colleague, even your junior colleague, because your patient myocardium may be stunned, but your cerebrum is stunned. So take the help of the other cerebrum. Using the trapping technique to change the wire. And if once the wire finishes or balloon finishes job, just change it. Difficult lesion, you are using that whisper or whatever, XT or Confluence or any wire. Job is done. At the earliest, change it. And always distal tip of the wire and guide should be in your visual field. They're the four basic things described by the Dr. Bilakis. Inflate the balloon to occlude the vessel. See the hemodynamic assessment. Ask for the immediate the echo. Ask for the more assistant or more your colleague, senior, junior, whoever here. It is a teamwork. Just believe in we. Don't say anything me, because who does me? Bakra and cut jata hai. So don't do anything me. It is we wins. So fluid, vasopressor, or anything maybe support may be there. Pericentesis, which can be known by the pressure tracings or maybe echo, and give it call to the surgeon. Then thing is, if we can put covered wire, covered stent, that is the best thing. But sometimes tortuous arteries and calcified lesion you are not able to do. Then you can do the prolonged balloon inflation. If it is not possible, then you can try to do the reversal of the heparin. But before the reversal of this anticoagulation, make sure that all guide wires are out, because this heparin we use to prevent the coagulation because of these devices. Keeping the guide and wire there and in reversal can lead to the disaster thrombus formation. And again, if it is a distal vessel perforation, still you can use the embolization, fat coils, or many other things are there. Like there are even covered stents are of different kinds of there. Then they fail, then same thing can be applied. So this is the technique. Like you just balloon it. Meanwhile, your brain, allow your brain to settle down. Let the other help come. Like this patient, RCA with ballooning, it settled with the ballooning only. Here you can see here, what is this? Pulsus paradoxus. It is just not a question to be asked in the Viva. Pulsus paradoxus is the thing to be seen when pericardial tamponade is there. And there you can see, and it is not the amount of the blood, it is the rapidity which Bell's falls. So then you can see balloon, important semi-compliant balloon, less than 10 atmosphere, more than 10 minutes. But then what will happen to the distal artery? It can cause another infarct. So what thing is, just put a small microcatheter just side to the balloon. So inflate the balloon, immediately put another wire, put another microcatheter, deflate the balloon, and then push the microcatheter and inflate it again. So distal perfusion can be done. The distal perfusion balloons are available, may not be available in all the cath labs. These are the FDA approved stents. We have at Bombay Hospital Graft Master, but it's difficult to put because it is a two stents. But in people, this papyrus stents are easy to. It can be even 5 or 6 French. It is easy. There are other covered stents like on vein. Vein can be mounted on the stent, and there are in Chinese. There are new terms. They are just in emergency. They use the tegaderm. They roll tegaderm over the stent, and that it can used as a covered stent. Some papers are there, though it is not approved still, but Chinese are using it. So covered stent, it can be 2 ways. If it is a big guide like 8 French, same guide, you can put the another wire, and you can put the covered stent through it. You can see here, inflate the balloon, put another wire, deflate balloon, put wire, again inflate balloon. Take the covered stent till here, deflate the balloon temporarily, again put this thing, withdraw the wire and covered stent and put it there. Another can be 2 guide technique, that is also known as ping pong guide technique, because your guide is 5 or 6 French or 7 French. It cannot accommodate 2 things, particularly graft master. So you have to take another guide, one guide that put it just outside, let this be there, balloon there, inflate the balloon, put the another guide, deflate balloon quickly, wire it, again inflate it. Take the now covered stent till this portion. You can see here in this slide, if you can able to see. So these are the different techniques by which you can put this covered stent. If it does not go, then definitely prolonged ballooning, and then surgeon or maybe reversal can be helpful. Then small vessel perforation, balloon inflation, or maybe fat or coil embolization can be there. This is what I was saying about the Kashmir. You should say the ostium of the left main or artery, and there it is the lesion. Always you should behave like a Arjuna, Chidiya ki aankh, but at least somebody should see about the Kashmir and then Kanyakumari. You can see where the Kanyakumari is going, and you can see here these small perforations are there. And this is again wire going into this RV branch, but again, with the ballooning, this was enough. This try to put the cover stent. You can see cover stent is here. It cannot go here. So just ballooning. Fortunately, it worked. So fat and coil embolization is cheaper, better. It is you can see it, you can control, but fat is easy. Just put a cut, just crush it, and you just take this fat and you can, but because you don't see it, so you can soak it into the dye and you can use all these local techniques, but it is a cheap. In emergency, anything is good. So then again, these are the coils are there. This is the prograde. It is a bigger one, 2.5 French, and another one is the fine cross, that is a 1.8 Frenches is there. So it is easy to put. So this again, same like covered stand. I said, say, if it is a 8 French, usually we don't have. So we can put the another guide and you can do same thing, ballooning, inflating, deflating using other wire. Yeah, you can see here, putting all this material, fat or coil, whatever it is. Or if it does not work, then you can put this, close this side branch by putting the covered stand into the main artery. So these are the various techniques. This patient, spontaneous resolution occur after the 3 months. So heparin reversal is there, but most important thing is do not reverse heparin until unless you remove all the balloons and guides. So thank you very much, my dear friends. Simplifying a complex lesion is an art. Avoiding complexifying a simple lesion is a bigger art. Don't lose your cool. It is a teamwork. Sorry for writing. It is a teamwork. Be fast, be smart, and protect the heart and life. Effort plus wrong tool, no results. So right tools, right size catheters, right technique. You have two choices: think and then act, or otherwise you just act and keep on thinking what to do or what I have done. Thank you.
think a great talk, sir. We'll just have that concluding 10 minutes presentation by you and then we'll have some discussion. Yeah, and go ahead. Broader guidelines in general to prevent all the complications, we requested him to just highlight in the end. Then we can have some discussion. Many of you must have faced complications in cath lab. If you want to discuss anything apart from what is not discussed also, you can feel free to discuss.
So next, we would be having a daily checklist in cath lab by Dr. Sandeep Mishra, sir. So I would request her to please start the proceedings.
So I think we are having a very interesting session about complications in cath lab. And so what I will try to do is, talk not only at a technical level, but more at a philosophical level on how to deal with complications in cath lab. So basically, one important thing to understand is, उधर नहीं आ रहा So, friends, I think this is, I think, the final talk. So please be patient because we'll get it over soon. So as I said, important thing in cath lab is you have to think like a fighter pilot. So I think that is one of the important things. Interventional cardiologist is like a fighter pilot. 90% of the procedure is in mind. Only 10% is in the physical realm. So I think this very important thing you should remember, that you should always plan the patient. The whole procedure should be in your head from start to end, along with plan B and plan C. So you should know in this patient, this is what I'm going to do, and mentally do the whole procedure. But if this happens, then this is what I'm going to do. And if this happens, then this is what I'm going to do. So basically, it is 90% of the complications can be presented if you already run the procedure in your mind. So I think that is important to know. Understanding how to prevent is more important than actually treating them. So that is important thing. So what are the issues in PCI? What are the things that you need to look at? Number one, patient condition. Number two, lesion condition. Number three, the procedure that you are planning, that you have to consider whether it's a straightforward procedure, whether it requires the use of a new technique, whether it requires the use of a new hardware, what is the skill of the person doing it, that means your own skill, and what is the condition of cath lab. So I think you need to look at all these things at the time before you start doing the procedure. Now, as I said, preventing complications is like fighting war. So you have to win with minimum casualty. And as I said, you are like fighter pilot. The only difference between you and fighter pilot is that once you are in the jet fighting, then your life is at risk. Here, the patient's life is at risk. So that is the only difference. Otherwise, similarities are there between you. So if you think of doing PCI or preventing complications like fighting a war you are raging, trying to prevent any complication from happening. So there is this very important Chinese philosopher, Sun Tzu, and what he said was that if you have to win a war, you have to look at 5 things. And this is, as a matter of fact, taught by the Marines, US Marines. This whole strategy is taught to even US Marines, this very old philosophy by Sun Tzu. And what it says is you look at 5 things. Number 1, choose your weather. Number 2, choose your terrain. Number 3, choose your general. Number 4, choose your strategy. But most importantly, have the people's benefit at heart. So here the people is the patient. So patient's good should be at your heart, trying to do good to the patient at all times. So I think that is one important message. Now coming to terrain, in context with cardiologists, what is the terrain? The terrain is cath lab. This is your terrain. So you have to see whether the cath lab is properly equipped. So before starting the case, make sure that all things are available. Now, also the operator should be conversant with the cath lab. Now, it's not a very good idea going to some other lab and doing a live case, because that can lead to many complications. Therefore, it has been seen that once people do live cases, there are more risk of complications happening actually. So you should be very conversant with your own cath lab. The cath lab staff should be well trained, including yourself. The crash cart should be available nearby. Always, before starting the procedure, check whether defibrillator is working, whether crash cart is available or not. And then also make sure, if possible, the CTBS support is also present. Now, coming to choosing your weather. So what is weather for interventional cardiologist? Here, weather is the timing of the complex procedure. So once you are planning a complex procedure, always remember the difficult case should not be the first case. It should not be the last case. It should not be at a time when people are hungry. It should not be at a time when people are full. It should not be at change timings when you think nurses are going out, technicians are going out, and at that middle of that time, don't plan these complex cases. And also make sure that surgeon is available. So that is also timing, because surgeons finish the case and sometimes go home. So you plan cases at those times. So I think that is important to understand. Now, choosing the general. Of course, general here is you. So you cannot unchoose yourself unless you think it's a very complex procedure, and then when you might require a senior help or something. But the important things, those characteristics that you should possess is, number one, very important, you should follow a procedure. You should be stickler of method. Don't try to do things here and there. Just follow a certain method and always follow it. Second, of course, you should be skilled in preventing complications. So I think that goes without saying. But the other thing is that you should have a cool temperament, and you should be in control, as Dr. Anil also said, that don't lose your cerebrum while you are doing these cases. Always, whatever is happening, it is happening, but you are the one in charge. You are the fighter pilot. You cannot lose control of your jet. So that's why you have to remain in control of the situation at all situations, irrespective of what is happening to the patient. Other thing is, as I already mentioned in the beginning, once you plan a difficult case, you already run the case through your mind from start to end. This is what I'm going to do. This guiding catheter I'm using, this wire I'm using, this preparation I will do. I will use rota, not use rota. I will use an imaging catheter, not use a catheter, whatever. You run the whole case. And then you think that if something happens, this is my plan B. If plan B is not working, this is my plan C. So as I said in the last cases, as Dr. Anil also said, this is a person who's likely to have perforation. If it happens, then this is what I'm going to do. So make sure those things are available. You have a covered stent available with you or not, in a case where you think perforation can happen, or in a case where embolization can happen. Do you have the snares available with you in case you have to retrieve it? Or you have those proper dilatation balloon catheters, non-compliant high pressure balloon catheters or not, if you want to crush the stent to the size. So those things, I think you should make sure. And if that happens, go to plan B, go to plan C. Then another important thing, characteristic of an athlete. Remember, athlete always thinks while performing the athletic thing. So always on the run, athlete is thinking. Likewise, a cath lab operator should always keep thinking while things are going on. So think on the run, take quick decisions, and then go for them. So I think that is important. And finally, as I said, have the welfare of patient in mind always. Always think, I have to do best for the patient. Don't think of anything else at that point of time while you are doing the procedure. Of course, key to managing complications are threefold. The anticipation, as I said, you see the patient wheeling in the cath lab, you feel, no, I think something is wrong. Patient is not looking good. So you start anticipating. Then, if you have a method in place, you will avoid the complication. If you have already thought about it, you have thought of the problems that are going to happen, 90% complications can be prevented because they are in mind. And then finally, if it happens, of course, you have to do whatever is required. Now, basically, complications can happen at 3 times, all of us know. But as I said, 90% complications are in the pre-procedure time. So if you properly plan your procedure, 90% complications can be avoided, but some will happen during the procedure. And finally, there are certain complications that can happen even after the procedure. Like Dr. Anil showed you, those guide wire perforations which happen to the distal vessel. So those perforations can happen 6 hours after the procedure, 3 hours after procedure, 30 minutes after procedure. So they can be late complications or results of embolizations. If it goes to cerebrum, they can develop CVA later on. So those complications can happen even after the procedure. You have to remember that work is not done just completing the procedure and running away. They have to be shifted and they have to be monitored properly for at least near future. So as I said, pre-procedure is the key, and the key is properly choose your case, properly choose your strategy, run the whole strategy in mind. Then based on your strategy, properly choose the hardware, properly choose your technique, and also you choose your operators or assistants. Because you know that this is a complicated case. Dr. Anil was referring again and again to his assistants. So mostly he was choosing his assistants in those complex cases because he knew that things could go wrong and therefore have the right people in place. Then, as I already discussed this, that 90% is in mind. So 90% complications can be prevented if you run through your case, especially the complex case that you are going to do. Proper case selection. Again, I think we saw through the things. Somebody was mentioning about the sole remaining artery. Whenever you are in this situation, the sole surviving artery, I think, as it was already discussed, start thinking of Impella device to be put in or IABP to be put in to give extra support to the patient. Always anticipate. Because even why the single remaining artery is important or sole surviving artery is important? Because while doing the case, even if a small amount of embolism happens, then whole heart is dependent on that artery. If something happens to the circulation, then practically whole heart is knocked off. And then there is a huge chance of death on table. That's why the sole surviving artery is very important. Likewise, anybody with poor ejection fraction, because already ejection fraction, already the contractility is impaired. Small impact on contractility will lead to a catastrophe. So you have to look at the ejection fraction. Then calcific, thrombotic, tortuous lesions, all those complex lesions are already there. Left main bifurcation with triple vessel disease, cardiogenic shock patients, or patients with comorbidities like renal failure, uncontrolled diabetes mellitus are all risk factors which you need to know before taking up the case for the procedure. And this is just a sky list of the risk factors, clinical, procedural, and anatomic, which give you an idea where complications can happen. So here is a case. This is like CTO, and sure enough, the perforation happened in this particular case. So if they had anticipated it, they could have prevented it, or they would be ready to treat it if necessary. Here is another case, a calcific thrombotic left main lesion with LAD occlusion, a very high risk case, very recipe for disaster if not done by an experienced person and with a proper cool. Here another case, large artery, but look, huge thrombus, a recipe for no flow, a recipe for, sudden collapse of the patient, because such big RCA, if it gets distally occluded, there will be a huge problem. Another important thing, post-CABG cases. Now, people might think that post-CABG patients will not have, even if they have perforation, will not have tamponade. But problem is that they are more complicated and there is more risk. And here perforation happened and a Jome stent, which is a covered stent, was put. So this is another. Then sole surviving artery, no right and tight left main disease. So if something happens in embolism happens in left main, patient is just crashed. Patient will not make it. So this is some of the things which you should keep in mind while selecting cases, maybe not for beginners. You need seniors' help. You need more devices. You need more hemodynamic support in these kind of cases. So don't rush to do those cases. Then, of course, proper selection of hardware. Obviously, you could even do CT before going for the actual procedure. And through CT, you can see the course of the vessel, where calcium is existing, where you might encounter problems. Then proper selection of guide catheter that you already know, proper selection of guide wire, proper selection of balloon catheter, properly kept covered stents, micro catheters. Dr. Anil already showed you where you could use a micro catheter, and imaging catheters, and then distal or proximal protection devices where there is a high risk of embolization, and then thrombectomy devices to remove the thrombus as well. So And here is an example case, improper guide, see non-coaxial guide. And so you can see osteocoronary or osteoaortic perforation, type 2 osteoaortic perforation, very risky case. Fortunately, as this is one situation when you have a proximal or ostial and aortic perforation where you stent this dissection immediately or this perforation immediately rather than trying to tackle the distal part. This is one situation where you actually handle it very quickly. Then, of course, proper selection of technique. And in technique also, not only the procedure, also look at how much contrast will be required. So you calculate the dose of contrast 4 into creatinine clearance, maximum 6 into creatinine clearance. If you are using more contrast than this, you will do well, but late complication will happen and they will develop renal failure. So that patient is not benefited. Keep patient's benefit in mind. Doing procedure is not that important. Patient's benefit is the most important thing. That is why we are doing the procedure. Also, how long are you going to do fluoro? There are cases where fluoro has been given so much that burns have happened into the patients. So also remember these things are important. Then sometimes in CTOs you take bilateral access to know the retrograde part of the artery. Also, already discussed proper vessel selection, proper vessel preparation, whether by balloon dilatation, by rota or cutting balloon, whatever it is. Then thrombus extraction where necessary, imaging where required. So these are, I think, the common things that you need to do. But during the procedure, I think important thing is, of course, the technique should be good, but you should always stick to technique. Never try to jump here and there, miss some steps, never. For example, if you do bifurcation, always remember to do final kissing balloon dilatation. Always remember to do a proximal pot. So these are the steps and you always remember to do. If you are doing left main, always remember to do imaging. So don't skip this particular step in left main case. So that's what I mean by sticking to technique for that particular case. And of course, adapt when necessary. But very important thing, what happens when patient collapse? Everybody starts shouting. And there is a total confusion. Nobody knows what to do. Always keep the communication channel ready. Only the person who's doing is the head. He's the leader. He should communicate with everybody whom should be doing. Not everybody shouting, you do this, you do that. So I think that is a very important thing. Even, think when patient collapses, what one is going to do, who is going to do what. So I think that is also important. Finally, I think, as I said, technique is important. And here there was a case of under-deployed stent. Technique was not followed. No post-dilatation was done. And there was a thrombus, acute thrombus. And ultimately, again, the whole process was done. So acute thrombosis happened because the proper post-dilatation of the stent was not done. Here another case where there is a damage to the stent stud because it was over-dilated. And then one had to put another stent inside this stent to cover up this thrombus, huge thrombus that had been formed. So again, the proper technique was not followed. Properly stent size was not calculated. Then plan B, as I said, once things start going wrong, always think about them, have the plan B ready. Here, the stent embolized, and you can see that it is being retrieved. So this is the plan B or plan C. Retrieval is always plan C. First, you try other things. If not possible, then you go for retrieval. So, but if necessary, you have to do. But crushed stent is the plan B. So this is a case where the stent was crushed. And I think I already showed you this case so previously. Then I think very important, don't be egoistic. Be ready to call for help. Whether it is a junior, whether it is senior, sometimes juniors are more skilled than you. Many times seniors are more skilled than you. Have no ego. Because patient's benefit is in your mind. Your ego is not your goal. The goal is patient's benefit. Whether if junior can do the thing, if somebody else can do the thing, if you can call more people, then I think that is the best idea. So this is important. Other things I already told you. Clear communication I already discussed with you, so I will not spend any time there. Finally, as I said, procedure is not over till the patient gets discharged. So even after the procedure, you have to look at guide wire perforation, retroperitoneal bleeds can happen, contrast reactions can happen, and cardiovascular, cerebrovascular accidents can happen. So you have a very good staff, very trained fellow in the CCU also, who can pick up these complications once they start happening and immediately inform you so that you can take corrective steps. So here is that case which you could not see, where trying to cross the aorta, there was in the severe AS, the calcium got embolized, and then finally it was actually crushed. And here is a case of guide wire perforation, and you can see that there are some strategies. I think Dr. Anil already told you, so I will not spend any time there. So I will conclude because Dr. Srinivas is looking at me again and again. So I will now quickly conclude that complications happen even in best of hands. If somebody tells you that I have never had a complication in life, means he has not done enough procedures. If you do enough procedures, then you will definitely have complications. So they happen in best of hands. I think that is important to realize, but still most of them are preventable. 90% are preventable. Proper choice of patient, lesion, strategy, technique, hardware can prevent most complications. But if they happen, keep plan B, plan C ready, and be watchful of the whole procedure. As he said, look from Kashmir to Kanyakumari. So keep that while you do the fine print, you have the big picture in mind, and the biggest picture is patient's benefit. So keep that in mind. So thank you so much for your kind attention.
Yeah, I think great talks. I hope all of you enjoyed this complication session. It's very important. As told already, keep patients' interest in top priority. And when you work with that, and God and everybody will cooperate and things will fall in place. And whenever you do some hanky-panky things, unindicated things, then that's where we land in trouble and more problems happen. So keep that patient's interest in top priority. That's what I think Sandeep highlighted. And all of us could face, but try to prevent if problems if happening. I think we can have some discussion. All of you could have some complications, one thing or the other. If you're not asked coming directly, then we can ask each of you to tell some interesting complication which you had in your tenure. At least for namesake, one or two people can explain what interesting complications they had in the cath lab and how it was tided over, or you had unanswered complication. We try to answer that here. Anything, but please come forward. The last, I don't want to trouble you further with more lectures, but I will end up with an angio fire chart session where we will be having interaction, how decision-making process can happen, where even if you are tired, you can still interact. So I'll close with that. We promise that we'll break by 9 as promised, and then you can have dinner. But before that, I want some discussion in complications. If you don't discuss in complications, where will you ask questions? Yeah, please. All of you sitting here, you must have had some complication in cath lab. No, definitely no. Otherwise, as Sandeep said, you have not assisted or not done many. Yeah, each of you. I think Sandeep or Anil sir, everybody will be.
I'll add few comments rather than complications, because complications can be anything, like maybe antiplatelet is not given. Patient's hemoglobin is 6. We all have experience. Dr. Sandeep said that I already said there, if you said I have not seen the complications, there are two differential diagnoses. What are these two? Dr. Anushri, come on. Yeah, once, yeah. You have not done the one. Second, you are liar. So there are only two differential diagnoses. So 90%, our aim is to reduce this 90% and let 10%, 10%, 9%, so minimize the chances.
But I think overall, with the advent of better techniques and better cath lab material, the avoidable complications have come down significantly. But why, on the other hand, also we keep increasing is we do more complex cases now. When we were students, probably average number of stents put per patient was 1.5, that's all. Now the cath lab procedures which we do, there may be 3.5 stents per patient. So these complicated procedures, less patients go for surgery. If you analyze our own patient database, 20% of patients are sent by surgeons because they can't tackle it. Very diffuse disease or calcific patients or elderly ladies, their relatives. So such stuff comes. So still,
we are tackling all those, still complications could happen. So we need to understand. But one thing I strongly believe in life is you do with good intention to help the patient. God or nature, whatever you believe, will cooperate and patients will come out of the complicated problems. Second is human body is very great. In spite of you doing one mistake, patient will not die. But you have to do it multiple times, neglecting it. Don't see the problem. Again, do one more mistake, then that's where patients land in trouble totally. If you can identify a problem, immediately fix it, most of the times he'll come out of the cath lab correctly. But if you neglect, if you retrospectively analyze any deaths which has happened in the cath lab, so multiple problems, multiple mistakes must have happened in the patient then only. Otherwise, human body, nature, God made it so tough and so great, it tolerates multiple nuisances and nonsenses which you do in cath lab. But it doesn't mean that you have to do it. So, but please understand, and I request at least symbolically, two of you, Rishi also joined, two of you should talk and express one of the interesting complications which you faced in cath lab, or any minor complication also okay. Because in India, we lack this in spite of repeated efforts to make it interactive. It again ends up with adult lectures. Please.
Thank you, sir, to giving me opportunity. Myself, Dr. Raut from Cuttack, Odisha. So, a few months, around 2 months back, we have done a elective angioplasty of medial lady, and after 24 hours, the patient again complained severe chest pain. So then we took the patient to the cath lab, and the stent is missing. So everybody is surprised of where the stent went, and otherwise the patient is stable except mild to moderate chest pains, typical angina. So we have searched the whole body. So finally we got at ankle. The stent was at ankle, and we again done angioplasty, and the patient is stable on DAPT. And second complication that I have seen is during angioplasty in radial, the guide catheter stuck, and it after doing all type of protocols, whatever we can do, we are unable to remove it. Then we shifted the patient to the CTVS under general anesthesia. It removed. So both of are very learning experience for me, sir.
Yeah, peripheral embolizations, that's what he's mentioning. Unless you are put a very smaller stent in a bigger artery, generally it is less likely to happen. That's why when in doubt, actually you can take help of post-dilatation and try to fix it. But human body is great. At that particular point of time, you saved the patient. Even 10%, 20% blood you gave in acute MI, he improves. You must have seen in inferior wall MIs, RCA, if it's totally occluded, how much ever inotropes you pump and whatever pressures won't pick up. Once you put a wire and balloon it and give some flow, pressure suddenly pick up. So that's the beauty of interventional cardiology. That's why we start thinking we are semi-gods. But we are channels by which God makes things that happen. That's what you should think. Otherwise, you feel too great about it. Next day, cath lab is a balancer, I will tell you. Next day, something smaller things will happen to you and it will level down. So that is a great equalizer also. But always do with good intention, God will help us. And one more, at least complication you can share, then I will.
You said the stent, you placed the stent, the stent was missing, and finally, that could not happen, but only by one thing. While initial deployment of the stent, there has been some push and pull. There has been, you have not been able to deliver the stent. You have tried to retrieve it back into the guiding catheter. You have stripped the stent, retaken the balloon inside, thinking that the stent is inside, but the stent was probably outside. And while this engagement, while your wire has been pulled out somehow, then the stent has embolized somewhere close to the descending aorta. So it has gone down. But essentially, until and unless you have pulled that stent back, stripped it while it was still on wire, and then reintroduced the balloon and just inflated the balloon, thinking that you are inflated the stent. Otherwise, this cannot happen.
But at that particular point, you have produced blood flow. That's why patient must be okay till then. And again, something happened. But cath lab is not a place again to show your power or strength. Okay. If there is some resistance, some thing stuck, you don't pull your to show your pressure. It's not a. Sandeep showed a lot of war fields, but it's not really so. So if you apply pressure, there is something going to happen. So don't apply pressure. Cath lab is not a pressure place to show your power. Even minimal resistance, you should have the sensitivity to detect it and then see what is happening. In the initial stages, you can image more, do fluoro, there's no problem. Don't do blindly. So that will help avoid it. Sandeep?
No, no, I
I'm
said
telling it
apply pressure,
neither way.
but with your mind.
Yeah, yeah.
Don't mindlessly apply pressure.
No,
So
no,
you see what is happening. You know, in a skilled way, you apply pressure, not in an unskilled way.
No, no.
Similar small event occurred with me 6 years back. A young 36-year-old am I, and I planned just direct stenting I will do 2 a.m. in midnight. 3:18, I put the stent. I did very good result. Then technician says, I'm not able to see the stent. I said, where is the stent? Now it was again the month of December. The winter are not very big. It's great winter in the Mumbai, but I start perspiring because I am not able to see stent. Then I start searching, and then on the table it was
Yeah,
there.
same. 1 month back.
So it was just stripped off, fortunately. And then I had to put again a 3024 stent immediately. And then patient did well.
1 month
So
back.
we have to be very clear. Patient, the case is not over till it is over.
Before we took the stent has actually fallen out. But thinking that it is stent, person has taken up the balloon, inflated, but the stent was lying outside.
Earlier, these problems are more because you have to crimp it. Earlier is to crimp.
Actually, in today's era, I'm not disrespecting Indian companies, but all the Indian companies, once the procedure is done, the stents are fine. But sometimes you have these issues of crimping. One odd stent could get in trouble. That's what you notice when you're taking it, when there's resistance, when you come back, that's where is the problems happening. We've noticed it quite a lot in many of these various companies coming up. But be careful, as shown, when there's resistance, please try to see. One more problem where the stents get into trouble is in this Y connector business, when you have a spring inside, when you totally push it, you thought the stent is inside, but it is there in your Y connector. So that also happens sometimes. So please be careful about those minor things. But symbolically, as I promised, we'll close at around 9. But I thought we'll have one interactive discussion because I always wanted you people to be talking. And this interactive discussion is on a angio fire shot session. I labeled it in the program. But basically, for you to encourage and your thought process, decision making, how we decide in multivessel PCI. Generally, people say diabetics, multivessel PCI, as if doing PCI is a crime in diabetics and multivessel PCI. Not so, because better quality stents have come. And sometimes better quality stents can do a job where your surgeons cannot do it also. I'm not disrespecting surgery. There are places for that also. But you have to understand, it is not like single vessel is equal to stent and multivessel is equal to surgery. It could be a sometimes combination. I have specifically chosen one of the recent patient which we had. I want 1 or 2 people to come in front and probably participate in the discussion. I'll be happy with this. This is a story. See this 38-year-old software professional. This is true story. I think my colleagues are sitting in the audience. So 38-year-old fellow, software professional. This is the problem. Software means night working, chronic smoking. And he also unfortunately developed hypertension. Luckily, he has no diabetes, normal renal function. Then he was having another of angina. They think as gas. Sometimes they'll get blown up also. But luckily, this patient was known. He had some minor SCT changes. Then echo was normal, but TMT, somebody, he has classical discomfort. If it had come to us, we wouldn't have done TMT. But some outside, it was done positive also significantly. Still, he was not able to believe himself that he has CAD. Now, this has become another fashion. Doctors will be just, can make the timer on. Doctors will think that they'll tell like that. So if you see this, the ECG showed this sort of things, no? Inferior lateral changes. So suppose this patient says he is not having angina, had the sort of changes, what else you will think? Anybody can volunteer? Inferior lateral ECG changes, minor ECG changes, but if the dynamic, it becomes more important with angina if it's coming. With chronic, sometimes some hypertension, something also could be there. But clinical history, talking to the patient is more important. That's what I wanted to highlight. So otherwise, you'll miss the angina diagnosis totally. Then we said, I had no doubt, this is the angio. So anybody can just volunteer in interpreting the angio, please. One of you. Otherwise, I'll talk myself again. Please see it. There is no, can you dim the lights? Oh, I will help you in reading it. This is a normal left main. There's no problem. So surgical immediate emergency priority is unlikely because patient also is young, not having diabetes. But you see this left main, Can you dim the light, this light? You can come in front. So the left main is normal, LED till the mid segment looks normal. Then there's a large diagonal that is a tight stenosis. What is happening here? LED from here, it is occluded here, right? Then left circumflex seems to be little codominant or dominant. They also have a lesion in the OM, a lesion here in the bifurcation of OM, right? So LAD, probably this is the place where surgeons tend to graft, but below which there's no LAD seen. The diagonal, which is again tight, LCX. But mind you, the left main, the proximal LAD, proximal LCX is all right, right? So try to avoid sending patient that to a 38-year-old male, right? I always feel a pinch with very bad if you are sending a patient of 38 years. One of you, if you ask you to go for surgery, you feel bad. You know? You don't want it unless you have a very strong reason to do it. So this fellow is first not able to believe. Then you tell him for surgery, he will not agree also. But still, then you see this. Till here it is okay, but such sort of patchy disease, the large diagonal, this is again tight disease there, right? So any other information you want? And one more thing we keep seeing is if you get adequate information about all the vessels and all the things, you can stop. I see some angiograms coming, 15 views taken. All that may not be required. If there's a doubt, then you can do it. Angiography doing is not a problem, provided you have the adequate information on table. Once you get the patient table out, then you can't get him back. That's what is important. So try analyze views, whatever you're taken. And if you're comfortable, confident with the decisions of that vessels, you can safely come out. That's what is important. Otherwise, doing angiogram, if you practice it, anybody will do it. But decision making on table also becomes important. Otherwise, to avoid it, so many angio views will be taken. That is unsaid, not very encouraging. But if you have any doubt, you can always take it. I always, as it was told before, have a senior colleague, take help of somebody if you're in doubt. But once you take the patient out on table, then it will be a problem. So this is, I think, this distal LCX is occluded here, tight stenosis here, and LAD is occluded distally.
Dr. Srinivas,
large
can
diagonal
I interrupt you? Can I interrupt you a minute?
Yeah.
So first session we started the angio. So I would like a little more emphasis on the first shoot right side. Which is diagonal, which is LAD? How
Okay.
you?
I'll just finish the right also, then we can. This is about left, right? Then Eleocaudal, we wanted to see whether proximal LCX is important or not, because proximal vessel involvement, again, take it seriously compared to distal vessels, to make sure. So elevocranial view shows the left main, I think it is already covered. I didn't want to go into it again. So this is the right, okay? Right looks like there is nothing major happening here. Then it actually, if you have not seen it carefully, you will end the angio here. But I was thinking the PDA is not there from there. Then we searched it again. You got another vessel which is just arising by it. This is a large right and it's a PDA. There's a tight lesion here also. Here also. So now we have a patient with triple vessel disease, young fellow, normal LV function, normal renal artery, requesting you to avoid surgery. Or else you ask surgery colleague, he was also very not confident because distal LAD was not, unless LAD is revascularizable, generally we feel painful to send the patient to surgery, and surgeons also rightfully say. So he requested to do a multivessel PCI. But I again tell you, if you are doing it, total revascularization should be your aim. Don't just fix this small right coronary artery, which is easy, and say that you have done the job. So always try to aim for it if possible. The smaller vessels which are not physiologically important, not very major supplying vessels, if you have a small branch, a surgeon also may not be able to graft that. Again, you could be managing with medicines, but by and large vessels, important vessels, you should try to revascularize. That's the principle. I want to just take you through the process of decision making. That's why I selected one case. But it's a true case, 38-year-old male. This is what is happening in our country, unfortunately. So now that you have decided, we have had a hard team discussion, whatever you say, again, patient is a top decision maker in this, and patient never wanted. I gave him time. I asked him to take time and come back. Otherwise, they'll think if you put 6-7 stents, they will say, why you did all that and something happened. So I gave time to patient. Luckily, it is only like a chronic stable angina at class 2-3 types. Then I made him request us to do procedure because painful thing, it continuously work for 2-3 hours in the cath lab, no? So that's why patient was given adequate time. I asked him to come once, twice again. Then after repeated request, then I decided to do multi-vessel PCI. So this is I've edited for that. Sir, you are wanting to discuss something? You want to tell?
We start with the right from the beginning, from the angio, because they should get like, how do we decide which one is the LED, which is diagonal? First should
Shall I go there?
Yeah, because that they should know, because many times first should they say the which is coming outside is like, which is, yeah, right side shoot, right side. No,
RAO?
Yeah, this one. And you can freeze sometime in between, freeze. So many times, like, because LED has to make a box like, and something coming outside is the diagonal. So start from the right. From the first shoot, they should see, as you said, left main is okay. Proximal LED, proximal circ is okay. Then you go to the LED, something like mostly septal. Then which one is LED? The outermost is LED, or this one is LED? That is why one they should come out.
The problem in our country is this, sir. Unfortunately, they're very intelligent, but we don't talk. We do a lot of good things, but we don't write. This is the problem with us.
Yeah. So one which is giving septal, one other reaching to the apex, 2, 3. In this, which one is reaching to the distal one? Which is bigger one? No, this view only. If you take more, that is the next thing, to take more views. Which one is LED? Which one is diagonal? Right side, very good.
Okay, I think he has answered partly correct. This is elevocranial view if you're taking, what is coming down is critical. But here you are getting doubt because the distal LED is not forming. Unfortunately, it is occluded. But generally, as a conceptual, if you see RAO views separate atria from ventricle. So atrioventricular groove, if something is going, it should be either LCX or RCA. Whereas LAO views separate right ventricle from left ventricle. So what is running in between will be the either LED or the PDA. This is conceptually you should understand. Conceptually, you should see contralateral views you should take, because in one view, eccentric disease, sometimes you see haziness, means in other view it could be tight. That's where after advent of imaging, now you know oval shaped lumens. That means it comes as haziness in angiogram. So I think for the sake of time, I'll proceed. I'll just show you what briefly we did in this. Not to say great about us, but it is a greatness of good quality stents which we have. But provided patient is compliant and takes drugs well, and probably antiplatelet statins and all that. Nowadays, we started giving this PCSK9 injections also in such patients, because this thing, then here we thought RCA is relatively straightforward, and proximally here and here we fixed it up. And he had some infralateral changes also, could be because of LCX or RCA. So we fixed this both, and I've edited multiple things, proximal, mid, both were tight. Distally also it was there, but I thought it's too thin a vessel, that's why we didn't do it. So we stented mid, and then the proximal, as Sandeep told, tackle distal vessels stents first unless there is a reason. So did you see this, the final result of RCA? I think we did both, and that was okay. Then we went on to left. So left again, we were thinking to tackle. In general principle, if you are not successful, the patient is going for surgery, open the toughest vessel first, not the smallest one like this. So if patient here is anyway not wanting to go for surgery, whichever is the critical most, you might tackle it first, which is bigger. Those are some of the conceptual things. Some of them, the seniors should excuse me for the sake of everybody, I wanted to run it. Here, if you see, then we were again wanting to tackle the LCX again, because infralateral changes were bothering me, or the tightest thing was, next tightest was diagonal. So we were thinking whether to do that or this. We thought we would take the help of imaging. And if the proximal LCX is very critical, which was hazy, we thought we'd do it. See what happens in this catheter. That's what I was asking. I don't know, the lights are, you're not able to see it well. This is a catheter, imaging catheter. Can you not dim this light? The proximal vessel catheter, when you want to take it, that's where it gets separated. This, especially the one modification which OCT catheter did in between, it became more horrible. Now they modified it and improved the catheter, it goes more cohesively. That doesn't go, but with great difficulty, something we had negotiated. I finally did imaging for the LCX. I would show you that. Then it showed that the proximal thing is also very important. Then we tackled the proximal vessel. Then also another exception where you do it is if you have a very critical lesion or proximal dilated projections, all that you could tackle proximally also. But generally we dilate with a balloon, make it stable and tackle the distal stent and come to the proximal stent. So this is what is the lesions. I think, I don't know whether you're able to appreciate. So we stented here and we stented here. Yeah. So that is about LCX is again tackled. Then we are going to now this one, the diagonal. So diagonal was very tight, but we thought we could wire LED also in that process not to get into trouble. The diagonal is tackled. And then initially our plan was to just do a drug-eluting balloon. We thought it is okay, but it could take, whenever you get a 2.25 vessel stent again, you are itches to put a stent again. It could be less than 2, then probably you have no choice. Then we did that. Then we opened up for sake of this thing, I've edited some of these things, wired the LED also, they opened up here, and the distal vessel, what we had a idea is it could be there is was filling from the distal apex LED was filling from there. Then we wired this, and then probably this is what a good quality LED came. So this, if this was information was there, surgeon would have been comfortable maybe. We were also not very sure when surgeon said, and the patient was also not really at any cost for surgery, that's different. But suppose this was occluded, really diffuse disease, surgeon puts a graft also, it gets closed. So that's why, but finally you got a good result in the LED also. So that's where finally we had a LED diagonal OMs revascularized, and then we checked it by the imaging. But see the number of stents this patient had. Unfortunately, patient should be told about all this, and finally, patient should be compliant with drugs and statins and things like that. Both operator and patient has to be lucky. Don't think that you only did everything. So sometimes a small lesion in the end also could create trouble. So till no procedure is over, till everything is over. But we have to work in cath lab for 2.5 hours and things like that. So it is equivalent to doing about 6-7 stents procedures. But very rarely we do so many. But this is an example. That's the greatness of good quality stents which I have. I wanted to show, and also caution you that 38-year-old gentlemen also get into trouble. So please take care of your health also. We get exposed to a lot of stress and doctors are suffering a lot. So take care of your health and manage it well. This patient came back. The beauty of percutaneous procedure is he joins back work. He was telling, when can I go? I said, from tomorrow. Then I asked him to take 1 day rest, and from day 4, he started going, walking 3 kilometers, no angina now. Came for 1 month follow-up, only it's too early, but he's doing fine. So that is why I think this approach treats well. May not save lives always, but very important in giving good quality life. And of late, such patients who can afford, when the lipid levels are not very high also, we started giving PCSK9 inhibitors. It's not indicated immediately, but I thought aggressive, the plaque stabilization benefits, other things are noted even with that. I think with this, I wanted just to give I requested also to Lupin to get some interesting angios from your side, but as usual, I think nobody brought. At least I thought I'll discuss one multivessel PCI. I think with this, I close. Any other seniors who are wanting to advise them anything, otherwise we'll close for the dinner. Any doubts you have, anybody? Yeah. Sorry? That's what I showed. Now I told the reason also why I tackled RCA first. Whenever you're dealing with multi-vessel PCI, if your total occluded vessel is there, which is difficult, for patient, if you fail that, if patient is willing to go for surgery, do that first. Because again, LED gets a priority always, because LED supplies 50% of the vessel, heart. So if LED is diseased, you should tackle LED always. But here the problem was LED, we were not sure, because we also thought the mid-end, frankly, mid-distal LED, nothing was filling. So we thought it could be also creating trouble. We'll try in the end, we thought. That's why we did it in the end. But that is also not proximal LED again. Big diagonal came, distally, that's okay. Proximal RCA, out of all the vessels, whichever is most proximal vessel, I thought RCA is the most proximal. And I had a doubt whether these inferior lateral changes happening, whether it could be because of a large PTA or because of LCX. Sometimes, though theoretically we may say L3 vessel more, that, this, all that, but still the proximal tight lesion, I thought of tackling RCA first, and it also had a mid RCA disease that also had to be tackled. That's why we did RCS, and we the things which you can finish faster, the critical lesion, that's another thought process. We did it. But then later on, we did LCX again because of infiltrator lesions. Then finally, we came to diagonal. And then lastly, even if the LAD was not opening, we were willing to leave it, frankly, because everything was tackled. Then patient, we were not sure what kind of LAD would come out. But patient operator, everybody is fortunate. So we got a good quality LAD later also. And LAD also feeling normal. So we did as good revascularization as a surgeon. I always keep thinking about it. Do total revascularization if possible. And just don't, and another important thing is don't chase very small branches also. You end up in trouble. Small 1.5 vessel dilatations also, if it dissects, patient starts getting angina, the other important things which you have done also may be lost. So don't do unnecessary things also. Right? Any other doubts? Anything apart from it? I hope you all like today's lectures. Tomorrow we'll again assemble back to discuss a little more on the STEMI interventions, which are again very useful. All of you get involved in it. And then newer things coming up like TAVI is now again a lot of importance. So we'll touch upon that and end up with newer interventions. And renal denervation is another new procedure which is coming up, which all of you should become comfortable. I keep telling my fellows and juniors also, each of you should develop some niche technique nowadays because becoming more and more competitive and there is less requirement. And you see, strokes are so common, acute stroke interventions. I always have a passion to develop and I keep pushing juniors to develop interest in it because there's very few people who can handle. Now ACC, and European Society both recommended the cardiologists can tackle and qualify to do. No worry of legal problems and things like that. Work with your radiology colleague and neurology colleague who is interested. And that's why I specifically included 2 of the sessions on neurointerventions, also acute stroke interventions. In Apollo, in our hospital nowadays, acute stroke gets a top priority and gets into protocols faster than primary PCA. But I would say that acute stroke is like how primary PCA was 10 years back. It is evolving, and wherever I always argued with 7 or 8 years back in TCT, I had a stroke intervention workshop. So I always argued with neurologists, it's not a white matter disease, it's occlusion of vessels, which is producing trouble. So vascular therapy will help. Though initially said the brain is different and all that, but now it is proven that initially 3 hours, then 4.5 hours. Now you are getting data with the longer procedural techniques also. So I requested 2 of our colleagues, one to cover where to give lighting therapy, other to have how to proceed for intervention. Those things will be also covered up. I thought youngsters, you should give some thought-provoking interest in that also. Those are the topics for tomorrow. And if you have no other things, then we will break. Any final words you want to say? Rishi? Want to say? Thank you.
Thank you so much, sir. Please give a loud round of applause. Before we go for dinner, I would request Mr. Sandeep Sharma to please felicitate our both the faculties, starting first with Dr. Anil Sharma. I would request Dr. Sharma to please be on stage for just a moment. Next, I would invite Dr. Sandeep Mishra, sir. Mr. Yeah. Yeah. So with this, now we end today's day and we break for dinner. Just a small announcement. Tomorrow we have an interesting session. The first session would be an international speaker, Dr. Sushil Kodali. So I would request all of the delegates to please be in the hall before 9 so that